بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. On behalf of the Saudi Society of Blood and Marrow Transplantation, I would like to welcome you all, our 1,500 registrants, to the 16 ICML highlights and the Hematopathology Overview 2021. As you are all aware, these two meetings, the ICML 16 highlights, being held every 2 years, following the ICML meetings of Lugano, and the Hematopathology Overview, which is held the following day. So over the next 2 days, we will have these two meetings. So welcome again. And to start with, I would like to thank actually many people. However, Professor Cavalli, who is, Franco Cavalli, who is the president of the ICML, and the ICML team and organizing committee, Francisco Bertoni and David Rossi, who will be joining us this afternoon. Thank you all again for your support and for having such a collaboration with the ICML. And special thanks to Christiana Brenton and from the ICML, and Irma Kaya from the SSBMT for working hard to put this program and meeting together. Special thanks again to our scientific committees members. For the ICML highlight, Dr. Mubarak Al-Mansour, as a chair of the scientific committee, and for the hematopathology overview, Dr. Ammar Al-Sghayr, again for putting the program together. We will see a great program, great speakers. Thank you all for participating. With that, again, as you're aware, the Saudi Society of Blood and Marrow Transplantation has been holding these meetings over the past 10 years, and we celebrated the 10th anniversary of the SSBMT in the last annual SSBMT meeting this year. We have held more than 80 conferences, physical conferences, and more than 48 webinars during the last 10 years. And I'm glad to see again this meeting coming up as a hybrid meeting after the pandemic, COVID-19 pandemic regression. So we are opening up and hopefully again to have a physical meeting very soon and to have all the participants and on-site networking and discussing issues. I would like to draw your attention to the SSBMT Hematology Research Award, which is again opening and welcoming submissions to this award, which is held on an annual basis. And I would like to draw your attention to some of the achievements beside the conferences and the meetings that's being held by the society. We also try to enhance research agenda, and recently we're glad to have publication as a Saudi consensus on the management approach of AML, as well as the Saudi Lymphoma Group clinical practice guidelines on the management of lymphoma. So these are Saudi consensus guidelines, and I wanted to bring it to your attention on behalf of the Saudi Society of Blood and Marrow Transplantation. So without further ado, I would like to invite the chairman of the scientific committee, Dr. Mubarak Al-Mansour, to give his opening remarks, followed by David Rossi from the ICML, again for the ICML remarks. Thank you again, and welcome to this meeting.
بسم الله الرحمن الرحيم. الصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. Thank you, Professor Ahmed Al-Askar, President of the SSBMT, for the kind introduction. And I would like also to thank Professor Branko Cavalli and Professor Ahmed, because the credit goes to both of them for having this continuous education and the collaboration between the Saudi Lymphoma Group, SSBMT, as well as the ICML over the last few years. I would like also to welcome all the participants who are physically attending the conference, or those who are virtually joining from other countries. I would like to thank all the speakers from the ICML and our speakers from the Saudi Lymphoma Group, and all the moderators for their participation today. Dr. Prof. Al-Askar already thanked all the people and the organizing committee who did a great job, honestly, to keep this highlight going. And today we have a very heavy program, as you can see, as the last ICML was, most of the people were not able to attend physically, especially outside Switzerland. So we worked on this program, and hopefully we'll be able at the end of this program to maybe cover most of the clinical data that was presented into the last ICML. I would just go briefly over the program. As you can see, we have 4 sessions, and within each module, we have 2 ways of presentation. The first one is going through the highlight within a site, and the 4 sessions are within a Hodgkin lymphoma, CLL, indolent, and aggressive. And within each module, we have a presentation highlighting into the latest update, as well as a few abstracts were selected to stress into the importance of those abstracts that might have impacted our practice. I would also encourage all the speakers, moderators to stick to the time. As you can see, we have a 7 hours program that we need to cover almost most of the aspects. A few housekeeping issues before I introduce the next speaker is, please, if you are not a speaker or moderator, just mute yourself and also close your cameras. And for the moderators and the speakers, as mentioned, to stick to the time. We have 5 minutes after each lecture, and we for the abstracts, we will be presenting 2 abstracts, and then 5 minutes for questions. Without any further ado, I would like to introduce Professor David Rossi, who is the Deputy the Division of the Hematology and Oncology Institute of the Southern Switzerland, and the head of the laboratory experimental hematology at the oncology also in Bellinzona, Switzerland, to give his remarks. And then directly we will proceed to our moderators for the first session, and wish you all a very enjoyable program. Prof. Rossi, the mic is yours.
Good afternoon, and thank you very much, Professor Al-Mansour, for the kind introduction. I'm glad to bring to you the greetings and the gratitude of Professor Cavalli, the president of ICML, and of the members of the ICML organizing committee for allowing to hosting your SSBMT meeting, the ICML highlights. Thank also to all the participants who are attending in person or virtually to this conference. And also let me thank, of course, the Saudi Society of Blood and Marrow Transplantation for having organized the event, and for all the speakers for giving their contribution to this meeting. Without further delay, I think we can move to the program of the meeting. Thank you very much again.
Thank you, Dr. Rossi. I guess we can start with the first session. I'd like to thank Dr. Al-Askar and Dr. Mubarak for this, for the organization of this very fruitful annual meeting. My name is Riyad Dada from Jeddah, and we will be having in the first session 3 talks. Each talk will be 25 minutes, followed by 5 minutes of discussion. So, and I'm glad to introduce my co-chairman, Dr. Mit'ab Al-Uthaymili, Consultant Adult Hematology, Director of Hematology and Oncology Department of Al-Hada Armed Force Hospital, who will start introducing the first speaker. Dr. Mit'ab.
Thank you, Prof. Riyad. My honor to introduce the first speaker, Dr. David Rossi. As Dr. Mansour mentioned, he is Deputy Head of Division of Hematology at Oncology Institute of Switzerland. Also, he is Head of Laboratory Experimental Hematology at the Institute of Oncology Research in Bellinzona, Switzerland. Dr. David, he is author of more than 267 publications. Dr. David researched mainly on the molecular pathogenesis and diagnosis of B-cell tumor and translation of biological information into marker for disease diagnosis and prognosis. Dr. David today will have a talk about chronic lymphocytic leukemia for the next 25 minutes. After that, we'll have 5 minutes for the short question and discussion. Dr. David, please, if you can start.
Thank you very much, Professor Al-Tumadi and Professor Dada. Okay, these are my disclosures. Meanwhile, while you go through them, I would like to thank you again for giving us, as ICML organizing committee and speakers to show you the highlights in each of the field that was covered during the conference. And my task here is to give you a flavor of what is going on in chronic lymphocytic leukemia treatment, and in particular what has been shown as a novelty during the last ICML meeting. Let me start with a short background. Ibrutinib, the first generation covalent binding BTK inhibitor, I would say, set the thresholds against which new treatment development have to be compared. The RESONATE 2 trial, which was updated at the last ICML meeting, has shown that in previously untreated CLL patients who are physically unfit because of the age of comorbidities, but lacking p53 abnormalities, ibrutinib monotherapy produces long-term, I would say, good remissions. And at 7 years, the median progression-free survival is not reached in this population, and the PFS is projected at approximately 60% at this time point. There are also data coming from the narrow group of patients who were not included in the RESONATE-2 trial because having p53 abnormalities, data that have been published by the NCI group in coming from a cohort of previously untreated CLL with 17p deletion who were treated with ibrutinib monotherapy. Also here the follow-up was pretty long as observation, and the 7-year progression-free survival also in this high-risk setting with ibrutinib monotherapy is comparatively superior to whatever we have seen with chemoimmunotherapy, again approximately 50 to 60%. Ibrutinib monotherapy comes with some adverse events that tend to stay over time, as you can see here in the plot of the incidence of adverse events during different treatment periods. Some of them are well known and for the reason are claimed as of clinical interest, in particular cardiovascular events, including hypertension, atrial fibrillation, and major bleedings, again tends to stay and do not decline over time during treatment as incidence. And there are also other non-life-threatening but clinically disturbing side effects like diarrhea, fatigue, arthralgias, muscle spasms, which again occur in a proportion of patients and again tend to stay over time and do not decline along with the treatment continuation. Therefore, from one side, adverse events, and from the other side, CLL progression, which actually occur in a proportion of patients despite treated with ibrutinib, are the two major causes of discontinuation of the drug. So there are some unmet needs, therefore, rising in the ibrutinib era. And as I said before, the first is toxicity with atrial fibrillation, infection, and major bleeding being the most worrisome, but there are also others like minor bleeding causing blue skin, diarrhea, rash, arthralgia, fatigue, which impair the quality of life of patients, leading to progressive dose reduction and eventual discontinuation of the drug. Which is the solution to intolerance? The technological innovation here is the development of the second generation covalent binding BTK inhibitors, which compared to ibrutinib, and as you can see here in the kinome plots, have a narrowed specificity against the Bruton tyrosine kinase, while ibrutinib inhibits also other kinases, as mentioned here, which are supposed, this inhibition is supposed to be the cause of some of the off-target adverse events produced by the drug. And in order to prove that the better specificity produce less side effects without compromising the activity of therapy, two randomized clinical trials have been designed and conducted, and the results presented this year. The first is the ELEVATE-RR trial, which is a randomized study comparing acalabrutinib 100 milligrams BID versus ibrutinib 420 milligrams QD as continuous therapies until disease progression or intolerance. And the trial targeted a high-risk population of CLL patients who were in treatment need, had relapsed CLL, so previously treated CLL, harboring some high-risk genetic features like 17p deletion. The primary endpoint was the non-inferiority in terms of progression-free survival, evaluated by an independent review committee. And here you can see listed the secondary endpoints, including, of course, safety signals. The patient population has the features that you would expect in a relapsed setting with a median age of 65 years approximately. Nearly half of the patients having 17p deletion, 40% of the patients having p53 mutations, nearly half of the patients having complex karyotype, and almost all patients having unmutated immunoglobulin genes. The median number of prior therapies was 2, so pretty advanced patients, I would say. The primary endpoint was met. Acalabrutinib is not inferior compared to ibrutinib in the progression-free, in producing progression-free survival in this patient population. And also the outlook of the PFS curve is what you would expect in a relapse setting of CLL harboring high-risk features with a median progression-free survival of a bit more of 3 years, as already reported in the initial phase 1 and 2 trial in this high-risk group subpopulation. But here comes, acalabrutinib is equally effective as ibrutinib, but here comes the novelty. It's better tolerated. Here you see the cumulative incidence of atrial fibrillation and flutter for acalabrutinib and ibrutinib, and the cumulative incidence is lower for acalabrutinib with a 50% reduction in the risk. Hypertension either, the incidence is lower with acalabrutinib with a 70% reduction of the risk, but also those minor but disturbing adverse events like bleeding, diarrhea, and arthralgia were less common with acalabrutinib than with ibrutinib, with a reduction of their risk of 40% roughly. The second trial is the Alpine trial. The Alpine trial tested randomized patients in receiving zanubrutinib, the second generation covalent binding BTK inhibitors, at the 160 milligram BID dose versus ibrutinib at the 420 milligrams QD dose until disease progression or intolerance. The target population again was composed by relapsed refractory CLL who received at least one prior therapy, without any constraint in the inclusion criteria with respect of the biological risk features. And indeed, compared to the ELEVATE-RR trial, despite similar median age and stage of the disease, the number of prior lines of therapy is lower here in the Alpine 1 versus 2, and also the incidence of high-risk molecular features like 17p deletion and p53 mutation is lower. And this is important if you like to contrast a trial with the other. The primary endpoint of the trial is not usual, but because it's overall response rate, and the endpoint was superiority, and this was met because the overall response rate was 78% versus 62% in favor of zanubrutinib, which was also maintained superiority also in the subgroup of patients with high-risk features because harboring 17p deletion. Surprisingly, although I have to say that we have to be cautious because of the follow-up, in the median follow-up in the ELEVATE-RR trial was 3 years. Here, the median follow-up at the time of data cutoff is around 12 months, and therefore I think we need more observation to claim firmly this, but it seems to, zanubrutinib seems to have also a superiority in terms of progression-free survival. For sure, it is not inferior. So more or less similar efficacy, maybe even a bit better efficacy, we will see compared to ibrutinib, but also as for acalabrutinib, better safety with zanubrutinib because of lower incidence of diarrhea, of arthralgias, of muscle spasms, and in the events of clinical interest, a very low incidence of atrial fibrillation. So again, zanubrutinib, like acalabrutinib and more in general, the field of second-generation BTK inhibitors, while preserving the efficacy with respect to ibrutinib, comes with a better safety profile. The second problem with ibrutinib treatment is the development of resistance, which causes discontinuation in different proportion of patients according to whether it is used in first line or in the relapse refractory setting. The resistance to ibrutinib is mainly driven by the development of a mutation in the position of 481 of the amino acid of the protein of BTK, which is the position where ibrutinib covalently binds to inhibit the target. And this mutation displaces ibrutinib from the target, producing, as I said, resistance. And the technical solution here was the development of non-covalent binding BTK inhibitors. So BTK inhibitors that does not need to attach to the BTK protein by binding the cysteine at position 481. And here I will show you the data of pirtobrutinib. Pirtobrutinib in preclinical models is effective in cell lines engineered to harbor the mutation of resistance to BTK, as you can see here in terms of tumor control, and in a similar way as it is when the BTK is wild type. But beside the activity against the ibrutinib resistant cell lines, it is also in the kinome analysis very specific for BTK, thus likely allowing preserving a good safety profile. Pirtobrutinib was tested to find the dose and define the safety profile and get some initial efficacy signal in the BRUIN trial, which enrolled several kinds of mature B-cell tumors, including 170 CLL small lymphocytic lymphoma patients. These are the characteristics of the CLL SLL patients enrolled in the BRUIN trial. Median age of 69 years, a median number of prior therapies of 3, so pretty advanced CLL, I would say. Almost all patients were previously treated with a covalent binding BTK inhibitors, as well as with chemo and anti-CD20, and a significant proportion also received BCL2 inhibitor venetoclax. 77% of patients discontinued BTK inhibitor because of resistance, while 33% because of toxicity. And nearly 1/3 of patients had the BTK6 mutation in position 481. Despite these characteristics of resistance, the response rate was pretty high, with an overall response rate of 63% in the population, and the response rate tends to increase over time as we have learned to see in patients treated with BTK inhibitors, where the quality of remission improves over time with therapy. And the activity signals were there for all subgroups, including those previously exposed to BTK inhibitors or BCL2 inhibitors or different combination of therapies, and also in those patients who progressed under ibrutinib or a previous other covalent binding BTK inhibitor, including in patients having the mutation of resistance to covalent binding BTK inhibitors. The safety also was pretty encouraging. I would like to highlight these points, which are of clinical interest in this field of BTK inhibitors. A low rate of hypertension. The follow-up is short, however, to have a firm conclusion, and also a low rate of atrial fibrillation. Another problem that we are all facing with ibrutinib therapy is that, especially in the first-line setting, being a continuous treatment, it is lasting many years. As I mentioned before, in the RESONATE-2 trial, the median progression-free survival, so the median duration of of therapy has not been reached after 7 years of follow-up. So the question here, which is a value for patients, is how transforming a continuous therapy into a time-limited treatment. And here we have the results of the GLOW trial. The GLOW trial randomized patients to receiving ibrutinib in combination with venetoclax for a time-limited period of 15 months, so 1 year and 3 months, versus chlorambucil plus obinutuzumab with the typical schedule that we all know. And the trial targeted previously untreated CLL with features defining unfit the patient like the age or the comorbidity rate. The patient population in the trial had a median age of 71 years, an elevated CS scores in many patients, some degree of renal insufficiency, and most of the patients have a mutated immunoglobulin genes. And the trial was positive as the primary endpoint, progression-free survival by independent review committee, was superior with ibrutinib plus venetoclax compared to chlorambucil plus obinutuzumab after a median follow-up of roughly 2 years, with a 78% reduction in the risk of progression favoring ibrutinib plus venetoclax, and a median progression-free survival which was not reached for the ibrutinib plus venetoclax arm compared to 21 months, more or less what you would expect with chlorambucil plus obinutuzumab. The quality of remission is also supported, the best quality of remission is supported by the analysis of the minimal residual disease by next generation sequencing, which you know is very sensitive, even more sensitive than flow cytometry. And in the bone marrow, at the end of therapy, half of the patients treated with Ven plus ibrutinib achieved an unmeasurable minimal residual disease compared to only 17% of patients treated with chlorambucil plus obinutuzumab. The treatment, the combination comes with some safety signals, including those ones that we are used to when considering BTK inhibition, like hypertension, atrial fibrillation, some more diarrhea, which is a common side effect of both ibrutinib and venetoclax, although the rate of infection seems to be similar with and low and comparable with the chlorambucil plus obinutuzumab. So to conclude, what might change in the future in our clinical practice? First, second generation BTK inhibitors may be considered for all the patients requiring a continuous therapy because of the patient value or the high risk biology. You may also want, because they have a similar activity and better safety profile. We may also want to keep ibrutinib in our treatment armamentarium, and in this case, you may want to consider the second generation BTK inhibitors only for patients who may have an increased risk of serious adverse events with ibrutinib therapy, like those having cardiac risk factors. Or you can use ibrutinib in first line and immediately switch to a second generation BTK inhibitors, and the sequencing has been proven to be safe in a trial that I didn't mention here. With respect to the third generation BTK inhibitors, where the space where they could find a value now while awaiting new trials that are anticipating their use in the course of the disease, is now for patients who have a resistance to ibrutinib, especially or acalabrutinib, especially if it is driven by the resistant mutation. But in this setting, I would like to remind you that we have also venetoclax monotherapy or venetoclax plus rituximab, which are very good alternatives. And for sure, pirtobrutinib is the treatment of choice for double refractory patients, so patients that progressed after both ibrutinib and venetoclax therapy. For the Ven plus I combination, this should be considered for all patients who have a value in a time-limited treatment, although as for all time-limited therapies with these novel agents, we have to see whether they are appropriate also for very high risk patients with p53 abnormalities or complex karyotype. And with that, I have concluded, and thank you very much for your attention. And I would invite you to save the date of the next ICML meeting in 2023. Thank you very much.
Thank you, Dr. David. Was excellent review and comprehensive overview of the last BTK inhibitor in treatment of CLL. Just for a reminder for our audience to type their question in the Q&A section. Meanwhile, Dr. David, any way to adjust the ibrutinib dose based on the toxicity without affecting the efficacy?
Yeah, this is a very important practical aspect that you are raising. And indeed, there are pharmacokinetic studies showing that after a lead-in phase of a certain number of months, when the disease has been nicely debulked by ibrutinib, the pharmacokinetics and dynamics of ibrutinib doesn't change irrespective of whether you continue as the standard dose, 420, or you reduce the dose. And therefore, my attitude is to reduce the dose of ibrutinib when the patient is in a good remission, even if there are minor but disturbing side effects. I would not await that the burden of the side effects becomes too high to induce the permanent discontinuation of the drugs. And in this way, you can mitigate the risk of discontinuing the drug.
Excellent. Thank you, Dr. David. We have a question from Dr. Majid Al-Ahmadi. Can we use MRD negativity as a guide for discontinuation of single agent therapy with the BTK inhibitor?
Well, this is another very good point. The hope when targeting the B-cell receptor signaling was to produce deep remission. However, we have learned that complete remission are rare, and especially remission with negative minimal residual disease is virtually absent, even if in patients who have been treated for a long time with BTK inhibitors. And this means that MRD is not prognostic, neither predictive, because it's irrelevant for BTK inhibition. But it also means that BTK inhibition has to be used continuously to get the maximum benefit from the treatment. In the first line setting, there are some data suggesting that, so not in advanced or high risk disease, there are some data suggesting that when coming from the ECOG trial where treatment with ibrutinib was interrupted because of side effects, some patients stayed in the remission achieved with ibrutinib before stopping for side effects for up to 12 months. So it's not true that every patient that stopped ibrutinib immediately progress. This is more common in advanced phase of the disease, is less common in early phase of the early time of the disease course. For example, in low risk patients genetically with previously untreated CLL. I'm not saying that you have to discontinue, but there is also this opportunity. If you have side effects, you can reduce, eventually hold the drug, and if the patient stays in remission, you can await before introducing a second novel agent until the clinical progression. Okay,
excellent. Thank you, Dr. Dev, for this informative talk. Because issue of time, I'll move to the second speaker, will be
Thank you very much.
By my co-chair, Prof. Riyad. Thank you, Dr. Dev.
Thank you, Dr. Mehtab, and thank you, Dr. Rossi. And I wish that the admin is allowing me to open the camera. I cannot open the camera. Anyway, so it's my pleasure to introduce the next speaker, who is well known Professor Anastasios Stathis, who is the head of New Drugs Development Unit and chair of clinical research at Oncology Institute of Southern Switzerland, EOC. And he was also the chair of the same unit for medical oncology in Bellinzona in Switzerland. He published many publications on the field of lymphoma, especially phase 1 trials. And his talk will be also about new therapeutics in non-Hodgkin lymphoma. So, Prof. Anastasios, please.
Hello to everyone. And thank you very much for your for the invitation. Sorry, I'm just trying to connect with and share my screen. Let me see. Can you see my screen now?
Yes, we can see the screen. If you go to the presentation mode, please.
It should be on the presentation mode. I'm sorry for that. Just give me a second.
That's fine now.
It's okay?
Yes.
Yeah, okay. Thank you very much again. It's a pleasure to be here on behalf of my colleagues from Bellinzona and the ICML organizing committee. I will be presenting a part on the new drugs, and in particular two new drugs that were presented at the last ICML meeting. So I will be discussing on first the human trial of valemetostat tosylate, and then on some updated results of glofitamab. Now these are two completely different drugs. One is a small molecular targeted agent. The other one is a bispecific antibody with a very interesting format 2-to-1 in order to target the antigen on lymphoma cells. And I think they both have very interesting data, and they also are examples of how drug development in lymphoma is proceeding in these last years. As a matter of introduction, before going to this study, I wanted to share with you this table which reports some of the new drugs that have been recently approved for patients with non-Hodgkin lymphoma. These are approvals, I believe, based mainly on FDA approval, but there are some other countries also that have had access to these compounds. Now, what I would like to point here is that if you look at the newer compounds that have entered in later clinical developments, there are compounds that target some old or more or less old targets. So PI3K, BTK are around now since several years, but there are second and third generation inhibitors, and this is being pursued. Why? Because there is the hope to improve efficacy or some of the toxicities. The other thing that I believe is interesting, and this is happening over the really recent years, the last years, is that while the first, let's say, the previous new drugs were mainly developed for chronic lymphocytic leukemia, where they had actually the main success, and then on indolent lymphoma. But now there is also something that is moving in diffuse large B-cell lymphoma. And here you can see some examples, but there are others. And of course, glofitamab that I will be discussing from the ICML, it is a drug that is having activity in diffuse large B-cell lymphoma. But you can see here there is an antibody-drug conjugate, polatuzumab vedotin. There is a targeted small molecule, and then an antibody, and a new antibody, anti-CD19, which I will be discussing later in the second part of a presentation on aggressive lymphoma that also was presented in ICML. But as I said, this is just to give you an idea of how it has been part of the drug development. So here you miss, of course, the CAR-Ts. So I did not present on that. Of course, this is another big area of current drug development in lymphoma, which is very, very interesting. In the previous table, there was not mentioned, because this was approved a little bit later in comparison to the previous drug on tazemetostat. So tazemetostat, it is an inhibitor, an oral inhibitor of the EDH2, a methyl transferase of histone, and it has shown significant activity in patients with follicular lymphoma, both in patients with wild type ZH2, but mainly in patients with mutated enzyme. So the response rates go from 30% in the wild type to 70% in the mutated. Another drug that also we saw some results from a phase 2 study and has been FDA approved very recently is another targeted antibody drug conjugate, which is loncastuximab tesirine, and this is an anti-CD19. So after polatuzumab vedotin, there is another antibody drug conjugate in diffuse large B-cell lymphoma with a response rate of around 50%. And again, these are response rates that perhaps 5 years ago we were not very familiar with in patients with relapsed refractory lymphoma. Again, as I mentioned, CAR-T cells probably have set the bar a little bit even higher in terms of response rates and in terms of complete response rates, but still we see that now there is compounds that are active in patients with relapsed refractory DLBCL. And finally, of course, we have bispecific antibodies, and these are what we know now, that there is activity and high CR rate in DLBCL, and now we'll be discussing on the glofitamab results of ICML. Before glofitamab, this is the trial that was presented by Dr. Izizuka. It's a first-in-human study, and this is in comparison to tazemetostat, is a dual inhibitor, so it inhibits both EZH1 and 2 enzymes. So as I previously mentioned, these are both epigenetic regulators. They are involved in the methylation of histone, and they are connected with epigenetic silencing of genes, and they have several there are several ways to which they are involved in the genesis of lymphomas when they are hyperactivated. Now, this is a field that is the epigenetics is not a very simple pathway. So there are several players that are involved, and perhaps they are not very well understood. So this, to some extent, explains also some difference that can be seen in responses and perhaps also in adverse events with this class of compounds. Now, as I mentioned, valemetostat, it is a dual inhibitor. So this is an important point because it makes it different with regards to, let's say, the first-in-class tazemetostat. And it has shown significant activity through different lymphoma subtypes in preclinical models. So the investigators brought this compound into clinics, and this is what we saw in Lugano. So this is the study design. a phase 1 trial with an escalation on doses. The drug is being given once daily. They started from 150, they went up to 300. The dose was selected at 200 milligrams per day. So this is an oral continuous medication, similar to the other oral drugs that are being developed or used clinically for lymphoma. And here at Lugano, the investigators presented the results mainly from the expansion cohort in T-cell lymphomas at the 200 milligram, because this is the dose that is being further developed. So they included a number of patients in the safety analysis of around 77 patients, and there is data of efficacy in around 60 patients, which include 44 peripheral T-cell lymphoma and 14 adult T leukemia. Now, this is the patient's disposition through the different dose levels, and in particular on the recommended phase 2 dose. So you can see that there were 60 patients treated at this dose. We have 77 patients in total available for safety. There are, of course, small numbers. This is still, it's a phase 1 study, and there is some reports now on the efficacy of 44 patients in PTCL and 14 patients in ATL. Now, these are the responses. So if we look at the PTCL, peripheral T-cell lymphoma, there is a response rate of 50%. And ATL 57%. So there is an important response rate. This is all patients previously failing other treatments. So these are difficult to treat lymphoma. I think, of course, it's a small number of patients, but there is activity of the compound in these patients. And here you can see a waterfall plot that, again, I think it's a very nice to see, because it's not something that we see very often. It is something that we were used to see with idelalisib. Perhaps it was one of the first types of waterfall plot to see in follicular lymphoma. So most of the patients have tumor reductions, and there is around 40–50% of response rates. So this is important for a disease like PTCL with a small agent. This is what it has been reported in terms of adverse events. What I would like to point out in the total number of patients, I don't think it makes a lot of difference to see on the different histologies. There is no really a reason why adverse events would be different. Now, what I would like to show you mainly is a grade 3 adverse, more than grade 3 and above of thrombocytopenia in around 17% of patients, and this is higher than the tazemetostat grade 3 thrombocytopenia. So if we look at some severe adverse events, they are mainly hematologic, and they seem, I say seem because small number of patients, they seem to be a little bit higher in comparison to tazemetostat. It could be because this is an inhibitor, a dual inhibitor. Now, in conclusion, there is encouraging efficacy. I think in a small study with 40–70 patients, we can say encouraging efficacy, encouraging activity in patients with relapsed refractory peripheral T-cell lymphoma or ATL. The safety profile, it is acceptable. I must remember in this case that with targeted agents, we must be careful, however, with the results of these small studies, because usually they don't have long follow-up. So I think it is important to also see how the other studies will be, and there is already ongoing trials with this certainly very interesting compound. Now I will move on the glofitamab step-up dosing, and in Lugano we had the chance to have a great presentation by Dr. Carmelo Carlos Stella and see updated efficacy data of this compound in patients with non-Hodgkin lymphoma. They included aggressive and indolent lymphoma. So this bispecific antibody is very interesting because there is the whole portion of a monoclonal antibody. So if we remember on the first bites, like blinatumomab, there were only small portions of antibody, and they had the main problem of having a very short half-life, so you had to give them as a continuous infusion. So now this new bispecific, they are whole antibodies, and they come with this very easy way to give them in a let's say standard IV infusion without the need for a continuous infusion, without the need of pumps. Now, here, what we see is this interesting approach with the step-up dosing. So you give 3 weekly doses up to reaching the your target dose. And the other interesting thing here is that due to the fact that one of the main adverse events of these compounds is cytokine release syndrome, in order to try to mitigate that, one thing is to use this step-up dosing approach. The other is to give an antibody, and they gave obinutuzumab here in advance. So day -7, they gave obinutuzumab, and then they started with the starting dose of glofitamab. They increased the dose from 2.5 to 10, and then the target dose from 16 or 30. In this slide here, you can see this 2-to-1 format. So there is 2 parts that block the CD20, which is the target, and then the target on the malignant cell, and then the CD3 to bring in the effector T cell. So this preclinically has resulted in much better binding in comparison to the 1-to-1, let's say, to the more classic bispecific antibodies. Of course, to say that this clinically also is better, we probably need to wait to compare the different results, but I think it's a very interesting approach. And here is the study design. So as mentioned previously, they started with obinutuzumab to do this kind of, let's say, debulking at 1,000, the standard dose, 1 infusion, and then the different glofitamab. They were able to go up to 30. Now, the patients were patients with lymphoma expected to present CD20, and they were previously treated patients. And here we can see there is 52 patients, again, small number of patients, 52 patients. And of course, these are patients previously treated with a median number of lines of 3. And the patients had, half of the patients were treated with, of course, CD20 and chemotherapy, and then there were 11% of patients with, so actually 20% with auto transplant. And I think it's interesting to see what was the rate of patients that had prior CAR T, and is 6%. So it's not as a high number of patients. There were 3 in these 52 patients that had previously received CAR Ts. Now, among these patients, and based on the different target dose, 16 patients received the lower dose, 16, and 34 received the higher dose, because the investigators wanted to bring the target dose at a higher level, because they think that this can result in improved efficacy. Now, this is what happened with the study. I think that there is no doubt that there is very high response rate, a complete metabolic response rate of, if we put together the patients, it's around 70%. So it's very high response rate. You can see here 70% in the patients that were treated with a higher dose, and 40% in those that received the lower target dose. So it seems that this is true, so that you should try to bring your bispecific antibody, the third dose, to, if possible, a higher dose. There is a median, some follow-up here, median duration of response, with a median follow-up 8.4 and 5.8 for the aggressive and indolent part. And those patients that achieve a complete remission are the patients that tend to have the more long-lasting responses. I think this is not specific to this compound, but it's something that we should think also when we use this compound. This is safety. As I mentioned, and that as it was already known, cytokine release syndrome, it is a mark of this class of compounds. But what it is interesting to say is that most of them are grade 1 and 2. So that's very important. And I think it will be also important to still improve this aspect. But I think the fact that most of them are mild to moderate, it's an important achievement. This is the slide on the CRS, where exactly you can see that most of them were of mild to moderate adverse events. Now, in conclusion on this compound, I think that there is really high response rates, and the hope is that they could translate in durable responses for patients with aggressive or indolent lymphoma. And this kind of step-up dosing permits to reach to a higher dose, which apparently is associated with a better, a higher response rate. So my comments in these two very, very nice papers that we're presenting in Lugano, if we look at the valemetostat, there is a high response rate in PTCL. I would like to have such a compound for patients that progress on standard treatment. I don't think there is really a lot of drugs with this activity. But as I perhaps mentioned during the presentation of that compound, I think it is important to understand the adverse event profile, how many patients can stay on the drug without interruptions or dose reductions. And then I think it will be also important to understand what is the possibility that this type of compounds could be integrated in the first line of treatments. And then again, we know about tamezetostat, the difference in activity in wild type versus mutated. So this is also something that we'll need to better define with these compounds. On glofitamab, my comments that there is a high response rates in difficult to treat aggressive non-Hodgkin lymphoma. The duration of response seems to be sustained, and especially in patients with complete remission. On the other hand, here they gave up to a fixed number duration of infusion, so it will be interesting to see what happens when you stop the treatment. And I think the other question here with bispecific antibodies, as data come from phase 1, phase 2 studies, is how we can clinically how we can integrate this treatment to the other available ones. So the data after CAR T is not too many. There is some data, so we need to understand what is the best approach. So in conclusion, in the last years, there has been an explosion of new therapeutics for lymphoma. And we have several small molecules, monoclonal antibodies, including also bispecifics. And there is a lot of activity that we see with these phase 2 trials, also in patients, mainly patients with relapsed refractory lymphoma. So I think now a burning question is how is possible, and if it will be possible, to integrate this or some of these compounds in the first lines of therapy. The other point is, of course, the costs. These are very expensive drugs, And on one hand, it's very nice to share them and be able to provide our relapse refractory patients with responses. But I think also it's important to understand at some point how possible it would be to sustain this course. And finally, of course, we still need to better define possibilities of selecting patients that could benefit more from these new treatments. And with this, hoping that I was not very long, I want to thank you very much for your attention, and thank you again very much for the invitation. And I'm happy to get any questions.
Thank you, Professor Stasis. Really very nice presentation, what the future will bring to us soon, hopefully. So I don't see any question. Maybe I have question. Can you remind us again on the duration of response for patients who were treated with valemetostat, PTCL?
I have to check. I don't remember it right now. I would I would try to guess around 3 months, 2 to 3 months. But no, I have to check. I'm not sure. I have to check.
No problem. So and you presented the data with glofitamab, which is really very interesting. Overall response rate in diffuse large B-cell of 78%, and in follicular lymphoma 100%. So and you touch on that, whether these kind of treatment will be given until disease progression or for limited number of cycles. What's your thoughts? What's the most benefit would be? Is a limited number of cycles, or to be given until disease progression, which is seems to be in the last decade?
Yeah, I think it's really difficult to answer to this question. And perhaps it's the same question that we are facing also with checkpoint inhibitors. So you have a patient
exactly
in complete remission, and well, you don't know whether to continue or to stop treatment. I think that at some point we need to stop treatment. I hope that we might be able to get some data on that will help us on defining when to stop treatment. Could this be circulating tumor DNA? I think that would be a very nice story, perhaps in the future, to tell us there is no any kind of disease you can stop now after 1 year or 2 years. So we need to have a little bit more follow-up with these studies. I think now that the idea is that at some point with this immunotherapy approach, some patients may be cured. And I think also with PD-1, PD-L1 inhibitors studies now, after 2 years, they stop. And then patients are followed up. And I think in this study, there was also a fixed duration. So I think it's also more friendly to the patient.
Yes, exactly. I agree with you. I mean, fixed duration is also healthy for our economic healthcare system. So question, I mean, I don't see any question here, unfortunately, because maybe the topic is difficult and new drugs. So with regard to glofitamab, so you mentioned the tumor lysis is an issue, but mostly they are grade 1 and 2. So I'm asking whether the first application and subsequent application, maybe because we don't have experience at all with this drug, shall be under inpatient condition or outpatient?
I think it's a good idea to try to debulk the patient. This was done also with the use of anti-CD20. And again, I think it's a good idea to consider at the beginning doing that as an inpatient. I believe these clinical trials also have a part of this dosing, at least the dose increases as in patients for 24, 48 hours. So I think there is not any wrong, actually. This was what I would think to do in the first steps to have the patient as an inpatient.
This is excellent. And subsequent cycles, because I'm now in the negotiation with a company to bring it for my refractory patients, the subsequent cycles will be outpatients.
Yes, yes. I believe that once you are beyond the third infusion and you don't see any adverse events, most of these adverse events are quite early onset. So once this is, let's say, under control, then I think you are fine to have your patient as an outpatient. And when you're at the stand and the stable dose, the target dose.
Excellent. Maybe one last question will benefit from your expertise. I mean, we have CART, we have autologous stem cell transplantation, we have allogenic stem cell transplantation, and we have the powerful efficacy of the new discovered bispecific antibody. So where do you think would be the place of bispecific antibody? Are they going to be ahead of stem cell transplantation, ahead of CART, or post-CART and post-autologous stem cell transplantation?
Yeah, so I think that's a good question, and I think it's still, this is a work under that is now ongoing, let's say. So we need to define that. So here in Switzerland at this moment, we do have compassionate access to some of these bispecific antibodies, and in that sense they come, I think they come right at the end. So when you really have used more or less everything. But I don't see anything wrong with trying to investigate their role in earlier stages of the disease of a patient. I believe also trials are being done on first line in some settings. So I think this is also an interesting approach. So this is not clear. We should look disease by disease. I don't think that is possible to give a reply that would cover all the different lymphomas. So we should look in its different subtype, aggressive, indolent, diffuse, follicular, and try to find the best place for these very interesting compounds. I don't think that is going to be only one place for the different lymphomas. But for sure there is place, we just need to define it better.
Thank you very much. You may stay with us a little bit. There are other questions, but I think so we now overdue for the next
Thank you.
talk, and maybe we can get other questions if there is any time. So Dr. Meteb.
Thank you, Prof. Riyad, and welcome again to our attendee for the last part of our first session of this meeting. Will be satellite symposium. Will be presented by Prof. Zanzani. Prof. Zanzani is well known for all the Saudi Hematology Society. He's Professor of Hematology, Institute of Hematology, University of Bologna. He's principal investigator of more than 180 clinical trials, including national and international multi-center studies. Also, he was the president of Italian Foundation of Lymphoma from 2013 to 2015, and now he is member of the board of the directors. He's associate editor of Annals of Oncology from 2014 to 2017, and act as a reviewer for many journals. He has authored over more than 580 peer-reviewed papers in many journals, such as New England Journal of Medicine, Blood Journal of Clinical Oncology, and Lancet Oncology. His current research interests including clinical trial methodology, prognostic factor in non-Hodgkin lymphoma and chronic lymphocytic leukemia, and new drug development and hairy cell leukemia. Prof. Zanzani, he will have a talk about optimizing outcome in cutaneous T-cell lymphoma, role of blood involvement and treatment option. Prof. Zanzani.
Thank you very much for the kind introduction, Dr. Tomali, and good afternoon to everybody. I want to thank also again my friends, Professor Dada, Sayello, and we start in the next 20 minutes. I will do an update concerning this issue, my conflict of interest. So, mogamulizumab. The story of mogamulizumab in the treatment of cutaneous T-cell lymphoma started with this phase 1, phase 2 study published on 2015 on blood by the group of Madeleine Dubich in MD Anderson. You can see here that they treated 38 patients, and at the end of the day, the overall response rate was close to 37%, with a very good activity in all the three different compartments. I mean, blood, skin, lymph node. This is a peculiar characteristic of this agent for the treatment in cutaneous T-cell lymphoma. I mean, so overall mycosis fungoides and Sézary syndrome. And at the same time, in terms of safety profile, you can see here in this table that grade 3 and 4 was close to 0. There was only one patient with a drug eruption with grade 3, the same grade 3 for 2 patients with nausea. And on the basis of this very interesting, promising, but preliminary data, started a phase 3 study. But first of all, you can see here that mogamulizumab is a humanized anti-CCR4 monoclonal antibody that markers for type 2 helper T cell and regulatory T cells, and involved in lymphocyte trafficking to skin, and is overexpressed in the majority of ATL, peripheral T cell lymphoma, and also cutaneous T cell lymphoma, with a higher ADCC due to a defocalizated FC region. So in particular, right now, this drug has a validation registration by Japanese FDA. I don't remember the name of the Japanese drug agency. Anyway, for ATL and also for peripheral T cell lymphoma. And with the Maverick study that I will present in a few seconds, there was also the official indication for cutaneous T cell lymphoma, not only FDA, but also EMA. So the mechanism of action is the target receptor, as I said before, is a CCR4, and after binding CCR4 in tumor cell, mogamulizumab induced ADCC. NK cells linked to FC region of MOGA on tumor cell, inducing the release of cytotoxic granules and the lysis of tumor cells. This is the study schema of Maverick, is the largest phase 3 randomized study conducted and published in the treatment of cutaneous T-cell lymphoma. I was involved in this trial. We included 372 patients, and the key inclusion criteria were adults with stage 1B, 4B patients, histological confirmed of mycosis fungoides or Sézary syndrome, at least one prior course of systemic treatment, and of course, a good performance status. The study was quite easy. Random was 1-to-1, comparing mogamulizumab, 186 patients included in this study arm, at the conventional dose of 1.0 milligram per kilogram intravenous according to the phase 1 study, and once weekly for first 4-week cycle, once every 2 weeks thereafter. And the standard arm was vorinostat with the same number of patients, 186, at the conventional dose of 400 milligram OD orally for 4 weeks, according to the United States prescribing information, because as you know, vorinostat is an HDAC inhibitor with an official indication for relapsed refractory cutaneous lymphoma by FDA. There was a possibility also to have a crossover, a one-way crossover after disease progression or intolerable toxicity after 2 cycle or more than 2 cycles from vorinostat to mogamulizumab. The stratification was done according to the different histological subtype, I mean mycosis versus Sézary syndrome, and disease stage, 1B2 early stage versus advanced stage, stage 3 and 4. CCR4 expression was not a requirement for participation, and patient could continue treatment until disease, drug intolerance, or unacceptable toxicity. The primary endpoint was the investigator assessed progression-free survival, and there were several secondary endpoints such as overall response rate, duration of response, the patient-reported assessment of quality of life, overall response rate in the crossover population, and of course, safety profile. I think it's very important, as I said before, on the basis of the data presented by Melanie Duvic in the phase 1, phase 2 study, that this kind of drug is really active in different compartments. I mean, skin, lymph node, and blood. And for the assessment of the skin, we use the modified severity weighted assessment tool, the mSWOT, every 4 weeks. For the assessment of lymph node, we use, of course, the CT scan. And for the assessment of blood, of course, the central flow cytometry assessed every 4 weeks with a stratification in 3 different subgroups, B0, B1, and B2. Inclusion criteria, as I said before, adult patient with an age at least of 18 years, 20 years in Japan, with histology, confirmation of histology of mycosis fungoides and Sézary syndrome, stage 1B, stage 4 disease, and who failed at least 1 prior systemic therapy. And you can see here the baseline characteristic of the 186 patients for each arm, mogamulizumab versus vorinostat. There are no statistically significant difference between the two subset of patients, and in fact the number of prior systemic treatment, the median number was 3 for each of these subset, ranging from 1 to 18 for moga, from 0 to 14 for vorinostat. At the same time, you can see here that the percentage of mycosis fungoides was a little bit more than Sézary syndrome, roughly 55% versus 45% respectively. The primary endpoint was met. I mean, the median progression-free survival, according to the investigator assessment, was 7.7 for moga versus only 3.1 months for vorinostat. And the P, of course, was statistically significant. And also, according to the different subgroup, the progression-free survival was in all these subgroup in advantage of mogamulizumab arm. I mean, for the sex, according to the different age, with the stratification at 65 years. Also, when you compare MF versus Sézary syndrome, in early stage versus advanced stage, and also with different regions, I mean United States, Japan, and Europe plus Australia. And also when you have normal or low level of LDH versus elevated LDH level. In terms of response, according to the different compartments, you can see here in the skin, the overall response rate for moga was 42% with a CR of 4%. And at the same time, in the vorinostat group, the overall response rate was 16%. In the blood compartment, the overall response rate for moga was roughly 70% versus only 20% for vorinostat, with a CCR rate of 44% for moga versus only 4% for vorinostat. And finally, concerning lymph nodes compartment, the overall response rate was 17% for moga versus only 4% for vorinostat, and the CR rate was 8% for mogamulizumab versus 2% for vorinostat. So you can see here that in all the 3 different compartments, there is a high advantage in terms of overall response rate, the CR rate for mogamulizumab versus the standard arm. And also in terms of waterfall plot of best skin response and also best global response, you can see here a huge difference when you compare the waterfall plot for mogamulizumab versus the vorinostat waterfall plot, comparing the two groups. In terms of safety profile, the median duration of exposure was roughly twice as long for mogamulizumab, I mean 170 days, than for vorinostat, only 84 days. And in terms of adverse event leading to discontinuation was 19% in MOGA subset versus 23% in vorinostat subset, and adverse event leading to death, only 3 patients, 1.6 in the mogamulizumab arm versus 9 patients, I mean 5% in the vorinostat arm. In terms of commonly reported treatment emergent adverse event, you can see here for mogamulizumab grade 3 and 4, the infusion-related reaction was less than 2%. Drug eruption was reported in 8 patients, I mean 4.3%, and this was the same data close to the phase 1, phase 2 study. And in terms of hematological toxicity, there was no grade 3 and 4, and also few patients had fatigue grade 3 and 4, and only 1 patient nausea grade 3 or 4. And on the basis of this trial, there was this final publication concerning upon the final result of Maverick. And the basis of the publication, there was also, as I said before, the official indication by FDA concerning the activity of mogamulizumab in the treatment of Sézary syndrome and mycosis fungoides, of course, all relapsed refractory patients, the same situation for the European drug agency, so EMA. And on the basis of this summing up of this study, it was the first report of a randomized phase 3 study, I mean the largest phase 3 study in this kind of disease, comparing a new systemic treatment like mogamulizumab versus one of the conventional one. And MOGA, a first-in-class monoclonal antibody targeted CCR4, demonstrated significantly superior efficacy outcomes compared to vorinostat in patients with previously treated cutaneous cell lymphoma, independently by mycosis fungoides or Sézary syndrome. The primary endpoint, the median progression for survival, was a statistically significant advantage of mogamulizumab, 7.7 months versus only 3.1 months, and also in overall response rate was again a statistically significant in advantage of mogamulizumab, 28% versus only roughly 5% for vorinostat. In particular, in terms of overall response rate in the blood compartment, for mogamulizumab was close to 70% versus only roughly 20% for the control arm. Patient-reported quality of life outcome demonstrated significant improvement with mogamulizumab, and the safety profile was consistent with previous report, and common adverse events were really manageable. This study supports mogamulizumab as a valuable new therapeutic option in the treatment of relapsed refractory patients with cutaneous T-cell lymphoma. I want to do an update concerning the post-hoc analysis concerning 2 issues. The first one is efficacy and safety by blood classification, and the second one is the responder cohorts. For the first, mogamulizumab is better than vorinostat in blood compartment, as I said before, and the question is what happens by blood classification? And these data are really very interesting because you can see here, when you compare the result in terms of clinical response, I mean overall response rate of MOGA versus the study arm, the conventional arm, vorinostat, according to the 3 different cohorts, B0, B1, and B2, you can see here that overall response rate for MOGA was 15% for B0, 26% for B1, and close to 38% for B2. Versus only no more than 6% in the 3 different cohorts for vorinostat. And of course, the B was statistically significant. And this data, I think, is very important because you can have also a rebound in terms of longer progression-free survival in the 3 different cohorts of B0, B1, and B2 in advantage of mogamulizumab patients versus vorinostat patients. Another important point is concerning the time to the next treatment, and you can see here again that when you compare MOGA activity versus vorinostat is the 3 different cohorts, B0, B1, and B2, the time to the next treatment is close to 7 months for B0, more than 1 year for B1, and 13 months for B2 versus only 4 months in B0 for vorinostat, 3 months in B1, and again 3 months in P2 for vorinostat. Again, what the P was in the majority of this cohort statistically significant. And again, you can see here in the curves the real important data concerning the median progression response, the time to the next treatment, sorry, the median time to the next treatment for B0, B1, and B2, in particular for MOGA, the red curve versus vorinostat, the black curves. And another important point is related to the median duration of response. The median duration of response with Maverick was 14.1 months. And you can see here the overall response at 4 months, at 6 months, 8 months, and 1 year was 25%, 21, 16, and 10 months respectively. And in all these evaluations, there was a huge advantage, higher response, overall response rate for mogamulizumab when you compare with vorinostat. The same situation in terms of overall response rate, if you stratify the patient according, the response according to the 3 different compartments, blood, skin, and lymph node, with a different time of 4 months, 6 months, 8 months, and 1 year. And the last 2-3 slides are concerning the real-world experience with mogamulizumab. The first one was this publication the last year from the British group concerning the real-world experience using mogamulizumab in relapsed refractory patients with mycosis fungoide and Sézary syndrome in a pediatric area. They treated 9 patients with a very interesting result. And at the same time, this is the case report that we published from my experience in our institution. As I said, I was involved in the Maverick study. I included 19 patients, and this patient is one of them. It was a diagnosis of Sézary syndrome in 2011, stage 4A. And you can see here the long list of prior treatment lines with CHOP in 2011, and then extracorporeal pheresis plus bexarotene, and then the total skin irradiation in 2014. Again, bexarotene repeated in 2014, and finally also another conventional chemotherapy in 2015, like GEMOX regimen. The patient was enrolled in Maverick in July 2015, and he was of course, in the mogamulizumab arm, and was treated with MOGA until October 2017. So I mean for more than 2 years, roughly 27 months. The treatment was stopped because of non-lymphoman skin plaque for some toxicity. But after, and this is the picture baseline before to start with MOGA and after 10 cycles of mogamulizumab. And right now, after more than 4 years from 2017, when the patient stopped the treatment with MOGA, the patients continues to be in continuous complete response without any kind of other consolidation. And this, I think, is very important because is a very long period of continuous complete response that is quite strange to observe with this disease. And we did for several times in different sites skin biopsy, and all of them were absolutely negative. And finally, I want to remember also to visit the brand of new hub concerning this product by Kirin Kai. Thank you very much for your attention.
Thank you, Prof. Zinzani, for this update regarding the option of cutaneous T-cell lymphoma, which is, as you know, it's poor prognosis, especially in elderly. Prof. Zinzani, we have 3 minutes. Maybe we'll have 2 questions. The first one, as you mentioned in the inclusion criteria of the trial of mogamulizumab, the majority of the population was fit patient, especially ECOG 0 and 1. Do you think if we extend the inclusion criteria to have more fragile patients, how will affect the tolerance for the medication?
I'm sorry, I don't hear the last part of your questions.
Regarding the inclusion criteria in the trial of mogamulizumab,
Yeah.
Majority of the patient was fit patient, ECOG 0 and 1. What do you think if we extend the inclusion criteria to have more fragile patients? Will affect the tolerance for the medication?
This could be an option, considering that the safety profile, as I showed a few minutes ago, is really good. So there are no grade 3 and 4. The real problem could be drug interaction, but it's very well controlled. But there are no cardiac toxicity, no lung toxicity, no renal toxicity, and this, I think, is fundamental to try to, in the future, to include also frail patients, fragile patients for this kind of treatment. Okay,
excellent. Another question, Prof. Zinzani, regarding the combination of the mogamulizumab with other agents, especially monoclonal anti-CD30.
Yeah, we discussed it several times with the company. This could be another option, also because there is a very good activity with 2 different targets and potential without any kind of cumulative toxicity. But also could be another option also, why not to think in the future to use mogamulizumab also like a consolidation / maintenance treatment after frontline treatment for cutaneous T-cell lymphoma, because we need some, so the concept could be to have like an induction treatment, then to continue mogamulizumab like consolidation, to convert from PR to CR, or at least to maintain the response obtained with the first regimen.
Okay, excellent. Thank you, Prof. Zinzani, for your answer. By this, we end our last part of the session 1.
Thank you very much.
Thank you, Prof. Zinzani. Now I will pass it to my colleague, Prof. Riyad Dada, to have his closure remark for the first session of this meeting. Prof. Riyad.
Thank you, Dr. Medheb, and thank you, Professor Zinzani. I think Dr. John Abstolidis, he has a burning question, but he lowered his hand. Okay, that's the end of the session. Thank you very much. It was very nice. We have now around 15 minutes for Asr prayer, and I would like to remind you to rejoin. Maybe you can let your Zoom open and go and pray, and we'll see you inshallah at 3:55 Saudi time. So Dr. Lasker, I don't know whether he want to say something. Otherwise, thank you and see you later in 15 minutes. Please stay with us. Assalamu alaikum.
Hello, everybody. Assalamu alaikum. Good afternoon. This is Dr. Samir Al-Amoudi, consultant adult hematology and bone marrow transplant in National Guard Hospital, Jeddah. Welcome to the second session for 16 ICML highlight today. And I and my colleague, Dr. Muhammad Mari, who is consultant adult hematology at King Fahd Medical City, will moderate this session. So without further delay, we'll start to introduce the first speaker, Prof. Emmanuel Zoka, who's the head of lymphoma unit and medical oncology consultant in Oncology Institute of Southern Switzerland, and also the group leader of the International Extranodal Lymphoma Study Group. Also, he's the medical and scientific director, Institute of Oncology Research in Bellinzona, Switzerland. And he's talk today in the next 25 minutes about lymphoma imaging. Hi, Prof.
Thank you for inviting me. Thank you to all who are attending this interesting post-Lugano conference, which unfortunately is still on a virtual basis because of this pandemics. Let me share my screen so that I will start. Here we are, and I will summarize the session of ICML, which was devoted to lymphoma imaging. There are mainly two diseases which were addressed in the abstract presented in Lugano: diffuse large B-cell lymphoma and classical Hodgkin lymphoma. And all the presentation were actually proposals and the description of potentially useful prognostic models based on functional imaging from post-hoc analysis of clinical trials. The remarked French study of R-CHOP 21 plus or minus lenalidomide maintenance from the LISA group, the SAC, the Switzerland Clinical Oncology Group study 3803, which was devoted to study PET scan in R-CHOP 14 treated patients. And for the Hodgkin lymphoma, the GTIL-FIL HD0607 study, which was mainly testing whether radiation therapy can be omitted in patients in complete metabolic remission after 2 and 6 cycles of ABVD. Those studies had a cohort of patients with full PET studies, which were used for the post-hoc analysis presented in Lugano. The first I would present is the Hodgkin lymphoma study, which was presented by Professor Gallamini in Lugano. The background for this study is the evidence that combining the metabolic tumor volume and the Deauville score at interim PET would allow a good separation of patients with different prognostic risk in a prior important Hodgkin lymphoma study, the EORTC HD10 study. Based on this data, the Gallamini group tried to reproduce the same evidence in another large cohort of 331 patients with advanced Hodgkin lymphoma presented with a large initial mass and randomized to receive ABVD with or without radiotherapy. The 3-year progression-free survival, according to the classical international prognostic score for Hodgkin disease, was separating two groups of patients: those with a very good outcome with a score of 0 or 1 and the rest of the patient. This is a small subset of 13% of patients, and this is 87% of the entire cohort. The separation into 3 groups, the SPA is not significantly efficient in this study cohort. The next study they did was to see what type of discrimination would be otherwise provided by the PET parameters. And total tumor volume, the total metabolic tumor volume, with a cutoff volume of 471 ml, after a segmentation done with a 40% of SUVS threshold, separated very well two group of patients, a group of patients with a large group of patients with good outcome and a smaller group of patients with a very poor outcome. They decide then to combine both parameters, international prognostic score and a metabolic tumor volume, to derive a prognostic score, which is describing then a very good risk patient group with a 3-year progression-free survival of 98%, which was analogous to the one defined by IPS, an intermediate group with an overall survival of 85%, and also a very poor risk group with a 3-year progression-free survival of 56%. So, in their study, total metabolic tumor volume was very good in discriminating high and low risk population, and also IPI was able to identify the very good risk patient despite with a less strong significance, and combining both in a unique model proved a tool able to identify either patients with poor prognosis and those which may need a different frontline approach, while maintaining the capacity of also discriminating those with good outcome. The second study I want to summarize is now one of the 3 studies describing diffuse large B-cell lymphoma, which were discussed. This was presented by Catherine Thieblemont for the French LISA group, and they were attempting to use the PET parameters and other parameters to define ultra-high risk patients with diffuse large B-cell lymphoma. The background for their study is that 3-year progression-free survival and overall survival rates remains quite poor, or relatively poor, I would say, for R-CHOP-treated patients, with still around 40 to 30% of cases experiencing a treatment failure. So there is a need for those subsets to develop better therapies. In the REMARK study, which was, as I told you before, a study exploring the role of maintenance lenalidomide in these patients, they had already published 3 manuscripts dealing with functional PET parameters. The first one was showing that the total metabolic tumor volume was discriminating well the prognosis of patients with small versus those with large metabolic volume. The second study was integrating this volume into a prognostic score based on volume and ECOG performance status, which also was separating pretty well different risk groups of patients. And the last study was describing a novel parameter, the distance between the maximum distance between 2 PET positive lesions, which is an expression of tumor dissemination, as an interesting and powerful outcome predictor. The novel information provided in Lugano was referring to the adipose density, lumbar subcutaneous adipose density in PET scan, in CT scans, determined at the level of the L3 in the lumbar bone, which was also separating patients with good and poor progression-free and overall survival. And this adipose density had a predicting power which was independent from IPI, sex, and body mass index. They then normalized the individual parameter which was able to predict progression-free survival, performance status, the distance between the two metabolically active lesions, the adipose density, and the total metabolic volume, into a prognostic score. They call it MVED square. Metabolic volume equal distance density is the reason for this name. And this novel score was very well discriminating patients with good, intermediate, and poor progression-free survival and overall survival. And also seems better in comparison with IPI and is derived NCCN IPI. This is an interesting novel approach with integrating the standard host and disease-related clinical parameters with novel parameters coming from imaging analysis. And this score is potentially a useful tool to identify the ultra-high risk patient with diffuse large B-cell lymphoma, which may need different treatments. The third study, where a post-hoc analysis was focused on PET parameters, is the Swiss oncology clinical cancer trial 3807, which was presented by Guido Ghilardi. And this study was actually done now more than 10 years ago to investigate the role of PET scans in patients treated with R-CHOP14. The investigator said 141 patients with DLBCL treated with R-CHOP14 in whom they had serial PET scans, and 72 of those patients had tumor samples available for molecular analysis. We have already published two prior papers on this subset of patients. One was identifying metabolic tumor volume combined with metabolic heterogeneity on PET scan as potentially very useful prognostic markers, which can be combined to separate different risk of relapse. And in parallel, we also found that SOX1 mutation and CREB-EP EP13 mutations were discriminating good and poor risk patients, with SOX1 mutated patient doing well, as well as CREB-EP mutated patient doing poorly. The aim of the study was to integrate the PET parameters and this genomic information to see whether it would be possible to develop an algorithm that may better predict outcome of patient. And gene-specific mutations were found in most patients, and patients with a favorable mutational profile, those identified by SOX1 mutated and CRAB-BP wild type had a better outcome in comparison with the poor genetic group. And the Chisholm tree algorithm was then developed. Patients with MTV high can be separated in those with favorable mutation profile and those who had favorable mutation profile and low MTV are an excellent prognosis. All of them alive without progression. Whilst on the other end of the score, patients with high metabolic tumor volume, high heterogeneity, and have a particularly poor outcome. So the mutational profile can be integrated with the PET functional parameters to better discriminate within the good prognosis group. And from this data, a prognostic model can be developed, which is represented in this image. And this prognostic score has a negative predictive power of 100%. Still, there is room for improving in terms of positive predictive power, which is only 57%. But nevertheless, this study was suggesting that we can integrate functional PET parameters and genetic profiles to enable a more accurate stratification of diffuse large B-cell lymphoma. And this data may potentially provide a valid tool for dynamically optimizing therapeutic strategies in diffuse large B-cell lymphoma in the future. The same group was also addressing the potential utility of radiomics in the same cohort of patients from the same study. And this second study was presented by Professor Ciriani from my institution. And in this study, there is also the availability of a validation set from a retrospective large group of patients treated with R-CHOP 21, so the standard R-CHOP and not the dose-dense R-CHOP 14. And the study was aimed at exploring the role of radiomics, and the investigators put all the main international prognostic indices scores, the clinical parameters, LDH, stage, and so on, the standard PET metrics, submax, mean, MTV, and TLG, after a central PET revision, and 52 radiomics features not correlated with PET metrics in a lasso Cox regression. This Cox regression actually discarded all non-radiomic parameters and remained with a shape feature, which is actually the correspondent of the distance between the maximum distance between FDG avid lesions in the French study is very corresponding to that, and is adjusted for the body surface with 3 radiomic parameters indicating tumor heterogeneity. And the linear combination of those parameters provided a prognostic radiomic score, which was separating patients in quartile, the first 2 with good prognosis, the second with intermediate prognosis, and the third with poor prognosis. And this impact on both progression-free and co-specific and overall survival, you have here progression-free and co-specific, was confirmed in the independent validation set. And also, the comparison of the discriminating capacity of this score versus the standard international prognostic scores
Thanks, Prof. Emmanuel Zucca, for this informative presentation. So just let me see if there are any questions. So I cannot see any question, but if you allow me, I can ask. So regarding the combined mutational profile and with the functional bit, how gonna that translate into real life or clinical practice in changing the management of diffuse large B-cell lymphoma? So would that change the therapy? Would you give the same therapy? Because the standard until now is R-CHOP for diffuse large B-cell lymphoma.
Yes, I think that diffuse large B-cell lymphoma is likely to not to remain for very long as a basket entity. We have today much clear and consistent evidence that we can have at least 5 molecular subtypes of diffuse large B-cell lymphoma with different prognosis. And in another presentation during this meeting, you will probably have the report of the Chinese study from the University of Shanghai in Lugano, which was showing that you can probably use this genotyping on next generation sequencing of diffuse large B-cell lymphoma to drive the treatment in terms of adding targeted drugs to a drug CHOP backbone, which can be different according to the different molecular profile. And I think that this is the scenario in which we will have to improve and fine-tune the hypothesis generated by the Ghilardi study that we can use molecular profile integrated with imaging data for a better outcome prediction. Moreover, I think also that the radiomic and the radiomic studies, not only of PET scan but also of CT scan together, as shown by the Tieblemont study, will probably offer something more. And to do well in the future, I think that machine learning and artificial intelligence may be helpful in standardizing and perhaps in making faster this type of analysis, because today the time required is actually preventing any everyday use.
Okay, thank you. So there is another question here from Dr. Saeed Akhtar. What percentage of cancer institutions in world are able to perform this PET-CT?
Sorry?
So what percentage of cancer institution will able to do this like modality, like combine the PET-CT with the...
Okay, I think that today the use of total metabolic tumor volume is something that can be probably done in any nuclear medicine center. However, there is still no agreement on the best segmentation method and on the best way to calculate the volumes. But this is a problem being addressed nowadays by the main groups, and I think in a few years, if not months, there will be software available to use to calculate this in a consistent way, these parameters from the everyday PET scan. So this is probably an issue which is going to be solved quickly or relatively quickly. The wide applicability of genetic subtyping depends on platforms you use and on the panel you use, and still this is something which needs standardization. But we have everything to solve the problem. It is a matter of collaboration, and I think this is something that can be in a relatively short time span available for our, but need also to be validated in larger cohorts, in prospective studies. We still have some work to do.
Yeah, I think Dr. Akhtar meant using this modality combined a bit with the mutation and how many institutions are able to do it.
This is expensive. It's probably outside the possibility of non-academic community institutions. You need a molecular laboratory staff and to have a lab implemented. But also in this setting, there are now panels coming which would allow relatively rapid analysis from paraffin-embedded tissue. So it's a matter more of cost than capacity or ability to reproduce it.
Okay. Thanks, Prof. Luca. I cannot see any more questions. So just one more question, maybe. So you mentioned one of that about the adipose density correlate. It's one of the prognostic factor. And just to clarify, it's something not related to the obesity? Is that right?
Yes, apparently it was not related to anything. It was. It has been also suggested by other studies in some solid cancer that the adipose density on CT scan may be prognostic, and also in other lymphoma studies. But this is the first attempt to integrate this with other information into a precise score.
Okay. I cannot see any more questions. So I think we can conclude this lecture. Thanks, Prof. Zoka. Actually, it was very informative. And we're glad to have you with us here. Thank you.
You're welcome.
Okay, thank you.
See you later.
See you. Bye. Okay, so now I think we can move to the next talk. It's with Dr. Anastasios. Already he was present. He's, as you know, he's a head of new drug development unit and chair of clinical research of Oncology Institute of Southern Switzerland, AOC. And already he presented his first lecture earlier this afternoon. So his talk today in the next 25 minutes about aggressive lymphoma. So, Prof. Anastasios.
Hello again, and thank you again for the invitation, and I'm really enjoying the meeting. So let me go to share my screen. I hope it's okay.
Yes, it's okay. We can see it.
Okay, okay, so thank you very much. So I will be presenting now 3 abstracts that were presented in the last ICML on aggressive lymphoma. These are the first one is an abstract reporting on a very interesting study which assigned first-line treatment in diffuse large B-cell lymphoma based on genetic subtype. And I think this is really innovative. Then we do have another study where chemotherapy treatment was guided based on the biology of the lymphoma, again, a first-line therapy. And finally, I will be presenting the abstract that reported some update results on the combination of the anti-CD19 monoclonal antibody tafasitamab in combination with lenalidomide in patients with relapsed refractory diffuse large B-cell lymphoma. So let's go with the first study. So the study was presented by Dr. Zhang, and this is the title. So genetic subtype guided rituximab-based immunochemotherapy improves outcome in newly diagnosed diffuse large B-cell lymphoma. So this was a phase 2 study, and this is a first report of this randomized phase 2 trial. The background is that there has been many efforts over the last years to improve outcomes of patients with diffuse large B-cell lymphoma by improving or by attempting to improve the first-line therapy, which it is standard represented by R-CHOP chemotherapy. And in modern recent years, this has been attempted through mainly 2 ways. One was to increase the dose of chemotherapy, or to give more intense or dose-dense chemotherapies, auto-transplant, and more recently by introducing new drugs, small molecules that were added to R-CHOP. And some of these studies were based on the cell of origin, and we now know that these phase 3 studies were negative. So none of those studies actually was able to improve over R-CHOP. So here, what these investigators did is to use the more recent biologic knowledge that goes beyond the cell of origin. And based on this knowledge, and using 18 different genes, plus BCL2 translocation and BCL6 fusion, they assigned patients in 6 different possibilities of treatment based on the 6 different genotypically defined groups that you can see here. So MCD, BN2, N1, AZB, TP53, and the others. So here you can see how, based on analysis that was done on tissue, they defined these 6 different subgroups. And patients were randomized R-CHOP or to R-CHOP plus drug that was assumed to work based on the genetics. So they used ibrutinib, lenalidomide, trucidinostat, decitabine, lenalidomide. So these were the different drugs that were added to R-CHOP based on the genetic subtype. The key inclusion criteria included diffuse large B-cell lymphoma patients not previously treated, so it's a first-line trial. Patients had to have an EP score of 2 and above, and the primary endpoint was the CR rate. So they compared the CR rate of R-CHOP versus R-CHOP plus targeted agent based on the genetic subtype of the patient. Now, this is the patient's disposition. 128 patients were randomized to either R-CHOP standard therapy or R-CHOP plus the targeted agent, and so there was a an improvement of the CR rate. So this is a primary endpoint, was a positive study. If we look at the CR rate, and there was a clearly benefit in terms of complete response rate in the experimental arm. So 87% versus 66% in the standard arm, which is statistically significant. And now this is based on the different subgroups. So again, now here the numbers are much smaller. So we have 10 patients, 2 in some of them, and the improvement is in all subtypes. I just realized that I did not report here any time-related endpoints, and there was an improvement also in progression-free survival and overall survival, but these are secondary endpoints, but they did better in the experimental arm. This is toxicity. Of course, if you add another drug, you have some more toxicities, and this is here evident, although it does not seem to be a highly adverse profile by adding a new drug. So there is some more hematologic adverse events, but none of those regimens were really ending up with too much clinically significant adverse events in comparison to R-CHOP. So it seems to be a feasible approach. So in conclusion, this is the first study to assign therapy in first line based on molecular subtypes. And I think it's a very interesting approach. There is a lot of this type of trials in solid tumors. There are some conflicting results. There are results, the first studies were negative, some others now are positive, but it's a very interesting approach. So it's very nice to see such kind of a study in lymphoma. The study is positive based on the primary endpoint, and it showed a superior activity in comparison to R-CHOP when to R-CHOP you add a compound that is genetically guided. We know that phase 3 trials, as I mentioned previously, with new drugs in first line have been negative. They were based mainly on cell of origin. So now we have a little bit more of knowledge that it's interesting to see if this will be possible to apply. I think that this trial would support this kind of designs. It is very interesting. Of course, I think there is a lot of questions. I'm not sure that CR rate is the best endpoint because I think that the responses will probably be better when you add a new drug, but I think it will be also interesting to define if this would really result in clinical significant changes. So I think there is not currently a lot of information to say that we could expect really any of those arms in a randomized phase 3 study to be better than the standard of care. So I think this is still an open question. And of course, the other point is that we still need to understand what are the best drugs. So the drugs that we've seen here is an example, but I think the choice of the drugs is very, very important. So this kind of trials, if they come, I think that they will have to define what could be an appropriate endpoint, so that they don't are positive in this type of trials, and then you go to a bigger study and they fail, like it was the example of previous studies with new drugs in diffuse large B-cell lymphoma with R-CHOP. And the other thing, of course, is that we really need to define which are the good drugs to combine with R-CHOP. So this is, of course, still an open question, I think. I will move to the second study. This study was performed by the Nordic Lymphoma Group. It is, again, a study which prospectively assigns to patients therapy based on biologic genetic characteristics of the patients. So here there is not a new drug, but there is a dose escalation, we can say, a modification of the chemotherapy based on the presence or not of adverse factors. So this is the study design. It seems complicated, but actually what happens is that these are patients with high risk diffuse large B-cell lymphoma. So they have high IPI risk. they have high CNS IPI risk, and all the different types of genetically defined high-risk DLBCL patients are included. So double hit, triple hit, so these patients are included in the study, high-risk patients. So those patients were treated with R-CHOP plus high-dose methotrexate for 2 cycles, all patients. And then there was a stratification for those patients that after 2 cycles were not on progressive disease and they should continue with the treatment. And then there was really, let's say, a randomization between those patients that had any of biologic factors that were adverse and they were present, they were escalated to dose-adjusted epoch. So rituximab dose-adjusted epoch. And the other patients, those that were not having any of those factors, continued with R-CHOP, but there was again another change here. Etoposide was added. So it's not R-CHOP, it's R-CHOP plus etoposide. So there is still some escalation, but the other is the infusional regimen, the dose-adjusted epoch. And then all patients after 4 cycles received another consolidation study line of treatment with high-dose cytarabine. Now, the biological risk factors based on which the stratification occur, you can see them in this orange box. So this is MYC translocations, double hit, P53 deleted, P53 positive also by immunochemistry, MYC positive, BCL2 positive by immunochemistry, and CD5 positive. So any of those factors would make the patient go on the high-dose therapy. So this is the inclusion criteria that I mentioned previously. There is adverse events, clinical adverse events, histological, DLBCL, high-grade, follicular lymphoma grade 3B was included. Patients have to have at least stage 2 with high EP, more extranodal sites, testicular lymphoma, or paranasal orbital lymphoma were included. So these are really the high-risk patients from a clinical point of view. These are the characteristics of the patients. You can see here, 68% had stage 4, 60% B symptoms, LDH were increased, more than 1 extranodal site in 70 patients, 70%. So this is really a high risk also for CNS relapse. And here you can see the biologic characteristics, double or triple hit 12%, and then 17p, 53 deleted 15%, CD5 positive 5%. Now, this is what happened in the whole patient population in terms of responses. There is a high response rate at the end of therapy. This is after 2 R-CHOP and methotrexate, 15% of CR rate, 83% of PR, and then at the end of the whole program, there is a 77% CR rate and 20% of partial remission. And this is the metabolic response, Deauville score 3 to 1, 87%. Now, this is the time-related endpoints in the whole population. The failure-free survival in 2 years, 82%. Overall survival is 92%. Now, the patient with adverse biologic factors did worse in comparison to those without. And you can see here there is a clear difference in the PFS, 95% in those without risk factors and 76% in those with risk factors. Now, if we adjust for the EP, we can see that there is no difference among the those with double hit or triple hit versus those without double or triple hit, but only those with 17p, P53 deleted, and CD5 Q plus, they maintain an adverse prognostic score. Also, at multivariable analysis, there is still this importance of these 2 characteristics in the adverse prognostic score. Now, in conclusion, the activity compares favorably with historical data, at least in some of these groups. So there is some feasibility of this approach. to guide treatment based on these characteristics of the patient that can be relatively easily assessed on the biopsy tissue. And this is a study on intensive regimens, but these are regimens that are now used and have been used also just at epoch also for other entities. Now, patients with adverse factors still do worst. And of course, I think among the different regimens and the different possibilities of escalating therapies in patients with adverse factors, it's not easy to define which is the best regimen. So there is still questions also here. And I will go to the last study. This was a study on patients already treated and reporting on the long-term results of lenalidomide with tafasitamab, which is an anti-CD19 monoclonal antibody. So the study, as I mentioned, is a study on patients previously failing other treatments, not eligible for transplant. You can see here that the antibody is being given weekly for 3 cycles. So this means that the patient comes very often in the clinic. This is 3 months that the patient comes every week to have this antibody, and then they get lenalidomide, and from cycle 4, patients are up to cycle 12. So for the 8 months, then they come every other week. And then finally, there's a maintenance for those patients that after a year are in remission or at least in stable disease, that they can go up to progression. This is the patient population. There's 81 patients that have been included, and you can see here the median number of prior therapies is 2. And only 11% of patients were failing prior transplant, and 20% of the patients had previously defined refractory lymphoma. Now, this is the table of responses. So overall, we can see that there is a significant response rate, is 46%. So it compares well with other compounds. This is the overall response rate divided to patients that had only 1 prior line of treatment. So it's close to 30%, while it's 20% in those that had more lines of therapy. This is PFS. The overall is 11.6 months at this updated data. And in terms of adverse events, I think this is a pretty well-tolerated regimen. Most of the adverse events are hematologic in nature, and you can see neutropenia and thrombocytopenia are the most frequent adverse events, with thrombocytopenia grade 3 and above in 17% of patients. So as a conclusion of the study, this combination, it is active, there is activity. It is characterized by a good safety profile. On the other hand, as I mentioned previously, it's a long-term treatment, so patients have to stay in a treatment that logistically I imagine is an important treatment, because for several months they come every week to get treatment, and there is some benefit. However, it seems in comparison to what we've seen also with bispecifics or with loncastuximab, it seems to be more important in those patients less heavily pretreated. So this is also something that one should consider. And now, again, I think the question comes, as we have several now options with activity in DLBCL, how this could be integrated in the treatment of relapsed patients with diffuse large B-cell lymphoma. I will conclude my presentation on aggressive lymphomas to trying also to summarize what we saw in Lugano, also integrating with previous data. So this is a review that we did where we looked all phase 3 studies that were published up to 2018 in diffuse large B-cell lymphoma, first line, and we took in consideration all new drugs that were added to R-CHOP, and these were all invariable negative. They were all based in very good phase 1, phase 2 data, but then when they went to do the phase 3, they were negative. Of course, the cell of origin, it was a very important notion, and some of these studies were based on this assumption, the Phoenix study, the remodel, but this was not enough to help defining patient population that would benefit by ibrutinib, lenalidomide in these examples, or by other drugs. Now, this was mentioned previously. We have now new knowledge that also there is heterogeneity, genetical heterogeneity that goes beyond the cell of origin. I think that was also the rationale of the first study that we've seen, the study that assigned treatment based on the genetics. And there are distinct molecular subtypes of diffuse large B-cell lymphoma. Among the ABC subtype, distinct different types that they have different outcome when treated with the same treatment. So it's not the same disease, and perhaps these different subtypes, they do not respond the same way to a compound. Now, which could be the future perspectives based on this knowledge? Well, I think it's important that we still make a lot of efforts to molecularly characterize patients with diffuse large B-cell lymphoma and try to bring this knowledge to the clinic, to the clinical trials. So another question is how will we be able to incorporate these active drugs in the first line targeted by specific? And then, of course, I think it's important to define better strategies of guiding prospectively treatment. This could be based on PET. So PET responses, adapted strategies. We now have great tools with liquid biopsies, with ctDNA, adapted strategies. And I think this opens a lot of new possibilities, and really a great moment, I believe, at this moment to think on trials in diffuse large B-cell lymphoma. And on that end, I want to share briefly with you a clinical trial that we are performing here in Bellinzona, and it was designed here with Professor Zucca, Professor Rossi, and this is a PET and liquid biopsy guided therapy in diffuse large B-cell lymphoma. So we treat patients that would qualify otherwise for 6 cycles of R-CHOP chemotherapy. So DLBCL not otherwise specified. And there is a first randomization based on the presence or not of the mutations that you can perhaps see here on the red. So this is MCD genotype. And those patients that have this mutation, which is investigated in the blood, they go to receive escalation of treatment, R-CHOP plus acalabrutinib. On the other hand, those patients, and this is the majority that do not have at the baseline this mutation, they get 2 cycles of R-CHOP, and then based on PET and molecular response, so we do an integrated assessment, then we assign patients to 3 different arms. So we have an arm that goes to the standard 6 cycles of R-CHOP, and these are patients that have Deauville score 1-3 or a metabolic response, but not both of them. Those patients that have a response to both PET and complete molecular response on liquid biopsy, they are de-escalated. They get 4 cycles in total of R-CHOP and 2 cycles of rituximab. So we reduce the amount of chemotherapy. On the other hand, and finally, this is the last arm, those patients that don't have a good response in these 2, PET and Deauville score 4, and no molecular response, again, they are escalated. They get R-CHOP and they add acalabrutinib for another 4 cycles. So this is our study that we are running right now. And with that, I would like to thank you again very much for your attention.
Thanks a lot, Dr. Stasis, for this great presentation. So just a question regarding the first trial that you mentioned about combining R-CHOP with other targeted therapy. So do you think if there is like this result, and the patient achieve CR, will there gonna be a rule of maintenance, like, R-CHOP just for 6 to 8 cycles, after that, would you continue maintenance on the targeted therapy or not?
Yeah, thank you very much for this question. I think there is no really data to support this. There was a study with lenalidomide maintenance after R-CHOP, and actually it was a positive study. But if I'm not wrong, those patients that really benefited from maintenance were those that did not achieve a CR. For patients not in CR, of course, it makes sense, I think, also clinically to continue with the treatment. But again, I think this is a point that we could look with molecular residual disease and define if there is any patients that it would make sense to continue with the maintenance. But clinically at the moment, in first line, I don't think there is a lot of evidence.
Okay, thank you. So regarding the last trial that we mentioned about the tafasitamab, so is it like, we can say it's like a palliative approach to this type of patients that they are not fit for therapy?
I think, yeah, I think, yeah, perhaps it's not wrong what you said. I mean, it's a good option. It's an active therapy. We will need to have a little bit more data, if possible, to see if there is any patients that can have that can be free from their disease and can maintain that. Otherwise, I think it's a good option for patients that perhaps could not afford more intense treatments, and they would be well enough to come in the clinic every week. So in that case, I would be really happy. And there are many of those patients with DLBCL that they are progressing, you don't have any treatment. And I think for those patients, it could be a good option.
Okay, thank you. Any patient were included in this trial, like relapse post-CAR T-cell?
I think, well, we should look at the table. I don't remember, but I don't think that there were patients that had CAR Ts in this specific study. There are few studies so far with these new drugs that had really many patients in CAR Ts. I think that this is an ongoing work, and perhaps we will have some more data in a couple of years from now.
Okay, great. And there's a question, one of the audience, that I think about your second trial, like about the biological risk factor. Was there any difference in like subgroup analysis when they're using like CHOP or adding etoposide compared to those adjusted EPO?
Yeah, we should look at that. I don't remember specifically on the other clinical characteristics apart from those that remained, as I mentioned previously, important also after adjustment for EP. That was not the double hit, but for the clinical characteristics, I don't remember. It's a good point. We should look at that. Yeah.
Okay, great. I cannot see any further questions. So I think, okay, thanks, Dr. Stasis. It was a great presentation. Thanks for having us. You with us today.
Thank you for having us. Thank you very much. Thank you.
Thank you. See you. Bye.
Bye.
I think now we'll hand the phone to Dr. Mohammed Mar'i. He will be the moderator for the next two speakers. Thank you.
Okay, thank you, Dr. Samir. We'll move to the second part of session number 2. So we'll have Dr. Mohsen Zahrani. He is going to present 2 abstracts. The first one is BIT adaptive therapy in bulky stage 1-2 classical Hodgkin's lymphoma. And the second abstract will be a prognostic score incorporating MTV predict treatment failure in advanced Hodgkin's lymphoma. Dr. Mohsen Zahrani, he's a consultant, section head division of adult hematology and cellular therapy, Department of Oncology, King Abdulaziz Medical City, Riyadh. He's also an assistant professor in King Saud bin Abdulaziz University for Health Science, Riyadh. Dr. Mohsen, the mic is yours. Thank you.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Muhammad, for the introduction. And I would like to thank also the organizing and scientific committee of SSBMT to invite me to present in this conference, to present 2 studies from 16 ICML highlights. So the first study that I'm going to present was presented by Dr. Anne Lakaska, which is CLGB 5081 Alliance Beta Adapted Therapy in Bulky Stage 1-2 Classical Hodgkin Lymphoma. As you see in the table, these are 4 randomized bit-directed studies in Hodgkin lymphoma that included patients with bulky disease. Most of these studies include unfavorable stage, early stage, or advanced stage Hodgkin lymphoma. If we look to the group with the BIT2 negative in each study, which is this slide, the second slide will be showing the BIT2 positive studies. The ECOG study randomized patients to ABVD times 6 plus radiation therapy versus Stanford 5 plus radiation therapy. All patients had bulky disease, and the outcome was better using ABVD plus radiation therapy. So we know the ABVD plus radiation therapy, or ABVD in general, is better than Stanford. Russell study, 119 patients with bulky disease from 1,203 recruited in this clinical trial. The escalation of therapy to AVD, de-escalation of therapy to AVD times 4 with no radiation therapy did not affect the outcome on those patients to 91.5% BFS. The EORTC H10 study, 515 patients. There was bulky disease out of 1,196 patients. 375 had BIT2 negative, and no radiation. The non-radiation arm has similar outcome to those receiving radiation therapy. So omitting radiation in the BIT2 negative arm did not affect the outcome and has similar BFS to those who received radiation therapy. In HD17 study, 199 patients with bulky disease, removal of radiation therapy also did not affect the outcome. So we see from this studies that BIT2 negative studies showing that omitting radiation therapy may not affect the outcome and will reduce the toxicity. Regarding classical Hodgkin lymphoma with bulky disease and BIT2 positive, we have 2 studies, the EORTC H10. Again, 515 patients had bulky disease, and 140 of them had BIT2 positive. And the escalation of therapy to ABVD plus escalated BCOP plus radiation therapy resulted in outcome almost similar to BIT negative, with excellent outcome, 91%, similar to those with BIT2 negative. In HD17 study, 199 patients in total with bulky disease and BIT2 positive had low BFS despite giving radiation therapy to chemotherapy arm. So this indicates that BIT2 positive is associated with a worse outcome. But the escalation of treatment may improve the outcome of those patients, and we should include radiation therapy. In a previous study of Alliance group, which is 5064, stage 1 and 2 without bulky disease, the BFS of BIT2 positive arm at 3 years was 67% compared to 91% in BIT2 arm. However, radiation therapy is associated with late toxicities, and previous studies BIT directed is associated with progression-free survival outcome. The hypothesis in this study of classical Hodgkin lymphoma, this study with bulky disease, is to study the de-escalation of therapy in BIT2 negative with removal of radiation therapy and escalation of therapy if they have BIT2 positive. The escalation is with escalated backup plus radiation therapy. This is the design of the study. They start with ABVD for 2 cycles, then they do BIT2. And if BIT2 is negative, there is no radiation therapy, and they will continue with another 4 cycles, total of 6 cycles ABVD. If BIT2 is positive, 4 cycles escalated backup will be given plus radiation therapy. And the eligibility criteria is limited stage disease plus bulky tumor defined by mass more than 10 centimeter or mediastinal mass more than 1/3 maximum intrathoracic diameters on chest X-ray. Primary endpoint was the BFS. The calculated sample size was 93 patients. Final analysis after all patients had been followed for at least 3 years post-study entry. 100 patients enrolled. 92 patients completed 2 ABVD. 73 patients or 78% tend to have BIT2 negative and received additional 4 cycles of ABVD with removal of radiation therapy. 21 patients or 22% of patients had BIT2 positive and received the escalation treatment, which is 4 cycles escalated backup plus they added the radiation therapy. These are the patient characteristics were similar in both arms. If we look to the stages of the disease, the study included both favorable and unfavorable patients. Regarding pulmonary toxicity secondary to bleomycin, 70 and 76% of patients respectively received bleomycin for a total of 6 cycles in each arm. Pulmonary toxicity were similar in both arms, none with grade 4 in both arms, none with grade 3 in escalation arm, and more cases of grade 1 to 3 in ABVD arm. Hematologic toxicities, febrile neutropenia, and sepsis, as expected, were more in the escalation arm because we used the escalated backup, but no death is related to this. The BFS at 3 years was 90% in BIT2 positive in the escalation arm and 93% in BIT2 negative in those patients who received standard arm 6 cycles of ABVD with hazard ratio of 1.03. Overall, survival was similar in both arms, 94% in BIT2 positive and 99% in BIT2 negative. 1 death in BIT2 positive was secondary to pneumonia and lymphoma. 3 deaths in BIT2 negative were secondary to lymphoma, anaplastic astrocytoma, and COPD. So in conclusion, this was the first prospective study limited to bulky stage 1 to 2 classical Hodgkin lymphoma. BIT2 adapted therapy was associated with excellent BFS in all patients. 78% of patients did not require radiation therapy or exposure to escalated backup. Unexpectedly, BIT2 positive patients with bulky disease appear to have improved outcome compared to stage 1 to 2 patients with non-bulky disease in the Alliance 5064. Maybe the explanation for this, the small number of patients included in both studies, especially the non-bulky disease, and the use of 4 cycles of escalated backup in the bulky study versus 2 cycles of escalated backup in the non-bulky study. Limitations of this study is small number of BIT2 positive patients, as you mentioned, 21 patients. The non-randomization recommendation is to omit, as a conclusion, recommendation is to omit radiation therapy in BIT2 negative patients who receive 6 cycles of ABVD. Is safe, and this has been shown in other studies. Future directions is comparison of future studies incorporating novel agents with respect to efficacy, safety, and cost. So this is the conclusion of the first study. Thank you. And this slide from the presenter and the Alliance group. If you agree, I will go to the second study.
Yeah,
So
go ahead, Dr.
Okay, thank you. So the second study is the new prognostic score incorporating metabolic tumor volume, predicts treatment failure in advanced Hodgkin lymphoma. This was presented by Dr. Barrington on behalf of Rathel and Swag investigators from UK and USA. This slide is the disclosure of the presenter. As a background, metabolic tumor volume is promising biomarker for assessing prognosis at baseline in Hodgkin lymphoma. In this study, they hypothesized that the risk of treatment failure in advanced Hodgkin lymphoma might be assessed more accurately by incorporating BIT metrics with clinical factors to guide initial treatment at baseline. This study is well known. The Rathel study included patients with advanced Hodgkin lymphoma who were treated with 2 cycles ABVD with randomization of patients with negative BIT scan to ABVD or AVD by omitting bleomycin. This is the de-escalation arm, and treatment escalation for patients with positive BIT scan to PCOB chemotherapy. The escalation with AVD was non-inferior to ABVD as a conclusion from this study. Baseline clinical and BIT characteristics were evaluated in the UK Rathel population, including metabolic tumor volume, total lesion glycolysis, and various SUV metrics. Patients were divided into training and validation sets in a ratio of 2:1. A Hodgkin lymphoma event was defined as a positive interim BIT scan at cycle 2 of ABVD or relapse after a negative interim scan. They explored the association of clinical and BIT factors with the risk of a Hodgkin lymphoma event using bootstrapping with Cox regression and receiver operating characteristic area under the curve analysis 5-year event to drive a new prognostic score. 1 patient died before BIT2 due to Hodgkin lymphoma included as an event. 1 patient died before BIT2 with cardiac cause of death and was not included as an event. 17 patients died after BIT2 negative scan without relapse and death thought unrelated to Hodgkin lymphoma and were not included as event. These are the 25 parameters they evaluated. For BIT, they measured the maximum SUV, MTV, and TLG of the total tumor and the bulkiest lesion. They used 2 SUV threshold to outline tumor and locked site of extranodal involvement on BIT CT. The clinical factors were components of the IBS, bulk, B symptoms, and BS. The training set included 521 patients. The final model included MTV outlined using an SUV of 4 or greater and lymphocyte as percentage of total white cell, both as continuous variables and stage 4. The area under the curve was 64.8, indicating moderate accuracy. The hazard ratio of 1.89 indicate that for a unit increase in a score, there is nearly a doubling in the risk of a Hodgkin lymphoma event. They choose the 30% of patients with the highest score in the training set to be the high risk group, and the remaining 70% to be the standard group, as this cut point was associated with acceptable risk for treatment escalation at diagnosis. Using this more clinically relevant cut point, the Hodgkin lymphoma event rate at 5 years which included patients with a BIT2 positive scan was 22.1% for the standard group and 45.4% for the high risk group with a hazard ratio of 2.4. The new score had a sensitivity of 47.7% and a specificity of 76.3% to detect a Hodgkin lymphoma event by 5 years. It discriminated the risk of a Hodgkin lymphoma event by 5 years better than IBS, which had lower sensitivity and lower specificity and incorrectly assigned more patients to the high risk group. This table shows the expected outcome of 1,000 patients treated with Arathel approach at 5 years. 42% of patients would have a Hodgkin lymphoma event if considered high risk using the new score, compared to 36% of patients considered high risk using IBS score of 3+, which is the high risk group. Conversely, 81% of patients would not experience a Hodgkin lymphoma event if considered the standard risk. The new score compared to 74% considered standard risk with the IBS of 0 to 2. The standard risk patient had 5-year BFS of around 85%, the high risk group of around 70% and 80% for the whole cohort. The standard risk group had comparable BFS to patients in the bit-driven arm of the AHL 2011 study treated with escalated BICOP first line and de-escalation after 2 cycles to ABVD if bit negative. Combining the new score with IBS provided no additional information, as you see in this graph, and the new score model arm dominated over the IBS arms. The score derived from the training set validated internally in the Arathel database, as you see in the graph, with similar results in the training set and the validation set in for both the standard risk and high risk groups. They did external validation in the SWOG 0816 study, which had a similar trial designed to Arathel, but included only stage 3 and 4 patients. So in the SWOG 0816 study, they treated patients with 2 ABVD, and then they do BIT2. If they have BIT2 negative, then they give 4 cycles ABVD. BIT2 positive, they escalated the treatment with 6 additional cycles of escalated BICOP. They compared the result of the new score and its association with the Hodgkin lymphoma event in patients with stage 3 and 4 in the Arathel training set and the SWOG data. The score validated in the external independent database with the result as shown that were closely aligned with the Arathel and SWOG 0816. As you see in the graph, the result is similar for both studies in the training and the validation, external validation set in the SWOG database for both the standard and high risk groups. So in conclusion, a new prognostic score incorporating a metabolic tumor volume could identify patients with advanced Hodgkin lymphoma in whom more intensive therapy than ABVD would be useful at diagnosis, whilst avoiding escalation for those with high chance of cure with ABVD alone. As the score is continuous, cut point could be changed depending on the proposed therapy and risk-reward balance for over or under treatment. This is the acknowledgement from the presenter. And this is the, thank you very much. I'll be happy to take any questions.
Okay, thank you, Dr. Mohsen. We'll see if we have any questions from the audience. Okay, so it seems to be there is no questions. Can we use this prognostication like MTV in early Hodgkin's lymphoma?
Yes, it can be used, and as the training set included in the Arathel study, it can be used in the early stage Hodgkin lymphoma, but the details of the measurement for the early stage disease need to be studied carefully. And we need to wait for the manuscript of this study to see how they measure the metabolic tumor volume and other parameters to identify those with standard risk versus those with high risk.
Okay, good, thank you. So from your experience, like escalating the treatment after PET positive, after second cycle of ABVD, have you had like an experience, the tolerability of chemotherapy if you have PET positive after second ABVD in terms of toxicity?
Yes, this is actually our practice at National Guard Hospital in Riyadh. After 2 cycles ABVD, if there is still PET positive with no significant response, usually we escalated the treatment to escalated PCOP. And we have reported this in a manuscript, and the escalation of treatment has shown that there is improvement in those PET2 positive compared to those who did not receive escalation of treatment.
Good. Long-term toxicity, any update, any data you have?
Similar to, not different from those who are treated with escalated PCOP. We did not study this, we did not present it in abstract, but from our practice, we noticed similar toxicities regarding hematologic toxicities and other toxicities.
Okay, what about the new agent like brontuximab based regimen if PET positive?
This depends if there is clear failure of treatment like refractory disease or failure to treatment, there is like disease progression after 2 cycles. Those patients, they failed the treatment, so we take them to salvage treatment, which include second-line chemotherapy, and our practice is to add brentuximab to second-line treatment, followed by autologous transplant.
Thank you very much, Dr. Mohsen. If no questions, I think we're going to conclude this session. Thank you, Dr. Mohsen, for informative presentation.
Thank you.
So we're going to move to last part of session number 2. We have Dr. John Apostolodis. He is a consultant, hematology and bone marrow transplant, King Fahd Specialist Hospital, Dammam. He's going to present 2 abstracts. The first one is nivolumab for relapsed refractory classical Hodgkin's lymphoma after autologous transplant, 5-year overall survival. And the second abstract with going to be CAM-T, which is a conjugate antibody, an open label multi-center phase 2 study in a patient with relapsed refractory classical Hodgkin's lymphoma. Dr. John, go ahead, please.
Thank you for the introduction. I would like to thank the Saudi SSBMT and the Saudi Lymphoma Group for giving me the opportunity to present these abstracts. The first presentation is updated 5-year results of the phase 2 Checkmate 205 study, in which patients who had relapsed or refractory Hodgkin's lymphoma who had failed autologous stem cell transplantation were treated with nivolumab. So PD-1 blockade therapy is now standard of care for most patients with relapsed refractory Hodgkin's lymphoma, and this is based on the results of clinical trials that show that these agents have activity in the Hodgkin's lymphoma. And one of these studies was the pivotal Checkmate 205 study, in which results were presented at a time point of 18 months, as you can see here, and 33 months, and in which the results were quite similar. Now, we also know that PD-1 inhibitors as monotherapy in a randomized fashion have shown that they improve progression-free survival when compared with brentuximab in the relapsed refractory setting. what we don't know is the long-term survival benefit of anti-PD-1 therapy and the optimal duration of treatment in these patients. So the updated results of the Checkmate 205 study with a median follow-up of 5 years is looking into these questions. And just to remind us all of the study design, patients with relapsed refractory Hodgkin's lymphoma who had previously undergone auto stem cell transplantation were enrolled into the study. There were 3 cohorts. Cohort A, which included patients who were rituximab vedotin naive. Cohort B, which included patients who had received rituximab vedotin after auto stem cell transplantation. And cohort C, which included patients who had received rituximab vedotin before and or after auto stem cell transplantation. Treatment was continued until disease progression or unacceptable toxicity. And a particular interesting part of the cohort C was that patients who had achieved CR that lasted at least a year per protocol discontinued treatment and were retreated if they'd relapsed within 2 years. Data cutoff, the database lock was met in January 2021. Here we can see the patient's disposition. Sorry. Now, as you can see here, there are 19 patients who are still on treatment. As regard to patients who went off treatment, the vast majority of these patients, as you can see, 40% was due to progressive disease, while 10% of patients went off study due to treatment-related toxicity. Yes.
Can you switch off your camera and switch it on, please? It's not clear, actually.
Oh, sorry. Is it okay now?
No, it's not clear. Yeah, that's right.
Okay. Now, regarding patients, there was a proportion of patients, 24 patients who went on to a subsequent stem cell transplant associated with a benefit they achieved when treated with nivolumab. And of these 24 patients, the majority, it's 23, went on to receive allo stem cell transplantation, while one of these patients from cohort A received an auto stem cell transplant. Sorry, I'm having difficulty. Oh, okay. Here we can see the adverse events. And as you can see, 82% of patients developed adverse events, and 82%, sorry, and 28% developed grade 3 or 4 adverse events, which do not differ with those presented in the previous analysis of the study, suggesting that with long-term treatment, the side effects, there have been no new serious side effects. Here we can see the immune-mediated adverse events. As you can see here, a proportion of patients developed adverse events of immune-mediated of any grade, but if we focus on the grade 3 and 4 immune-mediated adverse events, they are very few numbers, so you consider this toxicity quite small. Now, if you look at the best response after extended follow-up, you can see that the overall response rate was 71%, and ranging from 65 to 75%. The CR rate was 21%, as you can see. Now, with regard to the CR rate, it was 16% at 33 months of follow-up, and it increased to 21% at 58 months of follow-up. But this is due to data cleanup, confirming responses that had not been previously seen, rather than late response to treatment. If we look at the duration of response by best overall response, we can see that the median duration of response for all responders was 18.2 months. But as you can see here, patients who achieved complete remission had a very good, very favorable outcome. As you can see, the median duration of response was 30.3 months in these patients. And if we look at progression-free survival, the median progression-free survival ranged from 15 to 18 months, and overall it was 15.1 months. And we can still see that the 5-year progression-free survival is 18%. Again, if we break down progression-free survival by best response rate, we can see that those who had the most favorable outcome are those who achieved CR. We can see that the median progression-free survival was 37.4 months for patients who had achieved CR. And if we look at the overall survival of the patients, we can see that the 5-year overall survival has not been reached, and it's 71.4% at 5 years. And again, if we break it down by best response, we can see that the patients who had achieved a CR had excellent overall survival, as you can see. But one could argue that also patients who achieved a partial remission or stable disease also had prolonged overall survival. Interestingly, even in patients who had progressive disease, there's a proportion of these patients who are still alive, mainly due to the incorporation of salvage therapies after failure of the immune checkpoint inhibitor. Now we focus on patients in cohort C. These are patients who discontinued treatment after at least a year of persistent CR. In total, these are 12 patients. As you can see here, 6 patients maintained their remission on follow-up. Of the remaining 6 patients, 4 progressed. 1 of these received commercial nivolumab off study. 3 patients were retreated per protocol, and 1 of these patients continues to be treated and is disease-free at almost 3 years. So in conclusion, the 5-year follow-up of the CheckMate 205 study confirms the efficacy of nivolumab for patients who have relapsed Hodgkin's or recurrent Hodgkin's lymphoma and who have progressed or relapsed after auto stem cell transplantation. We can see that in a proportion of these patients, the responses are durable and with extended follow-up, in particular for patients who have achieved complete remission. And the favorable overall response was observed with long-term follow-up in all categories of patients. Regarding the adverse event profile, with extended follow-up, there were no new signals of adverse events. And although a limited number of patients, it seems feasible to stop nivolumab after 1 year of complete remission and reinitiate treatment upon disease progression. So these are acknowledgements. So I'll proceed with the next abstract. So the next abstract is titled Camidanumab Tesarin Efficacy and Safety in an Open-Label Multi-Center Phase 2 Study of Patients with Relapsed and Refractory Classic Hodgkin's Lymphoma. This study was presented by Pierluigi Zinzani on behalf of the co-authors and the participating centers. These are the disclosures. So we know that there are limited therapeutic options for patients who have relapsed refractory Hodgkin's and who have been unresponsive or who have failed rituximab vedotin and a PD-1 blockade agent. So novel agents are required to address the unmet need in these patients. Camidanumab tesarin is an antibody drug conjugate, which comprising of a human IgG anti-CD25 monoclonal antibody, which is conjugated to a potent pyrrolobenzodiazepine dimer warhead. So essentially, as you can see here in this picture, the antibody drug conjugate targets the cell, is internalized, and transported to the lysosome, where a protease-sensitive linker is cleaved, and the pyrrolobenzodiazepine dimers are freed into the cell. And what they do is they develop intrastrand cross-links with the DNA, which leads to cell death. Now, treatment with CAMI, as we refer to from now on, demonstrated encouraging anti-tumor activity and manageable toxicity in a phase 1 clinical trial that included patients with relapsed refractory Hodgkin's lymphoma. These patients received CAMI at a dose of 45 microgram per kilogram and achieved an overall response rate of 86.5%. In the initial findings of in the initial phase 2 study, which included around 50% of the patients of the phase 2 study I'm discussing now, they achieved an overall response rate of 83%. So here, the authors presented the preliminary results of this phase 2 study after meeting the target enrollment of 100 patients. So this is an ongoing phase 2 single-arm, multi-center, open-label study in which patients with relapsed refractory Hodgkin's lymphoma received CAMI at a 30-minute IV infusion on day 1 of each 3-week cycle. In the first 2 cycles, the dose was 45 microgram per kilogram, while from cycle 3 onward up to a year, the dose was 30 microgram per kilogram. Here are the key study endpoints. The primary endpoint was overall response rate, as assessed by a central review committee. And secondary endpoints included duration of response, progression-free survival, the proportion of patients who went on to a stem cell transplant, and safety per frequency and severity of the adverse events. Here are the inclusion and exclusion criteria. Regarding the inclusion criteria, I'd like you to focus on one of the criteria, which is that patients had to have received at least 3 prior systemic therapies, or at least 2 if they were ineligible for stem cell transplantation. And all patients had received prior therapy with rituximab vedotin and PD-1 blockade therapy. Regarding exclusion criteria, I'd like you to focus to one of the criteria, which is a history of neuropathy considered of autoimmune origin, such as polyradiculopathy, including Guillain-Barré syndrome and myasthenia gravis, or another CNS autoimmune disease. Here are the baseline characteristics of the patients. At the data cutoff in March 2021, the number of patients enrolled was 117. The mean number of cycles the patients received was 4.6. These patients, I must emphasize, were heavily pretreated. As you can see, the median number of prior lines of systemic therapy was 6. And practically all patients, as you can see, had received prior rituximab vedotin and PD-1 blockade therapy. Regarding the table with the characteristics, I'd like you to focus on the autologous stem cell transplant. Practically half of the patients had failed autologous stem cell transplantation. And if we look at the disease status after the last line of systemic therapy, you can see here that 56.4% of patients were refractory to the last systemic treatment they had received. Here we can see the overall response rate. It was 66.3%, as you can see, with 27.7% CR and 38.6% partial remission. A proportion of patients discontinued treatment because they went on to hematopoietic stem cell transplantation. These were 9 patients. I'll just report that of these patients, of these 9 patients, one died due to disease progression 1 year after a haploidentical transplant, while the other 8 patients were still alive and being followed up at the time of data cutoff. Now, if you look at the results in the context of the prior analysis, I will just, this is on the right-hand side, you can see the data I just presented. But if we go back to the phase 1 study on the left-hand side, you can see the overall response rate was 86.5%, which compares higher. But the median duration of study, study duration was 10.3 months. And if we go to the preliminary data of this phase 2 study, again, the follow-up was slightly higher, 6.1 months, and the overall response rate was 83%. So what the authors want to say here is that because patients were assessed for disease at the first time point was at 6 weeks, as you can see here, the responses, the red triangle corresponds to complete remission, the blue triangle to partial remission, and the black box to stable disease. But as you can see, at the time of the second assessment, many patients convert into PRs or CRs, suggesting that with more mature follow-up of the study, the overall response rate will increase. Here is the Kaplan-Meier curve of duration of response. It was not reached after a median follow-up of 5.1 months. Here you can see the progression-free survival, which was 9.2 months, but not achieved for patients who had achieved a CR. And here we can see the most common adverse events. Here you can see the on the left-hand side, adverse events that developed in at least 20% of patients. If we focus on the grade 3 or above adverse events in at least 5% of patients, those the adverse events that of note is hyperphosphatemia, micropapular rash, thrombocytopenia, anemia, and lymphopenia. Regarding dose delays or dose reductions, we can see that almost half the patients needed adjustment, and 13.7% of patients discontinued treatment due to toxicity. Now, what about the pyrrolobenzodiazepine-associated adverse events? As you can see here, of note, 65% of patients developed skin reaction or nail disorders, 26% developed liver function test abnormalities, and 12% developed edema or effusion. If we look at fatal adverse events, there were 3 deaths in the study. One was from myocardial infarct, which was considered not related to treatment. One due to respiratory failure, considered unlikely to be related to treatment. And one from adenovirus infection, again, considered unlikely to be related to treatment. Now, if we focus on the polyradiculopathy and the Guillain-Barré syndrome, you can see that 6% of patients developed one of these autoimmune neurological events. There were 2 patients who developed, as you can see, radiculopathy, and one developed polyneuropathy. In both of these patients, with appropriate treatment, they recovered, the adverse event resolved. While of the 5 patients who developed Guillain-Barré syndrome, in one, it resolved with appropriate treatment, but in 4 patients, the syndrome was still ongoing. So what are the conclusions? So in this study, we see favorable response rates in heavily pretreated patients who had failed rituximab vedotin and a PD-1 blockade agent. And with overall response rates of, as I demonstrated, of 66% and CR rate of 27.7%. And although the overall response rate data still continue to mature, though the duration of response was encouraging and not reached, and the time to event data continues to mature with time. Now, regarding the safety signals, compared to the phase 1 and the preliminary phase 2 results, the safety profile remains consistent with no new findings. And regarding the Guillain-Barré syndrome and the polyradiculopathy, it remains of concern and definitely warrants swifter countermeasures when we have patients who develop these symptoms. So we should be aware of this, and they should be rapidly treated with intravenous immunoglobulin, plasma exchange, and/or high-dose steroids. So this finishes all. Thank you.
Thank you, Dr. John, for excellent presentation.
Stop sharing. Okay.
Yeah, we'll just move to the Q&A. Okay, so there is no questions from the audience. Just here, one question. Okay, so predictor for response to nivolumab. So any like any patient that you could, for example, early relapse after autologous transplant, versus late relapse after autologous transplant. Any other predictors for response to nivolumab?
Well, if you're talking about the particular this specific study, there was no data analysis on this issue, but I think early or late responders, the response to immune checkpoint inhibitors is similar, I would say. Now, regarding predictors of response, apart from time to relapse, I mean, we know very well that immunostaining for PD-Ligand 1 can predict, and we know from Margaret's SHIP study that by FISH, if you patients who have amplification of the PD-Ligand 1 gene are more susceptible to responses, but we don't do this in clinical practice. I wouldn't say that there are any specific tools to guide us which patients will respond and which will not.
Okay, would you consider Nivo after allo in case of relapse after allo, after auto?
Well, the answer is yes. There's no contraindication to give nivolumab after allo stem cell transplantation. There have been some suggestions that it can exaggerate GVHD, in particular in patients who've been who had chronic GVHD or acute GVHD prior, but I don't think it's a contraindication. The answer is yes, I would give it.
Okay, so I think no more questions from the audience. Thank you, Dr. John. I think we're going to conclude this session, and we'll be back after 20 minutes after Al-Maghrib prayer, inshallah. Thank you.
Thank you.
Bismillah wa sallallahu ala Rasulullah. I would like to thank the organizing committee and welcome back to the third session. I would like to start by introducing myself. I'm Dr. Rula Mufti, medical oncologist, consultant in Princess Noura Oncology Center, National Guard Hospital in Jeddah. I'm an associate professor in King Saud bin Abdulaziz University for Health Sciences. I'll be co-chairing with Dr. Amal Al-Bayhani. She's a consultant adult hematology and BMT and the acting chairman of Department of Medicine in King Faisal Specialist Hospital, Medina. I will start by welcoming our first guest. Our first guest is Professor Stefano Luminari. He is a professor of medical oncology in the University and Hematology in the University of Modena and Reggio Emilia, and the head of the Unit of Clinical Research in Oncology Hematology at the Hematology Division in AUSL IRCC Reggio Emilia in Italy. He is the chair of Indolent Lymphoma Committee of Fonziani Italiana Linfomi. I don't know if it's right. And he is the legal representative of the European Committee of International Extranodal Lymphoma Study Group and the associate editor of Italian edition of Blood. Professor Luminari, please go ahead and start with your first presentation.
Thank you for the nice introduction. I'm now sharing the screen. Okay, I hope you can see it. So thank you for the nice introduction and for the very kind invitation. It's my second time in Saudi Arabia, the first virtual. The previous one was actually in person, and I enjoyed very much staying with you. Hopefully the next time. In my first talk today, I will provide you with an update of the content about indolent lymphomas that have been presented as oral presentation during the last ICML. There are 4 selected abstracts that were all presented as oral that you can see here. So the first paper is entitled Direct Acting Antivirus as Primary Treatment for Hepatitis C Virus-Associated Indolent Neonatal Lymphoma, the so-called BART study by the Fondazione Italiana that was presented by Dr. Merli from Italy. The rationale behind this study was mainly the strong and very well-known association between hepatitis C virus infection and a wide spectrum of B-cell lymphoproliferative disease, mainly including indolent lymphomas and mainly including marginal zone lymphomas. Apart from the epidemiological data, some interesting findings come from the acknowledgement and recognition that interferon-based antiviral therapy that was considered in past for the treatment of hepatitis C virus was also associated with response and not only with ACV eradication, so with lymphoma response. But in that case, the antiproliferative effect of interferon could have not be ruled out, so there is no clear role of the activity of more direct antiviral agents and their potential role as also therapeutic agents for the lymphomas. This has been addressed by some retrospective study, and this BART study is the first prospective, even if small study, that as a phase 2 study mainly included adult patients with any of the indolent lymphoma subtypes, not only including marginal zone lymphoma, but also considering lymphoplasmacytic, small lymphocytic, and follicular lymphomas. All the patients had to be HCV positive of any genotype. And for all the patients, the requirement was the lack of criteria to start immediate treatment, and shown in the box in the lower right part of this slide. The primary study was based on the assessment on definition of virological response, and the clinical response of lymphoma was included as a secondary endpoints in terms of overall response rate, but also in terms of efficacy assessing progression-free survival and duration of response. The treatment with antiviral agent was based on direct antiviral agents like ledipasvir and sofosbuvir or velpatasvir. The treatment was had to be prescribed according to the genotype, and the change in the treatment was based on the genotype and on the drugs that were used and on the duration of the treatment that was at different duration from 1 year or up to 2 years for the other genotypes to eradicate. These are the results of the study. 40 cases were included with 27 patients of the marginal zone subtype, including 6 splenic, 7 nodal, and 14 extranodal cases, and with other indolent lymphomas differently represented with the small numbers per single subtype. The median age was 68 years. As you can see, all the genotypes were represented, with genotype 1 and 2 for HCV being the most frequently represented, respectively in 16 and 28 cases. 11 cases also were positive for hepatitis B antibody, and some cases also concomitant problems associated with HCV infection like cryoglobulinemia. And in terms of the primary study endpoint, there was virological response. This was achieved in 100% of the patient, with most of the patient achieving also a very rapid virological response. 92% were already negative for HCV RNA detection after 4 weeks of treatment. And what was more important for us hematologists is the description of the clinical responses that were observed in 18% of the patients, thus defining an overall response rate of 45% of the patient. That was quite consistent among the different subtypes. Marginal zone lymphoma had an overall response rate of 48%. Non-marginal, the response rate was 38%. Difficult to say this different, but across the different marginal zone subtypes, the overall response rates ranged from 71%, the highest value observed in multiple lymphomas, to 43% in nodal marginal zone lymphoma, and to, I would say, an unexpected 0% overall response rate in splenic marginal zone lymphomas. Nevertheless, if you look, if you move from the definition of clear-cut response class, but if you look at tumor size reduction, you can see that most of the patient, 2 out of 3 thirds of the patient achieved some kind of size reduction that were observed in terms of nodal responses, 38%. Extranodal responses, 71% of the patient with extranodal did achieve a kind of a response that was complete in 43%. Splenic response that was observed in 30% of the patients. And in terms of the duration of response, of course, these are a very small group of patients, but you can see a duration of response that is at 3 years, 83%, so very encouraging. The second study is the ISG 38 study. There is a phase 2 trial of rituximab plus Corambus plus followed by a 2-year rituximab maintenance in multiple lymphoma patients. This study was presented by Dr. Pirosa from Bellinzona. The rationale behind the study is the experience, the huge experience achieved by the ISG group with the ISG 19 that defined in a randomized fashion rituximab plus Corambus without maintenance as the standard treatment option for multiple lymphomas. The study also allowed to define the multi-IPI prognostic scores and also allowed to validate the concept of POD24 in this patient population. But for what is related to this presentation, the new ISG 38 study tried to move over from this first finding to mainly to assess the role and the activity of subcutaneous rituximab, also in multiple lymphomas, and also to evaluate, even if not in randomized fashion, the role of maintenance in multiple lymphomas. This is the design of the study. Similar to the ISG 19, chlorambucil was prescribed in 2 steps, as well as the rituximab. Part A was chlorambucil daily for 6 weeks, combined with 4 weekly doses of rituximab, standard doses. The part B consisted of 4 monthly cycles of chlorambucil given for 14 days, associated with rituximab subcutaneous given at day 1 of each month, and followed by a part C that was maintenance with rituximab subcutaneous administered for 2 years in 2 months interval. The primary endpoint of the study was CR rate, but secondary endpoint also included overall response rate and duration of response and safety. 111 and 12 patients were enrolled. The median age was 65, 63% at an advanced stage, and the MALT IPI index was intermediate high in 71%. As you can see, most of the extranodal sites were represented as expected. Stomach was the most frequent extranodal site, being involved in 32% of cases, followed by the lung in 14% of cases, and other extranodal sites. The primary study endpoint, the results of the primary study endpoint, the CR rate is shown here. There was an overall 67% of CR observed in the long-term follow-up, with an increasing trend of CR rates that started to accumulate from the first time point. There was 6 months at the end of induction, and increasing at 18 months, and then the end of maintenance 67 months, suggesting that a kind of role of maintenance can be supposed in this setting. And this is the survival curve of the ISG 38 study, with a 5-year progression-free survival of 86%. And even if this is not a randomized comparison, it can be unfair for some of you. The comparison between the ISG 38 study that included maintenance with the previous ISG 19 study that did not include maintenance clearly show that there is kind of improvement of as a consequence of maintenance is probably suggested here. So the third study is a study that I was able to present in the oral session. It is a response-adapted post-induction therapy in follicular lymphoma with updated results of the FOL12 randomized trial by the Fondazione Italiana Linfomi. Mainly what the study tried to assess, I would say for the first time, is the hypothesis that using the quality of response defined with the PET and with molecular assessment could be used to decide about a different approach in patients responding to standard induction therapy. Looking at the study design, all patients with follicular lymphoma stage 2 to 4 and in need of therapy due to a high tumor burden had to receive a standard induction therapy, and then they were randomized to receive a standard approach that was rituximab maintenance for all patients regardless of the response. And conversely, in the experimental arm, patients had to be evaluated for the quality of their response to induction therapy, and the patient achieving a complete metabolic response that was defined by Deauville 1 to 3 at PET done at the end of induction. These patients were also evaluated for molecular assessment that mainly targeted T14/18 translocation with the NRQ PCR technique. In the patient with double negative, that is both metabolic and molecular negative, they were not treated with maintenance, but they were only observed. If a patient with complete metabolic response turned from a negative to a positive molecular status, this patient had to receive a weekly rituximab until negativity of the molecular marker was achieved, with the main aim here to try to delay and to avoid clinical progression that was anticipated by molecular relapse. And last, the non-complete metabolic response patient had to receive standard maintenance with rituximab after one single dose of radioimmunotherapy that was delivered with Zevalin. Patients with less than PR at the end of induction were sent off study and were managed out of the protocol. And looking at the results of the study was a non-inferiority trial that was designed with the hypothesis that the standard approach of a response-adapted post-induction management was non-inferior in terms of PFS compared to the standard maintenance therapy. This hypothesis was not achieved, and as you can see here from the first slide, as a first point, we were able to show that both molecular and metabolic response were prognostic, even if they were able to identify a small proportion of patients at high risk. 9.3% of the patients did not achieve a metabolic response, left panel, and 10.1% of the patients were not able to achieve a molecular response. And this patient had a worse progression-free survival compared to patients that achieved a complete metabolic and molecular response. But this is the results of the study that clearly showed that the hypothesis of non-inferiority between the two study arms was not achieved. Actually, patients treated with the experimental approach that mainly was represented by no maintenance had a worse progression-free survival compared to patients that received standard maintenance. That tells us that even if achieving a complete metabolic and molecular response is a good news, if you believe that PFS is a good clinical endpoint for the patient, you still need to prescribe and to administer standard maintenance to the patient. Luckily enough, even if the study was not powered to identify difference in overall survival, the randomized arm was not associated with a difference in the risk of death for the patient. And moving to the subgroup of the patient, we looked at the study results by randomized arm according to metabolic response. You can see here only patients achieving a complete metabolic response, that in this group, the main results of the study were confirmed, 628 patients. And the main study results were also confirmed in patients with the double negative molecular and metabolic response, as shown in the left panel. In the right panel, you can see the survival of the patient who were at complete metabolic response, but for whom the molecular analysis of response turned out to be positive. So the red curve represented the patient that even if they achieved the metabolic response, they had to receive weekly rituximab due to a positivization of the molecular marker during the follow-up. As you can see here, this preventive measure that was adopted in the study was not able to change and to modify the risk of progression. It was still poorer and worse compared to the outcome of the patient randomized in the standard arm. So finally, this study was basically the first study that addressed the response-adapted approach to follicular lymphoma patient, and was basically an indirect confirmation of the role of rituximab maintenance for patients who responded. This is one step back in the research of treatment personalization of follicular lymphoma, but there is a lot to learn from this study, and more data will be required from this study to understand the real role of treatment personalization and risk-adapted therapy in follicular lymphoma patients. And there's a complementary slide, a complementary analysis, as this is an indirect comparison, an indirect demonstration of the prognostic role and the efficacy of maintenance. Maintenance rituximab was basically confirmed in providing better progression-free survival after R-CHOP, and for the first time, even if not randomized, but in a prospective fashion, it was also confirmed after bendamustine rituximab, as shown in the right side of this slide. And last study that was presented was the immune priming with nivolumab, followed by nivolumab and rituximab in the first-line therapy of follicular lymphomas. This is a phase 2 study presented by Elizabeth Hawkes from Australia. I have to say that there are preliminary data about the use of checkpoint inhibitors in follicular lymphomas. There is one promising study of a combination of pembrolizumab and rituximab in relapsed refractory patients that was presented by colleagues from the MD Anderson with promising results, but more recent data about one single agent study of nivolumab in relapsed refractory follicular lymphoma patient wasn't able to confirm that nivolumab, so the checkpoint inhibition in follicular lymphomas, all comers, is a good strategy to achieve clinically significant responses and efficacy of the treatment. Nevertheless, this is a phase 2 study that for the first line approach of the patient with treatment-naive follicular lymphoma patient requiring therapy, started with the nivolumab single agent for 4 cycles, and then continued with nivolumab alone for a patient who achieved a complete response after the first induction phase. For patients that were not able to achieve a complete response, nivolumab was combined with rituximab to complete the induction phase of treatment and to continue with the post-induction maintenance phase for 12 weekly, for standard maintenance for 2 months for up to 2 years, and nivolumab for 12 cycles, with a total of 18 cycles in the maintenance phase. The primary endpoint in this study was safety, assuming a risk of grade 3 or more toxicity less than 70% during the induction phase, and secondary endpoint were other safety endpoints and response rate, progression-free survival, and overall survival. 39 patients were enrolled in this study. Median age was 54 years. Advanced stage was observed in almost all patients, with 67%, 2 out of 3 patients with a stage 4. B symptoms were present in 23% of the patient, and bulky disease in 23% of the patients. The FLIPI, the final risk was intermediate, high in 56% and 18% of the patient respectively. Out of the 39 enrolled patients, all the 39 started priming with rituximab for 4 weekly rituximab. 2 had to discontinue due to progressive disease. 2 patients achieved a CR and continued with nivolumab, a single agent, for the duration of the study. Other 35 patients added rituximab to nivolumab treatment and continued up to the maintenance phase. And overall, 26 patients were able to complete the treatment and started follow-up. Safety was the primary endpoint, and as depicted here, the primary endpoint of safety was met with only 16 patients, that is 41%, experiencing grade 3 or higher toxicity during induction. Overall, the safety profile of the combination of the nivolumab and of the combination of nivolumab and rituximab was quite well tolerated, with 13% of infection and with other grade 3 or higher events that are shown here that occurred sporadically in the patients. And regarding the immune-related adverse events, some of them were observed during treatment or at the end of induction after the stop of nivolumab. There were some grade 3 rash, grade 3 pancreatitis and hepatitis, and as well as some laboratory alteration as shown here. But overall, this is confirmed as a manageable and safe combination. And my last slide, just to remind the final results of the study in terms of the secondary endpoint response rate. Response was overall observed in 92% of the patient, with 22 patients, 56%, who were able to achieve a CR after the full program. Interestingly, 2 patients were able to achieve a complete response after nivolumab priming and were able to maintain the complete response during induction and maintenance, suggesting that even if checkpoint inhibition is not a treatment that should be considered for all comers follicular lymphomas, at least a group of patients with follicular lymphoma may benefit from the use of this therapeutic approach. The problem here is to identify with the biomarker who is the patient who is going to benefit from the treatment and to address the treatment to a more specific subset of patients with a more rational approach. With this, I would like to thank you for your attention, and I completed the overall overview of the indolent lymphoma oral abstract at ICML. Thank you very much.
Thank you, Professor Luminari, for this very elegant presentation. I don't have any questions, but I was wondering, in our practice in Princess Noor Oncology Center, we actually used to give maintenance rituximab after BR. It is our practice even before the fall 12 final results. So I was wondering, in your practice, were you doing that as well?
Yes. Yes. So we were the first to show in a prospective way the role of rituximab maintenance, but we were not the first to suggest the role of maintenance after RBR. So there were also already convincing data and that were in favor of an efficacy of rituximab maintenance after this approach. We do prescribe rituximab maintenance and anti-CD20 maintenance after beta-based immunochemotherapy. We only stopped and reduced the number of prescription because of the COVID pandemic, because we consider enough to complete a good induction and achieving a CR. And we consider too high the risk of severe COVID during a treatment that has the only role of prolonging PFS without any effect on the overall survival. Conversely, the risk of developing a severe COVID during rituximab therapy was real and was associated with a significant increase in the risk of dying from COVID. So only during COVID we stopped for a while the rituximab maintenance. Now that the people are vaccinated, we are starting again to prescribe maintenance.
Perfect. I think you have answered even the questions that I was going to ask. Thank you so much. I will hand to Dr. Amal Al-Bihani to present our next speaker. Thank you very much, Professor Menari.
Thank you.
Dr. Amal, you're on mute.
Thank you, Rula. Sorry, I wasn't. So thanks, Rula. Thank Dr. Luminari for this elegant presentation and overlight. And thanks SSPMT for this organization of great event. It gives me a great pleasure to reintroduce again Dr. Emmanuel Soki. He was presented before in previous session. Dr. Emmanuel, he's the head of the lymphoma medical and he's a medical oncology consultant at the Oncology Institute of Southern Switzerland. He's the group leader of the international extranodal lymphoma study group. And he will present to us about the aggressive extranodal entities. Please, Dr. Zoki.
Thank you for introducing me. I would now share my screen. Now I hope it's fine now, and I will speak about the aggressive extranodal entities, and in particularly the presentation we had at 16 ICML in Lugano, which mainly were devoted to two topics. The first one is lymphomas arising in immune-privileged sites, namely primary CNS lymphoma and primary testicular lymphoma. And the second topic is primary mediastinal lymphoma, which, as you know, is actually a tumor deriving from the B cell of the thymus. The first presentation by Dr. Mutter in Lugano from Freiburg was related to the use of ctDNA profiling for diagnosis and risk classification of CNS lymphomas. There are some background information which may be useful. You know that primary central nervous system lymphoma represent only less than 10% of all primary brain tumors, even if the incidence is rising because probably of the rising age of the general population. Also in immunocompetent patients. It is most frequently, if not often, if not always, a diffuse large B-cell lymphoma. Is treated with a combination including always high-dose methotrexate. Is typically aggressive with early progression, but also later recurrences. And we do not have reliable biomarkers for this lymphoma. On the other hand, ctDNA is a good biomarker for systemic diffuse large B-cell lymphoma, and where it seems to have a broad applicability and high sensitivity and specificity. The applicability, however, of ctDNA detection in CNS lymphoma has thus far been challenging because it is based on invasive and risky procedures to get primary biopsies, and because the ctDNA level in blood plasma is often very, very low. And this has thus far somehow impaired our possibility of using this technique for CNS lymphoma. However, it has been very recently developed as an ultra-sensitive ctDNA monitoring approach named phase ED sequencing instead of the standard CAP-seq, which is used for the rest of diffuse large B-cell lymphoma. And I do not go into the technical details of this very complex procedure, but this methodology seems to be much better. And the authors apply this new method for the detection of ctDNA in primary brain lymphomas. They were able, with the standard NGS approaches, to find somatic mutation in all tumor specimens, with a median number of mutation in each of the 67 patients analyzed of 324. As expected, the most common mutated gene was MDY88 in 74% of cases. These tumor mutations were monitored in baseline plasma and CSF by this novel FAST-ED technology, which allow detection of ctDNA in 78% of pretreatment plasma and 100% of CSF. Notably, the CSF concentration were nearly 8 times higher than those in plasma. And when you see in this chart the concentration, the positivity of ctDNA is plotted against the tumor volume in magnetic resonance, you see that there is a significantly higher volume of the tumor for ctDNA positive cases, and the ctDNA concentration rise up at the growth of the tumor volume. So plasma liquid biopsy mirrors tumor burden. And this reflects a possible separation of two different subsets of patients with good or poor outcome according to the level of ctDNA. ctDNA positive patients have a clearly inferior survival in comparison with ctDNA negative patient at baseline, both for progression-free and overall survival. And ctDNA concentration was confirmed in multivariable Cox models to be independently predicting outcome, controlling for the main clinical parameters, either for progression-free survival or for overall survival. When pretreatment DNA concentration was used integrating this information with the information from magnetic resonance about the tumor volume, you see here that patients with both a negative ctDNA and low tumor volume have an excellent overall survival, with those with both high tumor volume and elevated detectable ctDNA have a very poor outcome. And then the hypothesis raised by the authors was, can we use this data, this approach, which is very prognostic, apparently also for improving our diagnostic capacity? Can, in other words, central nervous system lymphoma be diagnosed without surgery based on ctDNA mutational profiles in plasma or CSF? And they used a machine learning algorithm based on the study of 35 tumor samples of CNS lymphoma and more than 2,700 of non-lymphoma brain tumors. This algorithm correctly classified CNS lymphoma in nearly all biopsies, in more than half CSF samples, and in 20% of plasma samples. Notably, there were no false positives in the CNS lymphoma classifications. So this classifier was apparently very good in recognizing CNS lymphoma with no need of biopsy. And the author proposed this diagnostic flow to use initially ctDNA in plasma and CSF to classify the tumor, if there is a diagnosis of CNS lymphoma disease properly and adequate according to the data seen before, with 100% of sensitivity and good specificity. And for those not classified as lymphoma, a biopsy is then needed to discriminate between lymphoma and other tumors. In conclusion, the ctDNA with this novel phase ED sequencing has a very high detectability in CNS lymphoma, mirrors tumor volume, and has a prognostic value. It can be also useful for allowing a surgery-free diagnostic procedure. This was, in my opinion, a very important study, and the next presentation was done by Professor Andres Ferreri on behalf of the International Extranodal Lymphoma Study Group, the group I am actually a member and actively involved with. This is the long-term 7-year follow-up of a randomized study for primary CNS lymphoma, which was a study, the ILG32 study, which was based on 2 randomizations. The first one was addressing whether we can improve on the backbone of high-dose methotrexate and cytarabine by adding rituximab and or tiotepa. And the second randomization was for responding patient to the first-line induction. The randomization addressed the best consolidation with whole brain radiotherapy versus autologous transplantation with a CNS-driven, CNS-based conditioning. This is the consort statement of the study. We had 219 patients from 53 centers in 6 countries. And at the end, we have 69 patients responding randomized to whole brain radiotherapy, and the same number randomized to autologous stem cell transplant. The study was showing that the addition of both rituximab and thiophepa to methotrexate and cytarabine was the best regimen, the so-called matrix regimen, which is now our standard, and that for responding patient there was no clear difference between consolidation with autologous transplantation or radiotherapy, but radiotherapy was in our cohort characterized by cognitive and psychological side effects, which were not present in the transplant arm. The presentation of Ferrer was focused on this 7-year follow-up, and first he showed that the non-related mortality and the second tumor rates were not actually different in the patient receiving autologous transplantation and or radiotherapy, and they were not depending on the initial treatment arm. Moreover, at a much longer follow-up, the data about the activity of the matrix regimen were fully confirmed, and as well as the lack of significant difference between radiotherapy and transplantation, even if radiotherapy seems to have in these survival curves a slightly better, not statistically significant profile. Radiotherapy was associated with some impairment of the attention executive test, of the memory tests, and also in quality of life questionnaires. Whilst patient treated with the best regimen matrix plus consolidation, irrespectively of consolidation, had a 7-year OS of 70%, which is a very good result, a long-term result for this high-risk subset of patients. In conclusion, the excellent long-lasting survival in patients younger than 70 years was seen and confirmed after therapy with matrix regimen, with similar efficacy of the two consolidation arm, but specific cognitive function impairment after radiotherapy, without evidence of increased non-related mortality or second cancers after matrix and autologous stem cell transplant. Then let's now go to another ILG study, the ILG 30 study, presented by Dr. Conconi from Novara, which was dealing with an intensified intravenous plus intrathecal prophylaxis in primary testis lymphoma, again with long-term results. The background for this study was the prior ILG 10 study published in 2011, which showed that using 4 doses of intrathecal methotrexate plus 6 cycles of R-CHOP and contralateral radiotherapy, we can virtually eliminate any relapse in the contralateral testis, and we can reduce to 6% the cumulative incidence, which was over 30% for CNS relapses on the long term in historical series, and also have a 5-year progression-free survival very close to the rest of diffuse large B-cell lymphoma. Somehow dramatically improving the historical result for this subset of tumors. And the aim of the current study, LG30, presented by Conconi, was to demonstrate safety, feasibility, and efficacy of an intrathecal liposomal cytarabine plus intravenous high-dose methotrexate, intermediate dose methotrexate, as a prophylaxis for primary testicular lymphoma in order to achieve a long-term PFS improvement. And the inclusion criteria were identical to those of the prior study. And this is the approach. After 3 cycles of R-CHOP, there was an interim restaging. Liposomal cytarabine was given concomitantly with the second, third, fourth, and fifth cycle of R-CHOP. And intravenous methotrexate 1 gram per square meter was given at the end of the planned chemotherapy, followed by contralateral testis irradiation. The approach was feasible. 54% had 3 doses, 54 patients had 3 doses of cytarabine intrathecal, and at least 4 cycles of CHOP. 51 patients completed the R-CHOP treatment, and only 2 patients didn't get the 4th dose of cytarabine. Systemic intravenous methotrexate was given to 48 patients for at least 1 dose, and to 45 for the full program. Radiotherapy was possible and given as planned to 50 patients. So overall, in this elderly population, this regimen was feasible, and progression-free survival at 5 years is 91%. Overall survival is 92%. And we have a 5-year incidence of progression of 6%, but 4 out of the 7 relapses observed after were observed after more than 6 years from diagnosis, and no CNS relapse was seen so far. Toxicity of intravenous methotrexate in this elderly population was overall acceptable. And in conclusion, this program was feasible, well tolerated, and showed a clear improvement in comparison with the IG-10 result using only intrathecal prophylaxis. Late extranodal relapses are still a clinical challenge. Now, let's go to the last topic, primary mediastinal B-cell lymphoma, which is a unique disease characterized by thymic origin, by a molecular profile closer to classical Hodgkin lymphoma than to diffuse large B-cell lymphoma, presenting with usually with bulky single mediastinal masses, very difficult to be salvaged when relapsed, but also highly curable if proper frontline therapy is given. There is a question which has never been solved by a prospective study, is whether radiotherapy is needed in all the patients to consolidate initial chemotherapy, and whether we can use PET to decide about the necessity of radiotherapy. There are at least 3 large retrospective series showing that radiotherapy can be spared by in patients with a complete metabolic remission on PET scans, but the ILG37 non-inferiority study is the only one study which addressed in a formally prospective design this question. We cannot yet provide the answer to this primary endpoint of the study, whether or not radiotherapy is really needed in patients responding to induction chemotherapy. But in Lugano, we presented data about the metabolic response after immunochemotherapy, and we see 4 different regimens. 4 regimens were used in the large majority of cases, and namely R-CHOP standard or every 3 weeks, R-CHOP dose dense, R-CHOP 14 every 2 weeks, rituximab plus MACOB or VAPEC-B, and dose adjusted EPOCH-R. You see here that the response at the end of induction chemotherapy was significantly poorer for patients receiving R-CHOP 21, and this reflects in a clearly inferior event-free survival. In comparison with the other regimens, patients with R-CHOP 21 didn't show any particularly different risk factor. And this difference in event-free survival was also present in progression-free survival, and there was a trend for a worse overall survival as well. At multivariable analysis, R-CHOP 21 was the only significant predictor of outcome. In conclusion, dose-dense and dose-intense regimens appeared better than R-CHOP 21. They may reduce the number of patients in need of additional therapy. And we didn't see any difference between R-CHOP 14, MACOB or VARCOB or dose-adjusted EPOCH-R. So for us, R-CHOP 14 remains appears to be the easiest and simplest induction regimen to be offered to the patient, but also the other two regimens are extremely active. Similar data were also shown by this study from the LISA French group. They had a population of 313 patients with diffuse large B-cell lymphoma, receiving for the vast majority the standard French ACVBP regimen for aggressive lymphoma, sometimes with obinutuzumab instead of rituximab. The other had either R or G-CHOP 14 or R-CHOP 21, which was given to a group of patients which were a bit elderly than the rest, and however with better prognostic international indices. The CNS prophylaxis was given to the majority of the cases overall, and consolidation with autologous host radiation therapy was given to a small subset of patients. In particular, very few patients had radiation therapy in this population, and very few patients had consolidation transplantation in the arm with R-CHOP 21. Anyway, the data about the activity of single induction regimen are very, very similar to the ILG ones, with a clearly inferior progression-free survival and also overall survival for patients treated with R-CHOP 21. So the take-home message for these studies, from these two studies, is R-CHOP 21 is suboptimal and should no longer be recommended for the initial treatment of primary B-cell lymphoma. Now let's go to the last presentation I have to summarize, which is again in primary mediastinal lymphoma. This peculiar tumor is characterized by a specific chromosomal and genetic alteration, and the JAK-STAT pathway is deregulated in most cases, implying and suggesting that a positive control of PD-1L and PD-L2 expression, PD-L1 and PD-L2 expression is present. Therefore, also CD30 is expressed in most cases, and therefore brentuximab vedotin can be used to target CD30, but also for the priorly described alteration, checkpoint inhibitors may be useful to restore the immune control. And in future, we may also explore the activity of JAK inhibitors in this subtype of lymphoma. In this context, Pierluigi Zinzani presented updated results of the CheckMate 436 study, a phase 2 study of the combination of brentuximab vedotin, anti-CD30, plus nivolumab, PD-1 inhibitor, in relapsed refractory primary mediastinal lymphoma. This is an upgrade and an update of data already published by Zinzani earlier on JCO at the end of 2020. which showed an impressive rate of good responses, maintained, sustained good responses with this combination, which was somehow surprising because in spite of very good phase 2 data with pembrolizumab in this disease, which is another PD-1 inhibitor, brentuximab vedotin alone provided very disappointing results. You know that these are data from Kuruvilla in Toronto, that the patient with primary mediastinal lymphoma do respond much worse than the rest of diffuse large B-cell lymphoma to salvage therapy, including autologous transplantation. So there is really a need of better salvage treatment. This is the design of the study: 240 milligram IV every 3 weeks of Nivo and brentuximab 1.8 milligram per kilo IV every 3 weeks until progression or unacceptable toxicity. And the response, the good response rate, and the excellent duration of response with median of 32 months and a non-reached median duration of complete remission was confirmed. Moreover, 4 patients remained progression-free from very long time, from 137 up to days up to more than nearly 2 years after the last dose of the combination. The patient had subsequent radiotherapy in 8 cases or high-dose consolidation in 5 patients, 4 before and 1 after radiotherapy. Of the 22 responders, 12 in addition received subsequent stem cell transplant, either autologous or allogenic. And this is the progression-free survival, 26 months as a median and 56% at 24 months. But notably, overall survival, which is including also the results of transplantation, is very good, 76% at 2 years, much better than the historical data of Toronto. Toxicity was manageable and not unexpected. 5 of the 8 deaths were from disease progression. No deaths were considered treatment-related, and we didn't have any new safety signals for this type of treatment. And considering that 4 patients remained disease-free without need of additional consolidation, we can say that the combination of Nivo and brentuximab vedotin appears to be synergistic and is highly active in this group of relapsing patients. I will stop here and thank you for your attention.
Thank you, Dr. Zoka, for this excellent highlight, challenging topics. You can hear me, right?
Yes.
So we have 2 questions submitted. Please submit your question to the Q&A icon. So the first question is why there is no difference in overall survival and progression-free survival between the autologous stem cell transplant and radiation in matrix study, while the difference had been shown in the previous trial. What do you think?
I am not sure I got the question was comparing the result of the ILG study with
So why previously the result showed that there is no superiority for autologous, for autologous no difference between overall survival, progression-free survival between auto stem cell transplant and radiation in the matrix. The difference had been shown in previous trials or no?
No, this was also this was never directly compared by other studies. So this is the only study which was randomized in radiotherapy versus transplantation. Now there is also French data suggesting that autologous is which were generated in the meanwhile, which are suggesting that autologous is better than radiotherapy. We didn't see this superiority, but overall we would also recommend autologous consolidation because it is safe and has no has less impact on long-term quality of life and neurological capacity.
Thank you. Do you deal, the second question is, do you deal with a patient with diffuse large B-cell lymphoma stage 4E with testicular involvement as primary testicular diffuse large B-cell lymphoma from a perspective of removal of involved testis and the contralateral and the radiation for the contralateral testis?
I think, yes, even if I understand properly the question, I can say that we believe that orchiectomy and contralateral irradiation is part of the therapy also for disseminated lymphomas involving the testis, as well as CNS prophylaxis. Was that the question?
Yes, that's the answer. So we have one question from Dr. Dada. He's raising his hand. He's from the panel. Dr. Dada, please go.
Thank you, Dr. Abel. Thank you, Dr. Soka. And I have exact question to testicular lymphoma. We know this is the disease of elderly patients, but occasionally we are seeing indeed young patients. I have a patient who is in the 20s, and he has both testicles are involved, unfortunately. So not only one testis, and if he has one testis, we remove the other and radiate the other. So what shall we do? So shall we remove both for these young patients, or is there any way to avoid that?
Well, the alternative is to give radiotherapy to both testes, and even at low doses, you anyway will kill all the Leydig cells. So some endocrine replacement will be anyway needed after therapy. I think it is a very difficult question, and then you should find out a personalized approach discussing with the patient. But I think that if you do not remove the testis or the primary lymphoma, then you cannot hope in any cure. Particularly if this is localized, and
it is localized.
There are no data on adequate penetration of chemotherapy across the albuginea. For me, this is really a sad, extremely rare, but sad setting, and I may accept that you can replace surgery with radiation, but this would have a cosmetic and psychological effect, but not a functional, a real great functional benefit.
Okay, thank you very much. So you, as a difficult question, I know that's why I'm asking you as an expert. You favor removing both testes and replace.
But you can have at the end the same effect, keeping the testes there and giving radiotherapy to both testes.
Thank you.
So this might be psychologically more acceptable by the patient. And anyway, either in both cases you should give testosterone and endocrine replacement later. In a young patient, I would just say that I would also have a careful revision of the histology for a young patient, because sometimes seminoma is misdiagnosed with lymphoma and vice versa, and testis lymphoma is rare in young patients, with an exception of rare but curious that most young patients have follicular lymphoma in the testis, not diffuse large B-cell lymphoma. And also for this reason, I would recommend to have the specimen revised by an expert pathologist.
Thank you very much.
Thanks a lot. Dr. Mubarak, are you raising your hand for a question? Or?
Yes, thank you, Dr. Rahman. Thank you, Prof. Zuka. Two quick questions. I know the time is almost for the second talk. So the first about the role of the consolidation radiotherapy. Is there any data on just giving a whole brain radiotherapy post-matrix protocol or waiting until a time of relapse? Because you've mentioned about the toxicity, especially into the young patient. That's the first question. The second, radiotherapy in a primary mediastinal large B-cell lymphoma post 6 cycles R-CHOP with a PIT negative end of therapy. Do you still consider it part, or do you think that even with the PIT negative is still suboptimal compared to other protocols?
First, the second one was for primary mediastinal lymphoma, right? The
yes.
Second part of the question, yes. Okay, first, the CNS lymphoma. There are data for omitting radiotherapy, which were actually forwarded, particularly in elderly, by the community for an historical large German study, which had, however, several structural pitfalls in the design. But I understand that in people over 70 or over 65 in complete remission, omission of consolidation radiotherapy might anyway be consistent with a good outcome without neurological impairments. This at present, the question whether or not to give radiotherapy, however, was not clarified by the study. And the radiotherapy at the time we designed the ISG32 was formally the only one consolidated and needed consolidation approach. There is another point which we use the dose of radiotherapy in accepted as a standard 10 years ago when the study was designed. Today there are growing data from the US that you can have a good consolidation using only 23 grays to the whole brain with much less neurological toxicity. And this has not yet addressed, never tested or confirmed in a randomized design. So you should also try to put all the information coming from different studies in the proper context, and at the end, the decision whether or not to give radiotherapy to the individual patient outside a clinical trial has to be done together with the patient, taking into account all those type of information we have. The second point, radiotherapy for PET negative primary mediastinal lymphoma. There are 3 retrospective series. The first was the series from Professor Zinzani in Bologna. The second was the series from the group of Loris Sen in Vancouver. And the third has been published few weeks ago. Is the French series described by Dr. Camus in Lugano. All those series are suggesting that patients in complete metabolic remission at the end of chemotherapy might be spared irradiation. And all these series are confirming our retrospective, our prior, not retrospective, but prior ISG26 study, indicating that also patients with Deauville score 4 at the end of treatment may have a very good prognosis. Then, within 1 year, we will be able to analyze the large randomized study, and this will provide the final and definitive answer to your question. We will be or not able to say that radiotherapy is not to be given to a PET negative patient on the basis of a randomized trial and long-term observation, because now we are ready to analyze this study data with a minimum follow-up of 5 years after diagnosis, and we already know from prior studies that there are very few events after 2 years. So the final question will have an answer in 1 year from now, hopefully.
Thank you. Perfect.
Thank you, Dr. Zokas. There are a few questions in the Q&A icon. I think because of the sake of time, we'll leave it to Dr. Zokas. He can answer and type the answer for that, if you don't mind. And we'll move to next.
I can. If you send the questions to me by email, I will answer to them. If the organizer can send me all the questions in one email, and I will provide individual answers.
Yes, thank you. Thanks for
You're welcome.
Thanks for answering all the questions. Rola, please. Thank you.
Bye-bye.
Thank you, Professor Zuka. I will move to our next speaker. He is a dear friend and a colleague, Dr. Ahmed Absi. He's a consultant and a section head, the section head of adult hematology and bone marrow transplant in Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah. He's an assistant professor of hematology oncology in King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. I will leave you with the talk of Dr. Absi.
My name is Ahmed Absi. I'm the Hematology Bone Marrow Transplantation Section Head from Princess Noura Oncology Center in King Abdulaziz Medical City, Jeddah. I would like to thank the organizing committee for this opportunity to present two of the abstracts presented at the recent ICML conference. My first abstract was titled Early PET Scan Response Adapted Treatment in Localized Diffuse Large B-Cell Lymphoma, Age-Adjusted IPI of 0, Results of a Phase 3 LYSA LNH09B trial. As we all know, that early-stage diffuse large B-cell lymphoma therapy was dictated by several trials, some of which Phase 2 and some of which were Phase 3. Worth noting here, the SWAG 0014, which was almost the first study that innovated the 3 cycles of R-CHOP, followed by involved feed radiation therapy. It was a Phase 2 trial, which carried an excellent progression-free survival and overall survival for patients with early stage and low IPI score. Other studies that are worth mentioning, including the FLIER trial, which was a Phase 3 R-CHOP for 6 cycles versus R-CHOP for 4, plus 2 extra Rs, so comparing 6 versus 4, and patients less than 60 years old, age-adjusted IPI of 0, and non-bulky disease. This was an equivalent both arms. Also the LISA German trial, which was published in Blood 2018. It was a 2x2 design, PET-guided therapy of 4 to 6 cycles of R-CHOP plus minus radiation. Again, it included patients with early stage disease, non-bulky, and it shows equivalency in 5-year event-free survival of 89 versus 92 and overall survival. So these trials all set the stage for this current analysis. So the background is that R-CHOP21 is the standard treatment for diffuse large B-cell lymphoma patients based on previous studies. 6 cycles without radiation is the reference. In the 2019 FLIER trial, 4 cycles of R-CHOP21 could be as effective as 6 cycles in the younger population. And in early PET scan, directed therapy is effective to drive treatment for patients with diffuse large B-cell lymphoma and age-adjusted IPI score of 1 or more. So the aim of this study is to ask one question: are 4 cycles of R-CHOP non-inferior to 6 cycles? in limited stage CD20 positive diffuse large B-cell lymphoma and age-adjusted IPI score of 0. It was a randomized phase 3 trial conducted mainly in France and Belgium for patients both young and elderly. This was comparing both arms, standard arm, which was basically 6 cycles of R-CHOP for patients with early stage disease, if as long as they're PET negative after cycle 4. But the experimental arm, which was PET directed after 2 cycles, so patients who are PET negative after 2 cycles would get 2 more cycles only, so total of 4 cycles. And patients who are PET positive after 2 cycles will get 4 more cycles of R-CHOP as long as they are PET negative after cycle 4. So it included patients again with age-adjusted IPI score of 0 and limited stage disease. The primary endpoint was 3 years of progression-free survival. Secondary endpoint was overall survival and other response rate. It included almost 650 patients. It opened in 2010 and the study closed in May 2020. And median follow-up was 5 years. This is the 2 arms of the study. A standard arm enrolled almost 331 patients, experimental arm 319 patients, and it was well balanced between young and older patients, well balanced between gender, majority were males, very few bulky disease, the majority non-bulky disease, and almost all stage 1 and 2, but there were almost half of the patients having extranodal disease at the time of randomization. This is the extranodal disease included in this trial. It included everything, with the majority of being in the head and neck area, mostly tonsils. So we come to the trial, to the results. Progression-free survival, intention to treat. There was no difference at the 3 years between experimental arm event progression-free survival and the standard arm progression-free survival, both of which were almost 90% plus. The per protocol, again, there was no difference between both arms. How about overall survival? There was no difference between both arms. How about the progression-free survival by age? There was no difference in patients less than 60, but in patients more than 60, there was favoring patients on the experimental arm, the patients receiving less chemotherapy, with inferior progression-free survival of the standard arm at 86.3%. How about PET results? So PET was negative, achieved PET negativity and achieved in more than 80% after 2 cycles and almost 90% by 4 cycles. How about PET negativity results after 2 and 4 cycles? For patients who are PET negative after 2 and 4, there was no difference between both experimental and standard arm. How about patients who are PET negative after 2 but became, PET positive after 2 but became PET negative after 4? Again, there was no difference between both arms. How about patients who are both PET negative, PET positive after 2 and after 4? Who are still PET positive after 4? Obviously, they did inferior anyway, but there was a favoring of the experimental arm in that trial, probably only because of those patients selected earlier to be off the protocol. Progression-free survival, if you pool the whole population together, patients who are PET negative after 2 was 94%. Patients who are PET positive after 2 but negative after 4 was 88.7%. And patients who are PET positive after 4 was inferior at 67.6%. Toxicities were more in the standard arm, obviously because patients are receiving more chemotherapy, mostly in both hematological toxicities, GI toxicity, and peripheral neuropathy. How about deaths due to toxicities? There were almost none. There was only 1 death in the standard arm that was related to toxicity. but this occurred in patients above 60 years old in the standard and experimental arm, but mostly in the standard arm because of concurrent illnesses. And why is that? I don't know, but it's probably explained that those patients received more chemotherapy and they have more comorbidities. How about relapses? Was in the standard and experimental arm, the site of relapse was the initial site, mostly in the experimental arm. But new sites was balanced between both arms. And how about the time of relapse? We note that there were relapses noted almost up to 7 years to almost 10 years after the initial therapy. So the conclusions, this study demonstrates a non-inferiority of the 4 cycles of R-CHOP versus 6 cycles of R-CHOP for early good responders, confirming that R-CHOP could be the new standard of care of the large majority of limited stage diffuse large B-cell lymphoma patients regardless of age. Occurrence of late relapses shows the need of long-term follow-up for all patients, even if outcome is very good in this population. My second abstract was called Relapses in the Interim PET Negative Limited Stage Hodgkin Lymphoma Patients Receiving ABVD with or without radiotherapy, analysis of the H10 and RAPID UK trial. So what was the H10 trial? We all know that trial. It was published in the JCO of 2017. Let's remind ourselves about the H10 trial. It was intended for patients with early stage disease, both favorable and unfavorable. So for the favorable, they would get the standard arm of 3 cycles of ABVD plus radiation and the experimental arm of 4 cycles of ABVD as long as they are PET negative after 2 cycles. In the H10 unfavorable, they would get a total of 4 cycles of ABVD plus involved feed radiation therapy. And in the experimental, they will get 6 cycles of ABVD if they are PET negative after 2 cycles. This is the unfavorable criteria. It's the standard EORTC criteria. And the other arm of escalated BECOP is out of interest. The results of the H10 trial showed that patients with favorable had a better outcome if they received the combined chemo radiation therapy arm from progression-free survival point of view. And in the unfavorable, there is no difference between both arms. How about the RAPID? The RAPID was randomized interim PET negative patients. So after 3 cycles, if they are PET negative, they would get more further therapy. If they are PET positive, if they are PET negative, they were randomized between no further therapy versus 30 grays involved feed radiation therapy. In the RAPID trial, there was no difference in intention to treat analysis between both arms, between radiotherapy and no further treatment, but PP analysis showed that patients receiving radiotherapy had better progression-free survival with a hazard ratio of 2.36 and P value of 0.02. So what actually explains the difference of outcome between both arms? Well, first of all, the things related to patients as well as therapies. H10 patients included patients with bulky mediastinum and or B symptoms included versus RAPID patients with bulky mediastinum or B symptoms were excluded. Interim PET performed after 2 ABVD cycles in the H10, but RAPID interim PET was performed after 3 ABVD cycles. Interim PET negative patients received 3 to 6 cycles of ABVD versus in the RAPID, the interim PET negative patients received only 3 cycles of ABVD. And for PET results, IHP criteria was the reference in the H10, but the vial was in the RAPID. And the radiation arm in the H10 was 30 grays plus boost. In the RAPID, there was only 30 grays involved feed, not involved node without boost. The additional findings also there were different in the H10. Omitting RT showed an increase in early relapses but not late, and mostly occurring in initially involved areas. And there was in the analysis showing male gender plus stage 2 disease are adverse prognostic factors. In the RAPID, the only adverse prognostic factor was the maximal tumor diameter. There was no mentioning about early versus late, and no mention about the initially involved versus others in the RAPID. So to validate, they actually lumped all patients together. This is the whole group of both H10 and RAPID in favorable and unfavorable, both arms. So let's look at the results and how about the time of relapses for all patients. In the H10 patients, early relapses was majority in the chemotherapy arm alone. Late relapses was well balanced between both. How about RAPID? Same thing. Early relapses was majority seen in chemotherapy arm alone. So early relapses was majority in the chemo alone arm. How about time of relapse? Time of relapse, again, in the favorable, if you only look at the favorable, sorry, again, both in the early relapses as well as the late, because there were almost no relapses in the chemo and radiation in the H10 arm. And similar idea was in the RAPID, although there were more relapses seen in the late relapses in the radiation arm in RAPID. How about the site of relapses for all patients? In the H10, there was the majority of relapses in the chemotherapy arm was in the initially involved. In the RAPID, again, the majority of relapses in the chemotherapy was the initially involved, although the chemotherapy alone arm in the RAPID was for all relapses, both initially involved and initially involved, was more in the chemotherapy arm. How about site of relapses, favorable group? If you look only at the favorable group for the site of relapses, you find again in the H10 what was in the initially involved, and in the RAPID was also in the initially involved in the chemotherapy arm, but both initially involved and uninvolved was again more seen in the initially involved. How about gender? Well, there was inferiority for males with the H10, but no gender significance in the RAPID. So in the H10, the female gender was associated with a hazard ratio of 0.42, but in the RAPID it was non-significant. Lumping both together, there was still inferiority of the males, with the females associated with a hazard ratio of 0.49. How about the stage? Patients with stage 2 had an inferior outcome in the H10, but that was not seen in the RAPID, again with a hazard ratio of stage 2 of 2.26 in the H10 and non-significant in the RAPID. Lumping both together, it was also non-significant, although mildly above D1. So in conclusions, in patients with limited stage Hodgkin lymphoma who are interim PET negative after ABVD, omitting radiotherapy results in what? Number one, it results in an increase in less than 2 years relapses, but not in late relapses, mostly including initially involved areas. They were unable to prove the negative prognostic impact of male gender and stage 2 disease noted in the H10 in the group of patients enrolled in the RAPID trial, although the direction of the effect of gender was similar on both studies. Thank you very much, and that would end my presentation. Thank you.
So we'll pass on to the second presentation of Dr. Absi.
Done.
بس ما في شاشة بعدين.
Yes, so we will move to the last presentation of the session. It's the last abstract will be presented by Dr. Musa Zahrani. Dr. Musa Zahrani is a consultant hematologist and and assistant professor of medicine and hematology at King Saud University, King Saud University in Riyadh. He is a graduate of British Columbia, and he will be presenting the abstract about the title, the combination of venetoclax, lenalidomide, and rituximab in patients with newly diagnosed mantle cell lymphoma induced high response. Please, Dr. Musa.
Thank you very much. And I would like to thank the organizers for giving me the opportunity to present today. And so we'll talk about this result of phase 1 trial. Combination of venetoclax, lenalidomide, rituximab in patients with newly diagnosed mantle cell lymphoma. So the R-square, lenalidomide, rituximab, in addition to venetoclax. So as we know, mantle cell lymphoma is a rare type of non-Hodgkin lymphoma that constitute about 5 to 6% of newly diagnosed non-Hodgkin lymphoma. It remains incurable, and usually we think about patients in a dichotomized kind of way in the young fit patients, where typically they receive intensive kind of therapy that usually contains autologous transplant, versus the elderly and fit patients who typically get treated with immunochemotherapy. So for example, rituximab plus CHOP or BR kind of regimen. So the group from Cornell previously demonstrated that the combination of R-square was very effective in mantle cell lymphoma. And the long-term data of that showed that the remission was durable. Okay, we also know that venetoclax is an oral BCL2 inhibitor that is approved recently for patients with CLL, as well as for patients, not the relapse as mentioned there, but for the newly diagnosed AML who are elderly patients or cannot tolerate intensive chemotherapy. And we know that there was a study looking at the efficacy of venetoclax in relapse refractory mantle cell lymphoma that showed that venetoclax is effective. There's also a preclinical data that showed the synergy between lenalidomide and venetoclax. So in the study, they hypothesized that the combination of venetoclax and R-square regimen could be safe with potential to improve the overall response rate. And basically, as a phase 1 trial, basically they wanted to show that this regimen is safe and to try to find the maximum tolerated dose and toxicity in this regimen. They also looked at MRD status in these patients. So this is the protocol of patients. So untreated mantle cell lymphoma who require treatment were included. And we can see that there were 12 planned cycles of lenalidomide plus rituximab and venetoclax. We will talk about the doses in a few slides from now. And then after that, PET scan and MRD testing was tested after cycles 3, 6, 9, and 12, followed by a maintenance protocol that I will discuss later in details. In terms of MRD, they used basically the immunoglobulin PCR-based multiplex and next generation sequencing for the immunoglobulin gene. So the induction that had 12 cycles of treatment included rituximab, and it was given weekly in cycle 1, then every other month thereafter. And for patients who were felt to be at high risk for infusion-related reaction at the beginning, the rituximab could be delayed until at least day 22 of the first cycle. Lenalidomide was given as the usual doses for 21 days of a 28-day cycle. Venetoclax was started on day 8 of cycle 1 at a lower dose of 50 milligram, and then was escalated until basically the drug-limiting toxicity of a dose of 400 milligram when it was reached. And then maintenance was 3 years with plans to drop agents as discussed here. So rituximab given every other cycle for 36 months, lenalidomide reduced by half of the induction dose and continued for 2 years. And then venetoclax was continued for 1 year. So 28 patients were treated, and 19 of them completed induction and transitioned to maintenance phase. And one patient in the CR was off in the induction due to other medical issues. However, 3 patients basically had progressive disease, and 2 patients were off the trial related to other medical conditions. One of these patients had melanoma, and another one adenocarcinoma of unknown primary. So looking at the characteristics of these patients, so the majority of them were male, as expected. The mantle cell is more common in male. And all of the patients were Caucasians in ethnicity. And the median age was 65 years. And the ECOG performance status was 0 to 1 in the majority of patients, and advanced stage in all patients. Bone marrow involvement was common in 26 out of 28 patients. And the MIPI score was high in 18 patients and intermediate in 10. So 4 patients had blastoid variant, 2 patients had pleomorphic variant, and the Chi67 was more than 30, which is considered the high risk in mantle cell in 19 patients. So a lot of these patients were high risk, and P53 was detected in a few patients, so 7, 2 deleted and 5 mutated. The cytogenetics were normal in the majority of patients and abnormal in 8 patients. The disease detected in peripheral blood in the majority of patients by flow cytometry, and 3 patients were unfit or ineligible for high doses chemotherapy. So the median duration of treatment was 308 days. The median number of cycles was 11 cycles. Dose reduction or delays happened in 15 patients, or 53%. And there was a dose reduction in venetoclax, lenalidomide, in about 28 and 18% respectively. And those discontinuation due to side effects happened in 6 patients, and 4 of them were in venetoclax arm. As we can see here with the response, as the treatment went on, the rate of CR increased over time. So from 67% at 3 months to 78% in 6 months, and then 94% in 9 months, and then all patients responded at 12 months. So this is very impressive. Now, looking at MRD status, again, the MRD status is also very impressive. Looking at this graph, you can see that MRD response rate increased over time from 63% MRD negative in 3 months to 77% in 6 months, then 94% in 9 months, and 92% in 12 months. So this table shows the basically the rates of MRD positivity over time, and you can see that the plus or pink color or orange color indicates the positive MRD that basically decreased over time. So there is only 1 patient who remained positive, as you can see, at 12 months, but all of the other patients were negative. This graph also showing the different basically presentation of the MRD. So you can see the plus sign indicates positive MRD by flow cytometry, and the negative sign indicates negative MRD by flow cytometry. Green equal concordance between flow cytometry and PCR. Red equals positive by next generation sequencing, by negative by flow. And the yellow equals positive by flow and negative by PCR. So you can see the green is the concordance. So the majority of cases had concordance rate between the flow cytometry and the next generation sequencing. However, there are a few cases that were discordant, mainly mainly the red color, which is positive by next generation sequencing as expected, because it's a deeper level of detection of MRD. And the yellow one was less as compared to the red. We can see progression-free survival, as shown here, the numbers from 3 months to 12 months, and the graph showing that the progression-free survival is maintained over time. The dose-limiting toxicity period was 42 days from the initiation of venetoclax. And in this phase 1 study, there was no dose-limiting toxicity noted in the study, and all patients were able to safely escalate to a 400 milligram dose. There was one patient who started on 20 milligram of venetoclax due to a high absolute lymphocyte count of 500, and with a dose-limiting toxicity period of 49 days. The side effects or adverse events that were reported in the study were as expected with the drugs used. So neutropenia was very common, 89% of all grade, and grade 3 was 37%, grade 4, 25%. So neutropenia was the most common noted side effect. After that, followed by thrombocytopenia, diarrhea, anemia, fatigue, etc. We can see that tumor lysis syndrome happened in 4 patients only, and it was of grade 3. So this is basically the same as we discussed. The most common was neutropenia, followed by thrombocytopenia and anemia. Of concern, 2 patients had secondary cancers in this study that only included 28 patients. So the sample size is small, and yet there were 2 patients developed secondary cancer. So this is alarming. One was adenocarcinoma, and the other one was cutaneous squamous cell carcinoma. So 4 deaths happened during the study, 2 related to lymphoma and 2 other causes. So in conclusion, the combination of R² plus venetoclax is safe. There was no dose limiting toxicity noted in this trial. Several dose reductions without treatment discontinuation related to treatment. 2 secondary cancers were noted in the study. So early preliminary data indicates that the regimen is effective in these patients with many of them had high risk features, including blastoid, pleomorphic, high MIPI score, and indicated a very high CR rate and a very high MRD as well. And the future plan to include expansion of this study to include patients with more high risk features like TP53, and plan to modify regimen to target this population and other high risk features population. So with this, I conclude, and this is what the investigators' acknowledgement was. Thank you very
much. We don't have questions submitted. I have one small question, and because we are behind time, what the rituximab which is used, is it subcutaneous or the infusion?
Rituximab?
Yes.
I believe it was IV, but I have to double check on the presentation.
For the audience, still you can submit your question through the Q&A session as icon, and probably the panel will be answering them later. We will not be having a break because already we are behind time, and we will move to the next session, session 4 of the conference. Thank you all, and see you inshallah for the next session. We'll invite the next panel to join. Thank you.
Thank you very much.
Everyone, thank you for staying with us tonight. We will go directly to the fourth session. My name is Dr. Musa Abdamlaj. I'm a consultant in hematology and stem cell transplant at King Abdulaziz Medical City. And with me, Dr. Ayman Hijazi, also consultant and section head at King Abdulaziz Medical City. We'll be moderating the fourth session this evening. We will have 4 excellent speakers and 5 presentations. Dr. Ayman will begin introducing the first speaker.
Thank you, Dr. Musab. Welcome, everybody. It's the last session, hopefully in an hour or so. Will be done by this meeting, and there is a satellite symposium after that. So the first speaker is Dr. Stefano Luminari. He was presented previously, but he's a professor of medical oncology at University of Modena and Reggio Emilia, and head of the unit for clinical research in oncohematology at Hematology Division, also Reggio Emilia in Italy. So his talk is going to be about peripheral T NK cell lymphoma. Dr. Luminari, screen is yours.
Thank you. Thank you again for the nice introduction. I hope you are able to see my screen and to hear my voice. So once again, thank you for inviting me to give you the second lecture today. There is about the updates from the ICML about peripheral T cell and NK lymphoma. I will try to cover the 6 oral presentations that were presented at this meeting. So just to start very quickly, the first study, I think, was one of the most interesting contribution in this session. It was a randomized study conducted by the Chinese group about comparison of 2 regimens for the treatment of early stage NK T cell lymphomas. Also favored by the good epidemiology of this disease in the eastern country, they worked a lot with this disease, and I think that probably they're the only group that is able to produce randomized data in this setting, so that's contributing in advancement in the management. So they started from analyzing what was available when the study was designed in terms of regimens. As you know, NK T cell lymphoma are not suitable for treatment with anthracycline-based therapy. They need asparaginase, and this agent should be added to a combined chemotherapy regimen. They basically looked at the MESA, that is methotrexate, desamethasone, etoposide, and asparaginase, and they identified an alternative regimen that is ESA. There is MESA without methotrexate, that compared to ESA is likely more effective based on retrospective data, less toxic, and is mostly oral with the only exception of asparaginase, and is more convenient for the patient and for the hospital. They compared in a randomized fashion. The design is shown here, 1-to-1 randomization of de novo stage 1-2 NK T cell lymphomas between the 2 regimens. Patient with at least a stable disease proceeded to the sandwich program of radiation therapy, and again were treated with the same regimen as induction, and then sent to follow-up. This was a non-inferiority design of a randomized study. 248 patients were enrolled and randomized. The clinical characteristics are shown here. The study arm were well balanced between the 2 regimens. And if you look at the primary outcome, was basically a complete response. You see that the primary endpoint was met with a 80% complete response rate achieved with ESA and 78.9% achieved with MESA. And the same applies all to the all other activity measures. And also, if you look at the secondary outcome, mainly progression-free survival and overall survival, again, no main difference between the 2 study arms. Conversely, the difference was it's there in terms of the safety profile. The safety profile of the ESA regimen was significantly better compared to the MESA, with significant reduction in terms of leukopenia, neutropenia, mucositis, and other hematologic and non-hematologic adverse events, suggesting that based on this study, ESA treatment should be now considered as the standard approach to early stage NK T-cell lymphomas. The second study is a study presented by Dr. Dreger from Germany, who consulted the prospective registry of the ABMT transplant and the CIBMRT to assess and to compare the groups of patients with peripheral T-cell lymphoma that receive an allogenic transplant compare and to try to define differences in terms of efficacy and toxicity of the different sources of the bone marrow, those comparing haploidentical versus matched donor groups. These are the results of this huge study. 1,942 patients enrolled, divided into this group: haploidentical, matched sibling, MUD with T-cell depletion and without T-cell depletion. The groups are clearly shown here, very well comparable. Patients who had received haploidentical allo transplant were probably more frail, as showed by the 42% of the ECO performance status higher than 1, and more frequently treated with bone marrow as a source of stem cell transplant. In terms of acute graft-versus-host disease, they observed that patients treated with haploidentical transplant were associated with a reduced risk of graft-versus-host disease in the first 100 days. In terms of non-relapse mortality, no significant difference was observed between the different groups of therapy. And also in terms of overall survival, no significant difference was observed in terms of PFS and OS among the 4 groups, suggesting, as the conclusion highlights, that haploidentical allogenic stem cell transplant should be considered as a good source, a good treatment for relapsed refractory patient, considering that allogenic stem cell transplant is probably the only curative option, even if not very active and not easy to perform in relapsed patients with peripheral T-cell lymphomas. The third study is a phase 1/2 study of DZT-4205, that is a selective JAK1 inhibitor tested in relapsed refractory peripheral T-cell lymphoma, presented by Dr. Kim. The rationale behind this study is the availability of DZT-4205 as an orally available potent second-generation JAK inhibitor with high selectivity, and that is rational to use in peripheral T-cell lymphoma due to the involvement of the JAK pathway, JAK-STAT pathway in the pathogenesis of the disease. This is the design of the study. I will not go too much into detail. It's a phase 1 study of a novel agent, and the activity shown by the study was in favor of some kind of activity, as documented by an overall 47.6 overall response rate, with complete response rates observed in different rates according to the peripheral T-cell subtypes, being higher than more active in patients with angioimmunoblastic T-cell lymphoma, with a complete response rate of 26.3%. And in terms of the safety, 23.4% of the patient experienced neutropenia. However, the safety profile was considered manageable without significant adverse events associated with the treatment. The third study is about lacutamab in patients with mycosis fungoides that was delivered according to the expression of KIR3DL2. That is a phase 2 study presented by Dr. Bagot. Lacutamab is an inhibitor of KIR3DL2 that is considered is a receptor that is shown to be expressed by approximately 50% of the patients with mycosis fungoides and with more than 90% of patients with Sézary syndrome. This study that was presented here was part of a larger study with different cohorts. The cohort with Sézary syndrome patient was already presented, confirming efficacy. At this meeting, cohort 2 and cohort 3 were presented, cohort 2 and cohort 3 being different because from the cohort 1 because they were mycosis fungoides, and the difference between cohort 2 and cohort 3 was mainly based on different rate of expression of KIR3DL2 in the tissue, more than 1% or less than 1%. These are the characteristics of the patients divided by cohort. Similar characteristics and no significant difference. These are patients with relapsed refractory disease and with a significant amount of disease as documented by nodal involvement, blood involvement in a significant number of patients, with probably more patients with the disseminated disease as observed in the cohort 2 with higher level of KIR3DL2 expression. Responses were observed in both groups. This is the group cohort 2 with higher expression of the receptor KIR3DL2. Looking at the skin response, the patient with skin involvement, most of the patients showed a reduction in the skin involvement, and one patient out of the 17 subjects achieved a complete response, 8 PR and 2 unconfirmed PR. Responses were also seen in 4 out of 7 patients with blood involvement and 1 out of 8 with lymph node involvement. And regarding cohort 3, less marked response were observed in this patient with only 2 PR observed among the 19 patients with the skin involvement. Safety details are shown here. Grade 3 and 4 events were not frequent, and most of the events were of grade 1 and 2, and mostly represented by asthenia and nausea. And in only one case, a grade 3 event caused discontinuation of treatment. The other study is multicenter phase 2 study, romidepsin plus lenalidomide. This is very interesting because this phase 2 study was applied to patients with previously untreated peripheral T-cell lymphoma, so the patient never received any treatment. This study was presented by Dr. Ruan. The agent investigated in this study was an HDAC inhibitor, romidepsin, with the IMiD that is lenalidomide. Both agents showed activity as single agent in relapsed refractory setting and in combination again in relapsed refractory setting. So the hypothesis was that this combination could be also effective in first-line therapy. This is the schema of the treatment that was adopted in these patients. Lenalidomide was given at standard 25 doses for 21 days. Every 28 days, romidepsin was administered on day 1, day 8, and day 15 of a 28 days cycle for up to 1 year. The patient enrolled were 29. 20 patients were shown with available and were available for the meeting. These are the characteristics. 13 patients had angioimmunoblastic T-cell lymphoma, 6 patients peripheral T-cell lymphoma NOS, 1 patient ATLL. LDH was elevated in 80% of the patients. So these are the typical patient with peripheral T-cell lymphoma. Looking at the adverse event, the combination was not very safe in terms of the number of events. If you look at the events grade higher than grade 3, you see a significant amount of neutropenia, 45%, thrombocytopenia, 38%, and anemia, 28%, and with 10% of infection and sepsis and other infectious events that are shown here in the left. Other non-hematological events were observed quite frequently. Hypertension, 38% of the patients, fatigue, 70%, and the complete list is shown here for the value that it can have for an overview of a small number of patients. In terms of objective responses, I think these are the very interesting data because remember, this is first line, patient never treated. Overall, 15 out of the 20 evaluable patients achieved a response that was complete in 30% of the subjects. And that was relatively higher for the patient with angioimmunoblastic T-cell lymphomas, 38% compared to PTCL NOS. A small number, but I think interesting studies, interesting data. And if you look at the progression-free survival, the median progression-free survival was reported to be 1.19 years for the old patient, 3-year PFS 36.2%, and it was 1.83 years in the patient with angioimmunoblastic T-cell lymphoma with the 2-year median, with the 2-year PFS rates of 39.6%. Then promising result that I think that suggests further investigation of this combination for the first-line therapy of the peripheral T-cell lymphoma patients. And the last contribution was presented by Dr. Ovitz from the Memorial Sloan Kettering, a combination of duvelisib and romidepsin, so a PI3 kinase inhibitor and an HDAC inhibitor in relapsed refractory peripheral T-cell lymphoma. The background is again in favor of this reporting the activity of the two drugs used as single agent in peripheral T-cell lymphomas and in the possibility to combine them in a phase 2 study and a phase 1 study. The design of the study is shown here. There are two arms, non-randomized. The arm A was duvelisib plus romidepsin, so PI3 kinase plus HDAC inhibitor. Arm B is duvelisib plus bortezomib, but the arm B was not shown here. And in the arm I there was also a group of patients that received single-agent duvelisib as lead-in cycle before starting the combination therapy. The primary point was to define as phase 1 the maximum tolerated dose, but secondary objectives also included the analysis of overall response rate and complete response rate. 66 patients were enrolled in arm A. The clinical characteristics are shown here. 62 years median age, 64% were male. 13 patients were previously treated with autologous, 10 patients allogenic transplant, and the different subtypes of the peripheral T-cell lymphoma included is shown here. 55% of the nodal lymphoma or a cutaneous lymphoma with nodal involvement, and 11 patients had the primary cutaneous T-cell lymphoma, mycosis fungoides, or Sézary syndrome. Looking at the results by dose level, 3 dose levels were tested with the romidepsin fixed dose 10 milligrams per square meter IV and duvelisib from 25 milligrams to 75 milligrams moving from dose level 1 to dose level 3. Overall, you see there were responses seen in all groups, even if the groups are small, 50% dose level 1, 66% dose level 2, and a more interesting 54% overall response rate and 37% overall response, complete response rate in those level 3 patients. And looking at response by peripheral T-cell lymphoma subtypes, the results are shown here. Overall, 58% of the peripheral T-cell lymphoma achieved an overall response and 48% complete response rate. And PTCL patients overall were associated with an overall response rate of 56%. That I think is very promising, considering how difficult it is to manage to get a response in a relapsed refractory peripheral T-cell lymphoma. And finally, progression-free survival curves are shown here for both PTCL and cutaneous T-cell lymphomas. The median PFS was 6.9 months in PTCL and 5.5 months in cutaneous T-cell lymphomas. And given the possibility to achieve a significant amount of complete responses in peripheral T-cell lymphoma, patients with achieving complete response were likely sent to transplant. This was feasible. It was done in 15 patients. There was approximately 1/3 of the patients. So in conclusion, the combination is considered active with the response rates that I described before, and the combination of the two agents is considered feasible with a manageable safety profile and with higher activity compared to the historical data of single-agent duvelisib. With this, I finished the overview of this contribution about peripheral T-cell lymphoma, and I'm happy to take questions if there are some from the chair or from the audience. Thank you very much.
Well, thank you very much, Dr. Luminari, for this elegant presentation and choosing the nice abstracts. I don't think if there is any questions, I cannot read them from here, but I have a question. It seems that the addition of romidopsin is interesting in treating T-cell lymphomas. The combination of romidopsin and lenalidomide is showing at least promising results in the abstract. I mean, do you think in the future would be an option rather than R-CHOEP or adding any of those agents, or comparing at least the results of R-CHOEP or CHOEP to romidopsin and lenalidomide? Is that something that you think will really be a replacement?
Yeah, it's not easy to drive conclusion based on a small study, but I think it's pivotal and it's very interesting to see that it is possible to achieve responses and good responses in first line with a chemo-free option. You should remember, however, that romidepsin, even if active in a single agent and also in combination, has been added to CHOP by the French group, and results were not positive in all comers, with some suggestion that a better activity was seen in angioimmunoblastic T-cell lymphoma. There are more dependent on the epigenetic alterations that the pathogenesis of the disease. So the answer to your question is difficult, but the answer is probably yes, at least we should try. But the best way to try is not to consider all comers for PTCL, but to work on specific subgroups. Now it's clear enough that there is a cell of origin also for peripheral T-cell lymphoma, and the best cell of origin for romidepsin is likely to be angioimmunoblastic T-cell lymphoma with the T follicular helper cell subtype.
Well, thank you very much, Dr. Luminari. I guess we'll go ahead with the next speaker. Thank you. Dr. Musab, the mic is yours.
Thank you, Dr. Ayman. So it is my pleasure to present the next speaker. It's Dr. Riyad Al-Faqih, who's a consultant in hematology and stem cell transplantation in King Faisal Specialist Hospital. He's also an associate professor and head of the research unit over there. Dr. Riyad will share with us two abstracts regarding the use of CAR T therapy in two different diseases, in follicular lymphoma as well as CLL. Dr. Faqih, you may begin.
Thank you much, Musab, and I would like to thank the organizers for inviting me. Can you see my slides?
Yes, we can.
Okay, so I was asked to talk about two abstracts addressing the use of CAR T-cell in two new diseases without FDA approval, the follicular lymphoma CAR T-cell trial and the CLL CAR T-cell trial. So we will go over the ELARA and the Transcend CLL trial. This is the first trial. This is the ELARA. And as you know, follicular lymphoma is an indolent disease, but about 20% of the patients will have disease recurrence within the first 2 years of treatment. And these patients don't do well, actually. And Tizacel, which is Kymriah, is an anti-CD19 CAR T-cell approved for ALL and diffuse large B-cell lymphoma, but doesn't have approval in follicular lymphoma. So this trial is studying this CAR T-cell product in follicular lymphoma, with a primary endpoint being the complete response rate. So here's the schema of the trial, screening of the patient, enrollment, then manufacturing, which takes like 2 to 3 weeks, lymphodepletion thereafter, and infusion of the cells. And bridging chemotherapy was allowed on this trial. Eligibility, patient has to be more than 18 years, all grades of follicular lymphoma except 3B, relapsed refractory disease, failing 2 lines of therapy, and no evidence of transformation. Of course, patients should have not received anti-CD19 therapy nor allogeneic transplant. And this is the lymphodepleting therapy, fluci, regular fluci. Bendamustine was also used in some patients. The dose of the CAR T cell ranged between 0.6 to 6 by 10 to power 8 total dose. This is not per kg. And again, the primary response, endpoint was complete response rate. Secondary endpoints, overall response duration, PFS, OS, safety, and cellular kinetics. So they started with 98 patients, 97 were infused, one was not based on his physician decision, and 97 were available for safety assessment. 94 were available for efficacy assessment after 6 months of follow-up. So the median follow-up for the infused patient was 10.6 months. Here you see the baseline characteristics, median age 57, which is expected in this disease. This is a disease of the elderly. Selected group, all the patients had good performance status. As you see, the majority were 0 and 1, a minority were 2. But the disease itself was pretty refractory and high risk. You see a good number had bulky disease, advanced stage, advanced FLIPI score. Median number of prior therapy was 4 and ranged between 2 and 13. And the patients with POD24 were around 60% of the total population. Refractory to more than 2 regimen, 76%. And here you can see the types of therapy received. The majority received chemo immunotherapy, and some received PI3 kinase and R2. This is the safety profile. Again, 97 patient, and the safety was available on all of them. Most of the patient got side effects, the usual side effects. Grade 3 to 4 adverse events were seen in 76%. Death was reported in 3 patients, and all of them were due to disease progression, not toxicity. Here you can see the CRS management. 34% of the patient had to receive tocilizumab to control the CRS, and 6.4% had corticosteroid. In regards to the neurologic adverse event, none of them were more than grade, one of them was grade 3, and all the others were grade 1 and 2. And here you see again the cytokine release syndrome. None of them was grade 3. Of course, infection and the other expected side effects were seen as expected with CAR T cell, like B-cell aplasia and neutropenia, cytopenia, and infections. But none of these were outside of the expected range. Again, concerning the specific side effects of CAR T cell, cytokine release syndrome, all of them were 2 and below, grade 2 and below, and neurologic side effects, one only was grade 3. Here you see the primary endpoint. The CR rate was 66%, the PR 20.2%, and the overall response rate, which is the primary endpoint, was 86.2%. And here you see the median duration of response after 11 months of median follow-up. The median duration of response was not met. Interestingly, 12 of the 31 PR seen on that trial converted to CR between month 3 and month 6. So some patients started with a PR, and later on the response was deep enough to reach CR. Per subgroup, the efficacy, as you see, all subgroups did benefit regardless of the age, sex, number of prior neoplastic lines, as you see here, less than 2, 3 to 4, and more than 4. The type of therapy and prior autologous transplant, disease status at the last therapy, like refractory or relapsed, and POD 24 patients. So all subgroups did benefit from this treatment. This is the PFS, as you see here. Both median PFS and OS after 11 months of follow-up were not reached, and the estimated 6-month PFS was 76%. So all in all, Tizacel demonstrated high rates of durable response with an overall response rate of 86% and a CR rate of 66%. This data suggests that CD19 CAR T-cell is effective in relapsed refractory follicular lymphoma patient. Concerning the side effect profile, no high-grade CRS was reported. As you saw, all the CRS were less than grade 3. In regards to the ICANS or neurotoxicity, 1%, only one patient had grade 3 toxicity. No mortalities were reported due to the treatment. 3 mortalities, 3 cases died, and all of them were due to progressive disease. So all in all, Tizacel is a safe, promising therapy in this type of patients. We move on to the second abstract, and this abstract is a phase 1 cohort trying the Lysocell combined with ibrutinib in patients with relapsed refractory chronic lymphocytic leukemia. So as you know, targeted therapy are now available for CLL. We have many options. All these options are effective, and with the BCL2 inhibitors, we are reaching minimal residual disease negativity. However, this disease, as you all know, keep relapsing even with these effective therapies. Now, regarding the ibrutinib, and mouse models, it showed that it improved the expansion of CD19 CAR T-cell therapy. When these cells are exposed to ibrutinib, the expansion is expected to be better. And concurrent ibrutinib therapy improved engraftment and the efficacy of these cells in mouse models. Recent studies, phase 1 and case reports have described that the addition of ibrutinib to CD19 CAR T-cell therapy improved the response rate and at the same time reduced the toxicity. The Lysocell is an anti-CD19 directed CAR T-cell therapy, and it is composed in a way where the CD4 and CD8 ratio of these T cells are equal. So this report is an updated report of this phase 1 trial, and after a median follow-up of 17 months of these infused patients. Here you see the schema of the trial. Enrollment, leukapheresis, production of the cells, and before starting lymphodepletion, the patients had to have measurable disease, so negative MRD were not allowed on this trial. Then flu-cy lymphodepletion was done, and the dose escalation trial, the dose escalation part was started. Then the dose level 2 was chosen for the dose expansion, and patients were followed up. Regarding the eligibility, so these patients had to have relapsed or refractory CLL. They had to fail 2 lines, and ibrutinib, as you know, this trial is combining these cells with ibrutinib. So all patients had to have failed ibrutinib. So it's either progressed on ibrutinib or received ibrutinib for more than 6 months and achieved less than CR, or they had resistant mutations to ibrutinib, and prior ibrutinib did not have contraindication in these patients so that they can receive it. The objectives, primary objectives, were the safety and to determine the recommended dose, and of course the other endpoints were anti-tumor activity and cellular kinetic profile. So here you see the patient's characteristics. Here you see for all patients. Then next you see the dose level 1 patients and the dose level 2 patients. 4 patients were dosed with the dose level 1, and then after determining the safety of this dose level, 19 patients were dosed with the dose level 2. So as you see, the median age is 61. This is a disease of elderly, and the majority were males. Median time since diagnosed was 120 months, around 10 years as expected in CLL. Some patients had bulky disease, and as you see here, in regards to staging, RISE stage 3 and 4 were around 43%. High risk features, as you see here, deletion 17p constituted 40%, and 35% had TP53 mutation, so pretty high risk population. Prior ibrutinib exposure, all of them again had to have exposure to ibrutinib, so that, and they had to fail ibrutinib or exposed for 6 months and did not achieve CR. So as you see, 100% of the patients received ibrutinib. Bridging therapy was allowed, and as you see, 40% of the patients were or received bridging therapy. So here you see the endpoints, the toxicity profile and the safety of this combination was the primary endpoint. And as you see here, neutropenia and cytopenia was seen as expected. However, the CAR T-cell specific toxicities like CRS and urologic side effects were not out of range. As you see here, all grade CRS was 78%, was seen in 78% of the patients. And you see that in dose level 1, all patients had CRS, however, 74% only in dose level. So it's unrelated to the dose level. Median onset of CRS was 7 days, and it lasted for 5.5 days. Now, the majority, 74% of these patients had CRS grade 1 to 2. Grade 3 CRS was only seen in 1 patient with the dose level 1 as well. So this data suggests that the higher dose level, which is dose level 2, did not correlate with a higher CRS incidence. In regards to the neurologic side effects, as you see, 7 patients or 30% in total had neurologic adverse events. 3 of them, so 13%, 3 of them, 13% were grade 1 to 2, and 4 of them were grade 3 toxicity. Most of the toxicity, the neurotoxicity, was seen actually in the dose level 2. And here you see the treatment received by these patients secondary to toxicity. 3 patients had to receive tocilizumab to control their disease. 3 had to receive corticosteroid, and 5 had to receive the combination. Again, here you see the safety profile regarding the ibrutinib, because this is a combination trial, as I said. And you see here that grade 3 to 4 ibrutinib-related effects was seen in 40% of the patients. And as you see, around 75% of the patient received more than 3 months of the combination. So basically, it was a tolerated combination, and dose interruption or dose stopping was not required. The median duration of ibrutinib exposure was 141 days. And the median duration of ibrutinib therapy after infusion was 97 days. So these are the ibrutinib side effects. You can see here, cytopenia, AFib was seen in 1 patient, lung infection in 1 patient, and infection in 1 patient. The side effect that required dose reduction were AFib and the grade 2 fatigue. Here we see the response rate, which was a secondary endpoint on this trial. And as you see here, the overall response rate was 95%. So 21 out of the 22 infused patients achieved CR/CRI. As you see, no PRs on this trial with the dose level 1 and dose level 2. And here you see the MRD data, as you see here. In blue is blood MRD, and in yellow is marrow MRD. So very high rate of MRD negativity, both in the blood and the marrow in patients who achieved CR. And again, 95% of the patients achieved CR. This is the response over time, as you see with the dose level 1 and then with the dose level 2. And most of the response are still ongoing. So all these responders, sorry for that, achieved the response by day 30 after infusion of the cells. And most of the patients who responded were still maintaining their response at around 6 months. 2 patients did progress due to Richter, and the patients who received dose level 2 will be followed for 48 months and reported later. Of note here, 1 patient on this trial died from complication of COVID-19. Here's the median duration of response not reached, and here's the median PFS also not reached after 17 months of follow-up on this trial. So these prelim data suggest that liso-cel combined with ibrutinib is well tolerated with low incidence of grade 3 CRS and neurologic adverse events, and no grade 4 or 5 CRS or neurologic events. No clear difference in the safety was observed between the dose levels, dose level 1 and dose level 2. And the dose level 2 was the chosen dose to expand the cohort and follow them. As you saw, heavily pretreated, refractory, high-risk CLL patient did respond, and the majority of them achieved undetectable MRD. Responses were durable. Still, the follow-up is short, but as far as we know, the response is durable. Some patients achieved PR, 4 of these infused patients, and later on, with follow-up, the cells expanded and they went to CR. All in all, it seems to be an effective and safe combination, and hopefully will open the door for more therapies for these patients who have multiple relapsed refractory CLL with a high-risk profile like mutation or deletion of P17. With that, I will finish and happy to take any questions.
Thank you, Dr. Riyad. Very nice overview. Can you please check if we have any questions from the chat box? Okay, so I actually have a comment and a question. In the first abstract that you shared with us on follicular lymphoma, We see that the responses are quite high in these heavily pretreated patients, and the curve and the PFS curve seems to plateau after a period of time. What I'm wondering is that, as you know, with follicular lymphoma, the story is a bit different than the LBCL, where you can still see delayed relapses. So the question is, do we think a subset of patients will be cured using CAR T therapy for follicular lymphoma? And if, of course, we don't know the answer, but I'm curious to hear your comments on this. And where do you think this treatment modality is going to fit with the different options that we have in these patients?
Sure. So regarding the curability of this approach, it's too early to tell, you know. And as you know, this disease tends to relapse, but some patients will have very long remissions. You know, we treat patients with chemo, and sometimes the response goes on and on for more than 10 years. So it's a very hard question. What I can say, this option is a new option for these patients who failed the available standard of care. And specifically, I would say it will fit patients who relapse within 24 months after the initiation of therapy, after frontline therapy. As you know, these patients have a bad outcome in general, and they tend to have resistance to the available options. And these constitute around 20% of the follicular lymphoma cases. Typically in the past, at least myself, I used to do allotransplant for these patients. Of course, autotransplant as a first modality, but then later on, because most of our patients are young in Saudi Arabia, most of these patients will end up evaluated or end up having allogeneic transplant. So this is where I see it helpful the most. And patients who respond for more than 24 months, you know, we don't have a lot of options like in CLL. We do have nice options available. However, a good number of patients, you know, will relapse between 2 and 5 years after therapy. And these patients in our community, they are young and they will need to go through several lines and eventually will need CAR T cell.
Excellent. Thank you, Dr. Riyad. I think we'll move on to the next presentation. So it's my pleasure to welcome Dr. Musa Zahrani, who's a consultant in hematology and BMT and assistant professor at King Saud University. Dr. Musa will talk to us about the role of assessing response to CAR T therapy using PET scan in large cell lymphoma. Please, you can begin, Dr. Musa.
Thank you very much again, Dr. Musab. Okay, so I'm going to be presenting this study, which is a retrospective study from a UK group on early PET response in patients with CAR T, diffuse large B-cell lymphoma patients. So as we know, about 80% of patients with relapsed refractory large B-cell lymphoma respond to CAR T therapy, but only half of the responders have long-term remissions. It is unclear how to discriminate between the transient versus long-term responders after CAR T, and at which point of insufficient response further therapy should be considered. And we know that PET scan is a very powerful tool to assess the depth of response in lymphoma patients and potentially guide the therapy in diffuse large B-cell lymphoma. So the aim and the methods of this study was to assess the PET scan based on a 5-score DeVille score at 1 month post-CAR T as a predictor of outcome. So this was a retrospective analysis of patients with relapsed refractory diffuse large B-cell lymphoma treated between February 2019 and December 2020 with the licensed products of CAR T across 2 UK centers. And who were available for response at 1 month and 3 months after follow-up. So this is the standard basically response criteria that was published by Chisson and JCO in 2014. As we know, so based on the DIVOL score, we have complete remission defined at the DIVOL score 1, 2, 3, and then partial response defined as DIVOL score 4 or 5. And 4 is moderately increased above the liver, and 5 is markedly increased uptake compared to the liver, but decreased from the baseline. For any new FDG avid lesions, it will be called progressive disease. For stable disease, it is DIVOL score 4 or 5, stable from baseline with no new lesions. So the patients were included in the study were 90 patients with 2 products. So the AxiCell, the Kite product, Yescarta, 79 patients. So the majority of patients were AxiCell, and Tisacell, the Novartis product, were 21 patients. So the median age was 57 years old. The ECOG performance status prior to the infusion was 0 to 1 in 13. 57 of patients, or 63%, were male. The majority were de novo diffuse large B-cell lymphoma, so 61% of patients. However, they also included transformed lymphoma, 32%, and primary mediastinal B-cell lymphoma, and 7%. Stage 3, 4 patients were 71%. So the majority were advanced stage. They also included double head, triple head lymphoma, as well as basically the dual expressor, 21%. The cell of origin were GCB type in the majority of patients. And about a third of patients had elevated LDH and bulky disease. And extranodal involvement, more than 2 sites were present in 57%. Again, showing basically high risk kind of patients in diffuse large B-cell lymphoma. And with this, so there were 2 PET scan, as mentioned before, done. One done at 1 month period and another one at 3 months period. So we can see that CR was found in 31 patients, and majority had a DIVOL score of 1 to 2, and 13 of them had the DIVOL score of 3. So out of the DIVOL score 1 to 18 patients, at 3 months, the majority remained in CR, so 78% of them. However, 22% of them had progressive disease. Out of those who were DIVOL score 3 at 1 month, 54% remained in CR and 46% progressed at 3 months. This is in comparison to the PR group, so 35 patients in this group. The DIVOL score was 4 or 5, as mentioned before. So in the 27 patients with DIVOL score of 4 at 1 month, so 33% of them remained in CR, and 33% of them progressed, and 33% of them remained in PR. The patient who had either stable disease, 2 patients, or progressive disease, 22 patients, all of them had progressive disease at 3 months. So looking at progression-free survival according to DIVOL score, we can see a very clear difference between DIVOL score 1, 2, as compared to higher DIVOL scores. And you can see the p-value is very significant. And you can see the very poor prognosis of patients who have DIVOL score of 5 as expected. So this is the overall survival, again, according to the DIVOL score. And you can see that the p-value is borderline. So there is a trend of showing worse overall survival in patients who had DIVOL score of 5. But it seems like the lines between DIVOL score 1, 2 and DIVOL score 3, 4 are overlapping. Probably there is no significant difference, a statistical difference between these two groups. So in the multivariate analysis of progression-free survival, they included DeVille score 1-2 versus 3-4 versus 5. They included ECOG performance status 0-1 versus 2, high LDH or normal LDH stage, limited stage versus advanced stage, extranodal involvement, yes or no, and bulky disease, yes or no. And in this multivariate analysis, the only variable that was significant was the differences in the DeVille score between 1-2 and the higher scores, and you can see the p-value was significant. All the other p-values were not significant. So in conclusion, early PET scan response using a DeVille score criteria may be useful to predict the risk of relapse post-CAR T therapy. And patients achieving a DeVille score 1 or 2 by 1 month show excellent long-term outcomes. Patients with DeVille score 3 or 4 might benefit from additional combination therapies or approaches, and they might be considered for clinical trials. And we saw clearly that DeVille score 5 at 1 month, these patients have very poor prognosis, and they should be regarded as treatment failure of CAR T. This is the acknowledgements of the investigators, and the study was conducted in King's College Hospital and Newcastle in London. Thank you very much.
Thank you, Dr. Musa. Very nice abstract. Can we please open the question box to check if we have anything from the audience? Okay. So one question that I have on my own, obviously the most important factor or implication, I guess, of using early PET scan is to try to predict the how these patients are going to do. And there's already some thought about consolidating some of those patients with an allogeneic transplant, especially given the high failure rate of CAR T. So as you know, about half, and in some series, probably more than half of patients will relapse after CAR T. So the question that I wonder is that in these patients that have a DeVille of 3 and above, is it worthwhile, for example, to see the persistence of the CAR Ts, to see if they may benefit from a second CAR T infusion, and I guess if they don't, maybe take them for allogeneic transplant upfront because the failure rate is going to be much higher?
Very good question. I think as we need more data to replicate the study finding, since this is a small retrospective study, but I think there is a clear signal from DeVille score 5, at least, that these patients are failing. And I agree they should be considered for additional therapy. For DeVille score 3 or 4, other strategies, as you mentioned, considering either additional therapies or autologous transplant or consolidation with other methods, I think it should be strongly considered in these patients.
Thank you, Dr. Musa. So we'll move on now to our last speaker. It is my pleasure to welcome Dr. Ahmed Saeed, who is a consultant and deputy chairman at Princess Noura Cancer Center and Ministry of National Guard, Western Region. He will talk to us about chronic lymphocytic leukemia, and the title of his talk is Delving Deep into CLL. Dr. Ahmed, welcome.
Assalamu alaikum. الصوت واضح؟
Yes, we hear you loud and clear.
I'd like to thank organizing committee for inviting me for this lecture. So today, I know this is the last talk of the day, so people maybe get tired by now, and I hope it will be quick and soft. So today, slide is clear. Okay, so this is my disclaimer and disclosures. I will talk about some updates on CLL, and during this talk there will be a few interactive questions. So please scan your camera against the barcode and start to answer the question. So the first question is, what are your top 3 factors influencing treatment choice and first-line setting? There are some more options. Okay, so we can move now. So I will start by giving some overview on the first-line clinical updates. As everyone knows that during the last decade, the treatment of CLL has been revolutionized by introducing the novel agents. And by now we have some enough long period to assess the long-term or the longer effect of these novel agents. Starting by ibrutinib monotherapy, after testing, after encouraging results of ibrutinib in relapse setting, it was tested in the naive patients, and in the RESONATE-2 studies, ibrutinib was tested against chlorambucil in patients with previously untreated CLL, elderly patients, so 269 patients. Primary analysis and the current follow-up showed an impressive results. Now with the 7 years follow-up, as you see, ibrutinib compared to chlorambucil showed a significant difference in progression-free survival, with a median progression-free survival not reached in the ibrutinib group compared to the 15 months in the chlorambucil group with a significant hazard ratio. This results encourage people to test ibrutinib either as a monotherapy or in combination with the anti-CD20 monoclonal antibodies in a different scenarios of CLL. So it was tested for young fit patients and for older patients who are not fit for FCR but fit for BR, and also for elderly unfit patients. So FCR was considered the standard of care for young and fit CLL patients for a long time. And the ECOG 1912 trial tested ibrutinib against FCR in a young fit patients with a median age of 58 years, 529 fit patients with no deletion, 17p- was included. And after 48 months median follow-up, there was significant difference in favor of ibrutinib and rituximab against FCR. So in this study, ibrutinib was combined with rituximab versus FCR. In alliance studies, ibrutinib was tested as a monotherapy or in addition to rituximab against bendamustine rituximab for elder patients who are age more than 65. And in this trial, 17p- was allowed to be included. And after median follow-up of 38 months, ibrutinib as a single agent or ibrutinib in addition to rituximab showed significant difference in compared to bendamustine rituximab in these group of patients. And finally, ibrutinib in ILLUMINATE trial also in a combination with obinutuzumab was tested against chlorambucil obinutuzumab in elderly patients who were unfit for chemoimmunotherapy, and the median age was 71 years and 17p- included. Again, ibrutinib in addition to obinutuzumab was significantly better than chlorambucil obinutuzumab in these patients. So there was clear evidence that ibrutinib against against chemoimmunotherapy in a different group of CL patient is showing effective and sustained response in CLL frontline. What about using other novel agents? So CLL14 tested venetoclax in combination with obinutuzumab against chlorambucil obinutuzumab in elderly patients with comorbidities. What is special about this trial, CLL trial, that is it is with fixed duration treatment where patients received only 12 months duration of treatment. So with a median observation of 52 months, and all patients were off treatment for 3 years or more, the median progression-free survival in venetoclax obinutuzumab not reached against 36 months, 0.4 in obinutuzumab chlorambucil, and 74% of patients on the interventional arm were free of progression at 4 years of treatment, compared to only 35% of patients on control arm. Again, in CLL trial, time to next treatment was clearly in favor of venetoclax obinutuzumab, where the risk of starting new treatment was reduced by 54%, and the 3 years post-treatment therapy, 81% of patients in venetoclax obinutuzumab did not require any treatment. The last novel agents in the front line is acalabrutinib, which is a second-generation BTKI. So it was tested in ELEVATE treatment-naive patients as a single agent or as in combination with obinutuzumab against obinutuzumab chlorambucil in CLL patient aged more than 65 years, or if the younger patients with comorbidities. And again, it showed the same thing, the median progression-free survival for acalabrutinib alone or in combination not reached against 27 months or 28 months for patients on obinutuzumab chlorambucil. And at 4 years, the progression-free survival was 87 and 78 for acalabrutinib arms against only 25% of patients on obinutuzumab chlorambucil. So all these clinical trials showed clear efficacy of the novel agents and sustained the efficacy of these novel agents against different chemoimmunotherapy protocols. And next question, what about the safety profile of these novel agents? So ibrutinib has a well-characterized safety profile in all clinical trials used ibrutinib, and it showed much less myelosuppression compared to chemoimmunotherapy, but it showed some characterized and specific adverse events like atrial fibrillations, hypertension, bleeding, and maybe a slight increase of risk of infection compared to chemoimmunotherapy. But generally, it was well tolerated and fair toxicity profile. Regarding the venetoclax, the safety profile, obinutuzumab was consistent with the non-safety profile venetoclax, and grade 3 and 4 toxicities in CLL14 were similar between the venetoclax arm and chemoimmunotherapy arm. Acalabrutinib also has a manageable toxicity profile, and one of interesting is that maybe the incidence of a specific adverse event seen in ibrutinib is maybe it's seen less with acalabrutinib being a more selective BTK, so we see less atrial fibrillation, less hypertension, and maybe less bleeding. So this is about it. Now moving to another important aspects, where historically it was known that the patients with deletion 17p- or TP53 mutation has the worst prognosis in CLL. So what is the impact of using these novel agents on this high-risk subgroup of CLL patients? So starting again by questions, interactive questions. So again, please scan your camera again at the barcode and answer this question. Which therapy would you select for frontline CLL 17p TP53 mutated patients? Please start. Okay, so we move. So in all the clinical trials, some of them they did not include 17p minus like Resonate study, but other studies did include 17p minus. Also, the number of 17p minus were small numbers. But if you see in these trials, CLL14 Alliance or Elevate treatment-naive patients, it's clearly that the novel agents as single agents or in combination showed a significant benefit for deletion for 17 abnormalities compared to chemoimmunotherapy. In CLL14 in Alliance, the median progression-free survival not reached compared to 7 months for patients on BR, and in Elevate TN, the progression-free survival for 17p minus were not reached compared to 17 months for this. So there is a clear, although the number is small, but there is clear benefit of using novel agents for treatment of patients with 17 deletion and P53 mutation. Now, if you compare the outcome in 17p minus to non-17p minus patients, you see comparable results when use novel agents or near to. So in CLL14, in 17p minus, 4 years progression-free survival was 53 compared to 74 for non-17p minus patients. And for Alliance patients, when you use ibrutinib for 17p and non-17p, there is a comparable results as well as when you use acalabrutinib. So currently, what is the treatment of choice for patients of 17p minus as a front line, answering the interactive questions? So if we go by two major bodies, NCCN and ISMO guidelines, so both of them, they put novel agents as preferred regimens for all patients with TP53 mutation or deletion 17p, with ibrutinib, acalabrutinib, VEN-O or VEN or idelalisib plus rituximab. The evidence is 3A because of low number of patients included in trials. One most important point is mentioned by NCCN is that chemoimmunotherapy is not recommended since deletion 17p TP53 is associated with lower response rate. Moving to another subgroup in CLL patients, what is the impact of IGHV status on frontline in patients treated with novel agents in frontline? As we know, the patients with unmutated IGHV status, they have a poor outcome. So we will start again with the interactive question. Which therapy would you select for frontline CLL unmutated IGHV? So please. So majority is Okay, so we'll move. So again, when we go for subgroup analysis for frontline trials, comparing novel agents with chemoimmunotherapy in regards of IGHV unmutated, it's clearly again in favor of novel agents. In CLL14, the median progression-free survival is 15.7 months compared to 26 months. And in Resonate 2 also median progression-free survival not reached compared to 9 months. And in Elevate in acalabrutinib trials, the median progression-free survival in acalabrutinib single agents or in combination with obinutuzumab not reached compared to 22 months, and again also in Alliance trial. So there is a clear benefit of novel agents in regards of IGHV unmutated patients. What about testing it for in regards of mutated and unmutated? Generally, we see that both of them, they have a comparable outcome whether the patient has unmutated or mutated IGHV status. Now, this slides ISMO guidelines in 2021 regarding the frontline treatment for CLL patients. So the most important factors you decide on is the presence or absence of TP53 and deletion of 17p, the mutational status, and the fitness of the patients. Generally, chemoimmunotherapy is not recommended except in exceptional cases, if there is a contraindication for novel agents or if it is not available, but otherwise you go for novel agents. Now moving to relapse refractory CLL clinical trial updates. So Murano trials is a trial tested for relapsed refractory CLL patients where patients were randomized between venetoclax rituximab against bendamustine rituximab, and the treatment duration was fixed for 24 months. And the initial results, primary analysis after 2 years, showed again significant difference between the two arms, with median progression-free survival not reached for the venetoclax arm compared to 17 months for bendamustine rituximab, and the 2 years progression-free survival was 85% compared to 36% for bendamustine rituximab. And after 5 years follow-up with longer follow-up, this effect is maintained with the sustained effect of venetoclax rituximab with a median progression-free survival of 53 months compared to 17 months and significant hazard ratio. What about patients with deletion 17p minus in this trial? Again, the same effect is maintained with a significant outcome favoring venetoclax rituximab compared to bendamustine rituximab. So the median progression free survival the 2 years progression-free survival was 81% for these patients on venetoclax rituximab compared to bendamustine rituximab of about 28%. And we see that there is a comparable also results in regard with their patients they have deletion 17p or no deletion 17p. Another trial for relapse refractory is a Resonate trials, and with which tested ibrutinib against ofatumumab And the primary analysis after follow-up of 9 months showed significant progression-free survival in favor of ibrutinib, with the median progression-free survival not reached in ibrutinib arm compared to 8 months in ofatumumab. And after 65 months follow-up, this effect is sustained with a median progression-free survival in ibrutinib arm of 44 months, and at 60 months, the estimated progression-free survival was 40%, while in ofatumumab, the median progression survival was 8 months, and at 60 months, the estimated progression-free survival was only 3%. And if you remember, in the Murano studies, with indirect comparison in Murano studies, the 5-year analysis, the median progression-free survival was 53 months for patients on venetoclax, and the estimated 5-year progression-free survival was 38%, with the patients is off treatment for 3 years. Another study is a SEND study, which compared acalabrutinib against idelalisib rituximab or bendamustine rituximab, and whether progression-free survival by IRC or investigator assist progression-free survival was clearly in favor of acalabrutinib, with a median progression-free survival not reached for acalabrutinib and around 16 months for control arm with a significant hazard ratio. And again, the 12 months progression-free survival in acalabrutinib was 88%. And if you remember, in Murano studies, after 2 years of treatment, the median progression-free survival was not reached, and the 2-year progression-free survival was 84%. And after 5 years, the median progression-free survival was 43.6 months with venetoclax versus 17 months with bendamustine rituximab. Regarding 17p minus in acalabrutinib study, again, it showed the same benefit like the previous results with acalabrutinib, either there is a deletion, 17p deletion, or no 17p deletion, the results are comparable. Moving to another aspect, which is the MRD negativity in CLL patients, and this is very interesting point, as mentioned earlier in the previous papers, because patients with MRD, with undetectable MRD, this could be a surrogate markers for better survival outcomes. So which therapy would you expect to see higher undetectable MRD results? Acalabrutinib, obinutuzumab, venetoclax, obinutuzumab, or ibrutinib? Please vote. Okay, so for the sake of time, so venetoclax obinutuzumab, it showed that MRD reduction in peripheral blood was 76% in venetoclax obinutuzumab in comparison to 35% in obinutuzumab chlorambucil. And if we checked in the bone marrow, it was 57% compared to 17%. So a higher and significant higher number of patients achieved MRD negativity in CLL14 frontline treatment. What about in the relapse setting? Again, with the venetoclax combination, the number of undetectable MRD was 62% in the peripheral blood compared to 13% for patients with bendamustine rituximab, and in the bone marrow, it was at the end of treatment was 16% compared to to one person. So venetoclax-based treatment really showed a significant number of undetectable MRD in these patients, both in the front line and in the relapse setting. While it's known that ibrutinib, either as a single agent or in combination, is associated with lower CR and very low rate of MRD negativity, as shown by most of in all of the trials, where undetectable MRD was very low in ibrutinib group in all the clinical trials. Acalabrutinib also, as a single agent or in combination, was associated with also a lower rate of undetectable MRD negativity. So the best combination is the venetoclax based treatment in regards of having a higher rate of undetectable MRD. Another aspect or another very interesting point is the continuous versus fixed treatment therapy. Ibrutinib trials and the acalabrutinib trials is based on continuous treatment, while some trials of venetoclax-based treatment in frontline was 1 year, in CLL14 was 12 months duration, and in Morano study was a 24 months duration. And this is having interesting to the regarding many aspects in regards of convenience for the patients, regarding the cost, and in addition also it has other important. But let's go by voting on this last question. So do you prefer fixed treatment duration over continuous therapy? Okay, so there is no one answering no. That's good. So one important thing is the development of mutation, and this is seen clearly in a continuous treatment with ibrutinib, whether in the front line or in the setting of relapse refractory. And again, also it is seen in more, especially in more in patients who is having deletion 17p or TP53, where presence of deletion 17p and TP53 increase the risk of PTK mutation, whether in the first line or second line. Another, while in venetoclax or PCL2 inhibitors venetoclax study, there was no acquired mutation in PCL2 family genes when venetoclax is used in combination with obinutuzumab. Regarding the common adverse events, as we see in ibrutinib trials, we continue to see the adverse events of clinical interest over time. And as you see, like hypertension, still you see it after 6 to 7 years. You do see still you see the these adverse events, atrial fibrillations and other. So continuous treatment is still associated with adverse events, and about 23% of patients, they have either dose reduction or discontinuation of ibrutinib because of toxicity. While in venetoclax-based treatment, last slide.
You are wrapping up.
Last slide. So in venetoclax study, we do see the adverse event mostly during the combination treatment, and it's getting less after combination. And post end of treatment, we rarely see any adverse events, and this is a clear advantage of fixed duration treatment. And with this, I come to the end of my talk. I'm sorry if I did take a longer time. And again, thank you, Dr. Ayman and Dr. Musab and organizing committee.
Thank you very much, Dr. Ahmed. That was a very nice presentation, diving deep in CLL. It seems that we don't have questions posted by the audience. I do have too many questions in CLL, but maybe there is no time to answer all these questions. Maybe just one thing regarding chemoimmunotherapy, Ahmed. Let's look at the unmutated group of patients in the frontline setting. Is there still any role of chemoimmunotherapy, do you think, in that group, the unmutated, young and fit patients who are not 17p deleted?
Or regarding the guidelines, I would like to double check with you. You mean the unmutated or the mutated?
The unmutated group.
So the mutated
frontline.
I think the mutated answer maybe is more clearly in favor of the novel agents. But there was a question about the mutated group where FCR in these patients, young fit patients with a mutated group, the 8 years progression-free survival was about 60% and CLL8 with a possible cure in this patient. So the question comes for this group of patients, would you still use chemoimmunotherapy or you go for novel agents? And still, I think novel agents, especially if you go for a fixed duration based novel agents, maybe this is the right choice for them.
All right, thank you, Dr. Ahmed. And I guess with this, we conclude the satellite symposium of AbbVie. Thank you very much. And we come to the end of the day today. And now, on behalf of Saudi Society of Blood and Marrow Transplant, I would like to sincerely thank all speakers throughout the day. And I appreciate really the presence of a huge number of the audience since 2 p.m. today. Is just a reminder for tomorrow, please. The program tomorrow will start at 2 p.m. for the hematopathology overview meeting tomorrow. So please be there. And thank you very much for everybody. And good night. Goodbye for now. Thank you.
Thank you, Ayman.